Public health section headcount was 202 less than their fiscal 2026 budgeted headcount. In the FY27 preliminary budget hearing, we raised concerns regarding disease prevention and treatment, chronic disease prevention, health equity, and immunization programs. We were pleased to see that many of these priorities were reflected in the executive plan. At the same time, this budget hearing comes at a period of significant uncertainty for public health agencies across the country. Federal funding that supported critical disease surveillance, laboratory capacity, and emergency preparedness efforts is beginning to expire, while public health departments are simultaneously being asked to respond to emerging infectious diseases, rising chronic disease burdens, and increasing healthcare access challenges. That is why I'm encouraged to see investments in disease outbreak resilience, tuberculosis prevention, and childhood asthma initiatives, and healthcare access programs. However, it is also important that these investments are supported by a workforce that can successfully implement them. With the agency still operating below budgeted headcount and at the same time eliminating long-term vacant positions, we must ensure that staffing capacity keeps pace with the growing responsibilities being assigned to the department. I look forward to hearing from the Commissioner today about how the department plans to sustain critical public health services, address federal funding uncertainty, advance healthy NYC goals, and continues protecting the health of all New Yorkers in the years ahead. And now I want to turn it over to my co-chair for this hearing, Chair Schulman, for her opening statement.
Thank you. Good morning, everyone. I am Councilmember Lynn Schulman, Chair of the New York City Council's Committee on Health. Thank you all for joining us at the fiscal 2027 executive budget hearing for the Department of Health and Mental Hygiene. I want to thank our Finance Chair, Linda Lee, for co-chairing this hearing, and I also want to thank Speaker Julie Menon for attending as well. I would also like to thank the Commissioner, Dr. Alistair Martin, his staff, and everyone who is with us today. DOHMH's fiscal 2027 executive budget totals $2.64 billion, which represents approximately 2.1% of the city's budget. Funding for public health services totals $1.6 billion, a net increase of $116.6 million compared to last year's adopted budget. Of this amount, $526 million is for personal services and $1.1 billion for other than personal services. Today's hearing comes at a critical moment for public health in New York City. While our city has made meaningful progress in improving health outcomes and strengthening disease prevention efforts, we continue to face serious challenges that require sustained investment, thoughtful planning, and strong public trust in our health institutions. This hearing will examine how the department's fiscal 2027 executive budget aligns with the city's broader public health goals, including the Healthy NYC initiative to increase life expectancy, which the council codified into law. Healthy NYC established ambitious targets to address the longstanding inequities that continue to shape health outcomes across our communities. These goals cannot exist solely as aspirational benchmarks. They must be reflected both in spirit and in funding decisions throughout this budget. At the same time, the city is preparing for the impacts of significant federal healthcare policy changes. Approximately 233,000 New York City residents are expected to lose health insurance coverage due to upcoming essential plan eligibility changes taking effect on July 1st. These Medicaid-related disruptions could increase the number of uninsured New Yorkers and interrupt continuity of care. We will discuss how the department plans to respond through the new Health and Affordability Corps to support vulnerable communities during this transition. We will also examine investments in programs that directly address food insecurity, environmental health, infectious and chronic disease prevention, sexual health services, public health emergencies, and childhood asthma. Apart from responding to crises, public health is also about preventing illness before it occurs and ensuring that all New Yorkers have equitable access to the resources they need to live healthy lives. This hearing will also focus on the city's response to Legionnaire's disease following recent outbreaks and the implementation of strengthened cooling tower regulations, which I championed last year. The 2025 Central Harlem Legionnaire's disease cluster emphasized the devastating consequences of delayed detection and insufficient prevention measures. As warmer temperatures increase the risk of Legionella growth, it is essential that the city fully supports inspection, capacity, outbreak response, environmental monitoring, and community engagement efforts to protect public health. We will also discuss investments in tuberculosis prevention through Stop TB NYC, the city's ongoing Mpox response, and the growing importance of combating health misinformation through effective public health communications. Additionally, we will examine the department's role in animal welfare, zoonotic disease preparedness, and pest mitigation efforts as emerging public health threats continue to evolve. Before we would begin, I would like to thank the finance staff, Valeria Lazaro Rodriguez, Florentine Cabor, and Isha Wright for their work on this hearing, and committee staff Chris Pepe, Elizabeth Arzt, and Joshua Newman for their support. Finally, I would also like to thank my staff, Jonathan Boucher, Kevin McAleer, and Sammy New. With that, I will now pass it to Chair Lee.
Great, thank you. So before we get into swearing in, just wanted to make some quick announcements. So we're having our public testimony hearing all day. So instead of doing it on multiple days, we're doing it on one day, on Wednesday, June 10th, next week at 9:30 a.m. So if you're here from the public and want to sign up to testify, please do so. It should be a long, fun day. So we will make sure to get through all the testimony and hear from everyone. So please, again, June 10th, 9:30 a.m., please sign up. Okay, without further ado, I want to introduce our amazing committee counsel, Brian Sarfo, to swear in our witnesses.
Good morning. Do you affirm to tell the truth, the whole truth, and nothing but the truth before this committee and to respond honestly to council member questions? Commissioner Dr. Alistair Martin
Yes.
and Deputy Commissioner Anderson.
Yes.
You may begin.
Fantastic. Thank you very much, Chair Schulman. Thank you, Chair Lee. Thank you, Chair Gabon, and thank you, Madam Speaker, and to all of the council members who've joined us today. My name is Dr. Alistair Martin, Commissioner of Health at the New York City Health Department, and I'm joined today by our Chief Financial Officer, Aaron Anderson, and members of my senior leadership team. Thank you for the opportunity to testify today on our executive budget as it relates to public health. In the midst of this year's budget season, City Hall released a study that found 62% of New Yorkers cannot meet their basic needs. That's 5 million people, most of whom are missed by federal poverty measures. This budget season, the Mamdani administration is putting forward a blueprint for how to care for our city and lift some of the financial weight from New Yorkers' shoulders. We can't talk about affordability without talking about health. We're facing devastating cuts to public health and health care at the federal level, and we're bracing for the impacts of H.R. 1. Millions of New Yorkers who rely on Medicaid will soon become vulnerable to losing their coverage. That impacts nearly half of our city. We have both a responsibility and an opportunity to intervene. Our mission for the Health Department is centered around 3 main priorities. The first is to solidify the foundation of our core public and mental health work. As we face an increasingly hostile federal environment, we are dedicated to ensuring our core local services are operating efficiently. The second is to make clear that public health is an affordability issue. Key components of this work include enrolling New Yorkers in Medicaid and keeping them covered, especially the hundreds of thousands of residents at risk under new federal work requirements, connecting families to cash assistance benefit programs like SNAP, WIC, EITC, and other benefits they've already earned but haven't claimed, eliminating medical debt both by erasing it once it accrues and preventing it before it accumulates, and screening for housing instability at health visits and linking patients to eviction prevention services. The third priority is to make public health's invisible shield visible, because that metaphor does us a disservice. If something is hidden, it's easy to take for granted. We cannot afford to be taken for granted, especially not right now. We are building a healthier, more affordable New York City every single day. In the past 3 months alone, we've made extraordinary commitments to deliver for New Yorkers. That includes a $20 million investment in perinatal and early childhood mental health services, as well as expansion of our Nurse-Family Partnership Program, a program in which my own mother was a nurse, as a Nurse-Family Partnership nurse. Another $20 million towards community-based asthma programming in the Bronx. A $12 million investment in the peer workforce at substance use recovery programs across New York City. And a Board of Health resolution condemning federal tax on public health insurance and resolving to fight back. Each of these is both an accomplishment and also a promise of more to come. I'm proud to share them with you today. Most recently, the Board of Health unanimously approved a resolution responding to looming cuts to Medicaid and changes to public health insurance options more broadly. That resolution also calls on New York City and state government to mitigate the harms of federal actions and educate the public about their options. That very same day, we launched a $500,000 campaign advertising our free services that help New Yorkers enroll in low and no-cost health insurance. That campaign runs through the end of this month on social media, in newspapers, on Link NYC kiosks. It's translated into 13 different languages. The ads point New Yorkers directly to our health insurance enrollment team. These services are free of charge and available regardless of someone's immigration status or ability to pay. Our enrollment counselors offer guidance on coverage options and help navigating government bureaucracy. They help meet the needs of the whole person by recommending other benefit applications, including SNAP. They will also enroll people in NYC Care if that's their only healthcare option. These are critical services that that connect New Yorkers to programs that most of our city relies on. Right now, more than 5 million New Yorkers are enrolled in low or no-cost insurance plans, including Medicaid and the Essential Plan. Medicaid work requirements will go into effect at the end of this year, January 2027, and additional changes like frequent eligibility redeterminations will make it harder for people to stay covered. Upcoming federal changes that impact the Essential Plan are projected to cause an estimated 230,000 New York City residents to lose their coverage as well. At the Health Department, we are determined to intervene and keep as many New Yorkers insured as possible. I've heard some of the conversations unfold around how do we keep people enrolled in these insurance benefit options, and it's those moments that crystallize the impact of our work. We are meeting people where they are and helping them navigate some of the most consequential moments of their lives, and we're doing it by the thousands. Our direct one-on-one services reach more than 10,000 pregnant or parenting New Yorkers every single year. The Citywide Doula Initiative serves roughly 1,000 people each year. We've reached more than 3,900 people since the program launched in 2022, and there have been 0 pregnancy-related deaths among participants. Behind the numbers are New Yorkers like Masada, a doula I joined to visit a young woman who left an abusive partnership during her second pregnancy. She welcomed her son into this world in January with Masada by her side. Our Nurse Family Partnership Program serves more than 2,000 people every year, and that number will go up thanks to a $20 million investment in the Strong Foundations Initiative. I learned of that program's impact by watching my mom, who served as an NFP nurse for nearly 15 years. It's her example of public service I seek to emulate at this agency. Our newborn home visiting program serves more than 7,000 families every year. We dispatch community health workers to support families through the early days of parenthood. People like Wanda, who recounted what it felt like to hold a client's hand the day they came home from the NICU. In the richest city in the richest country in the world, no family should lose a loved one to pregnancy-related causes. All of these programs are built on trust. All of them are free of charge. And all of them are making pregnancy and parenthood safer and more supported in New York City. At the Health Department, we are committed to driving our resources according to need, no matter the subject area. This spring, City Hall announced a $20 million investment to improve childhood asthma outcomes in the Bronx. About half of that money will go towards community-based programming, and the other half will support asthma case management resources in schools. That investment would not be possible without the MTA. It's part of a larger $100 million commitment to New York City government. The money was generated by congestion pricing revenue and will go towards mitigation projects in environmental justice communities, including our asthma work. Every day, we are building on a legacy of more than 220 years in public health. We are positioned to meet and anticipate the needs of community members, and we will continue to do so. I'm encouraged to see increased support for our community health programming in the city's executive budget, and that includes a $3 million investment to establish the Health and Affordability Corps. That funding will support 46 employees dedicated to working with New Yorkers across our city to facilitate access to benefits, health insurance enrollment, and referral to low and no-cost services. We're grateful for a $12 million investment in our mobile food vending program, and I'm also reassured by the dedication of $10 million to continue Groceries to Go, which provides food insecure New Yorkers enrolled in Health and Hospitals NYC Care program with monthly credits to purchase groceries. At the state level, the fiscal year 2027 budget provides crucial support for public health. I'm very grateful to Governor Kathy Hochul and the New York State Legislature for restoring Article 6 matching funds of 36% to New York City. This reverses several years of cuts where New York City was the only jurisdiction in the state receiving a lower state reimbursement for core public health services. Thank you to Speaker Menon, to Chair Schulman, and the entire council for their continued advocacy on this issue. I'm also pleased to see a permanent carve-out of school-based health centers from Medicaid managed care in this year's budget. Our school-based health centers provide free primary care, including mental health and dental services, to approximately 143,000 New York City students. We're grateful to see these services supported in the state budget, and I appreciate this council's advocacy on that issue. Lastly, let me speak to the federal budget. About 20% of our budget is federally funded. That amounts to approximately $500 million. As mentioned, the majority of that funding goes towards emergency preparedness and infectious disease control. While we expect the federal government to honor its commitment and maintain that funding, the reality is we cannot rely on Washington, D.C. The writing is on the wall for the year ahead. This will be a uniquely challenging one for public health. But in New York City, I'm approaching that year with a whole lot of hope. I believe in the leadership we have across city government, including this council. I believe in the 7,000 people who carry out our work at the health department every day. And I believe in our city. If there's anyone that can turn tribulation into transformation, it is here. Thank you for your attention. We're happy to take questions.
Thank you. I appreciate the citations in your in your opening statement. Very awesome. Okay, so I'm going to ask a few questions, and when the speaker comes back, I'll turn it over to her. So really quickly for the executive plan, what was the process for your chief savings officer to conduct the required review of spending and operations within the 45-day timeframe, and what are the top line items that were identified and submitted to OMB?
Yeah, first of all, let me just start by saying, we are in a very good position with this executive budget, thanks to the work of OMB, this administration, but also thanks to your support in this council. You put us in a good position to execute with regard to all of the services that we need to keep people safe in this city. With regard to the chief savings officer role, we were managing two very specific things and trying to make sure that we were doing both complying with and aligning with the mayor's vision on EO 12, and at the same time finding places with savings that did not affect core services.
Exactly.
And we were able to do that throughout the entire budget, and I'll let Aaron talk a little bit more about the specifics there.
Yeah, thanks, Commissioner, and thanks for the question, Chair Lee. Right, these savings exercises are never easy, they're never fun,
Yep.
but I think we were absolutely able to meet both the mission and the charge of the administration to find savings while also minimizing or actually not having any impact at all on New Yorkers' lives. So in sum, the savings items that touch the public health side of the budget are Legionella. So this is just a reestimate for the current year only for spending based on less spending than expected. So that's a simple one. Zadroga reestimate. This is the World Trade Center Health Program. This is really a program run by the federal government. The city pays 10%. So we were able to identify savings in the current year to the extent that the feds spend less, the city's obligated to spend less. So that was sort of an easy one to recognize as well. Early intervention reevaluation, we took a identified savings of $500,000 in FY27 in the out years. That one's really about eliminating unnecessary evaluation procedures and aligning our practices with a recent state regulation.
Okay.
Yeah. And we found some space savings. We have a large real estate footprint across the city, so we're always thinking about ways to consolidate and think about best ways to use space efficiently. So I think we've made some progress there. So I think all of those taken together on the health side are really an example of finding savings without having any impact on services, and certainly nothing that would be reflected.
Right, and we definitely were very clear about that on the council side too, that we don't want services to get cut or anything to be sacrificed on that end. So I'm glad to hear that you were able to do that without. And then any consulting contracts, outside contracts that were reevaluated, or IT, because I know that a bunch of different agencies have been looking at those costs as well, more on the OTPS side.
Yeah, I mean, as part of the 45-day process, we certainly looked exhaustively. Consultants are a natural place to look. IT is
Right.
a natural place to look. You know, over the past 2 or 3 years of the prior administration, we had rounds and rounds of pegs and budget cuts, and I think we did a lot of work on that front there, so there wasn't much left to do.
Okay.
But we're always looking at those areas for potential efficiencies.
Okay, thank you. And then in terms of vacancy reductions, FY27 executive plan includes baseline savings of 6.1 million in city and state funding between FY26 through the elimination of 76 long-term vacant positions across DOHMH. So just again, to clarify, these are positions that were never filled, sorry. And so which program areas are impacted by the elimination of the 76 vacant positions? Were they across multiple programs or?
Yeah, thanks for the question. So, right, I think that the top line here is certainly that, yeah, this did not target current staff. This was
Right.
all, not only vacancies, but long-term vacancies.
Right.
So we've had challenges filling for years. It's really spread across the agency. The same approach we took to the savings initiatives, we took to the vacancy. Again, not easy, but, you know, looked for the things that were the hardest to fill, the longest vacant, and of course, the overriding principle was no impact to the public or to services. So, yeah, to answer that, it's really spread across the agency. There's not a single area where they're concentrated.
Okay.
We were able
how-
to meet the target.
What was the average length that the positions had remained vacant prior to being removed? And then also what other factors contributed to the department's inability to fill the positions originally?
Yeah, I mean, there's no single answer. I mean, as you know, our agency does so many different things. So the
Yes.
hiring issues that are in environmental health are very different than the hiring issues in the school health, and so it's just not really a one-size-fits-all answer. But in general, I mean, we're looking at positions that were vacant for upwards of 2 years.
Got it, okay. 2 years or more. Okay, and although the administration states that there will be no programmatic impact, how will responsibilities previously associated with the positions be absorbed or redistributed? And how would that look like, considering that the positions were never filled?
Yeah, I mean, it's a good question. It's a natural question. I think we're doing our best to absorb as we have. I mean, we have, as a city, every agency's had a lot of experience with us over the past few years. This vacancy reduction was not nearly as painful, at least, as the one several years ago. So I think we have some experience in how to absorb those, especially, and it's always easier to absorb and redirect that work when it's not sort of public-facing.
And
Direct
also not
services
currently,
type
there's
positions.
a current staff member there, so it's.
Exactly.
Right, and I know the answer to the next question, but just for the record. So I'm assuming that among the eliminated positions, were any of them connected to public health emergency preparedness, data modernization, health equity initiatives, or federally funded programs?
Generally, no. I mean, I think we certainly made every effort to focus on things that were more back office functions, if we have to group them together, things like data analyst or program specialist or office support.
Okay. So in terms of recruitment and retention, what are some of the strategies that you're implementing to improve some of the more harder to fill positions around public health programming?
I'll tell you, just right off the bat, Chair, this is one of the things that's top priority for me and is something that is top of mind. We're applying every single tool we can to make sure we get the right people in this building. We are hiring, so if council has folks that are individuals that we should be looking at, we'd love to see resumes and get people in the door. We're pushing on all fronts, on social media, on comms, and also doing the work that we can do in communities to recruit people as well. So this is a top priority of making sure we get the right people, and then we also keep them here.
Great. And then have you been partnering with other provider organizations as well as maybe, you know, the city's own programs, either through CUNY or workforce development type programs? Have you been plugging into those?
Yeah, actually, we recently just met with Commissioner Kenny Minaya and began doing some of our strategic planning around how we might collaborate with their really incredible Workforce One centers.
Yes.
They have a Workforce One Healthcare Career Center, and I think there's a ton that we can do there. You know, we are not going to recreate the wheel in terms of resume writing and job searching. But I do think that we have a role to play in helping to attract candidates and then, working with Workforce One to get them ready for hiring.
Okay, and then I'm assuming the positions you have open could be for multiple different types of degrees, right? So, I
Absolutely.
mean in terms of levels of degrees.
Absolutely.
Okay.
They span from roles that, don't require a college degree to some of the roles that we'll talk about today, which are highly specialized medical economist roles. So the bottom line is we are hiring and we're looking for candidates.
Great. And then just really quickly, going into some of your conversations with OMB. So how have your conversations actually been going in terms of things that maybe didn't get put in the executive plan that perhaps can be added before the adoption of the budget? Are there any resources that you're looking at in addition to what was added into the executive plan?
Yeah, I can say a few words and then pass it over to Aaron. At this time that we're in now, we have what we need to be able to carry out both the core public health and mental health services that New Yorkers count on us to deliver. But we will continue working with OMB, and we're going to continue our conversations with you all at City Council to figure out how do we push even more and continue to deliver the services that New Yorkers rely on. I'll pass it to Aaron, see if he has anything else to add here.
Yeah, I think that sums it up well. I mean, I'm in almost daily conversation with OMB, so they're very well aware of our needs and our evolving considerations as an agency. So yeah, we're in.
Okay, perfect. Can we add to your list actually? Because I know that there's some things I would love for you guys to take more funding on, especially related to the mental health or health programs. So just wondering. I'm sure Chair Caban would agree with that, right? So if you need, there's no shortage of things that we have on our end of things we would love to see in the budget, but we would love to work with you and OMB on that as well.
We'll have our pens ready to write the list down.
Okay, great. So it seems like most of the requests you submitted were approved. What funding or policy priorities did DOHMH advocate for during the state budget process, and were those, do you have any confirmation? I know the state budget is winding down, finalized, but if you could speak a little bit to that in terms of your state priorities.
Well, I'll just say the one that's really important, and just to say thank you to this council, to Chair Schulman, to you as well, Chair Lee, for helping to fight for Article 6 restoration. Is a big deal. That is tens of millions, if not hundreds of millions of dollars that we were being blocked from receiving because of the disparity in terms of our match rate. So thank you for that advocacy and for the commitment to that. So I'm going to hand it to Aaron to see if there's any other pieces that he'd like to lift up.
Yeah, I mean, not much else to add, just that Article 6 restoration is a huge deal for the city and a huge deal for this agency.
Okay, so I think the state budget agreement reportedly includes, I believe, $706 million for hospitals, $480 million for nursing homes, $20 million for assisted living programs, and $80 million for federally qualified health centers, FQHCs. And how will recent state healthcare investments impact New York City's public health system?
Well, I'll tell you another piece that is related to what you've mentioned that we're really excited about is the carve-out that school-based health centers got. For many of the students that are involved in getting care from school-based health centers, they don't have another primary care doctor or another place to go to get care. And so being able to co-locate those services in the school is incredibly important. Now, the challenge has been that these school-based health centers were facing the prospect of having to do a bunch of administrative work and billing and documentation and things that would have made it more challenging for them to receive funding for the work had they not been carved out and had to enter managed care contracts. So that carve-out is a huge benefit to the city in terms of buttressing our public health.
And then in terms of the school-based health centers, are there additional resources, capital needs, things that are needed of that sort that's in the budget as well that is, I guess, a new need? Are there new community health centers that are going to be put online, or the school-based health centers?
For school-based health centers, yeah. So let me say a few words there, and then I'll hand it to Aaron to talk budget. So our school-based health center program helps to serve about 140,000 students across the city. That's throughout 139 school-based health centers. And so, again, this is no-cost primary care for students. And it's something that I think, given the place where we're heading and where we are now with the federal environment that we're in, you know, when a family is concerned about going to a hospital or a primary care clinic, knowing that their school can offer the services that that child might get somewhere else, and also not ask questions about immigration status, and you know, I think that this is going to serve an even more important role moving forward. And so, you know, we're really excited to lean in to the school-based health center program. Let me hand it over to Aaron to talk about the budget.
Sure, yeah. So just to underscore the city's commitment to school-based health centers, you know, it's about $9 million a year, supports 34 sites of the 139 across the city. The only thing I would add is just to underscore the importance of the carve-out. I mean, I think that itself will go a long way towards stabilizing the resources for the many sites that the city does not support. So I think that goes a long way. I think there's certainly a larger question about what the right number is, but we're certainly happy to be a part of those conversations.
Okay. And do you look at zip codes, areas where there's chronic disease, more prevalence, to figure out where to place them?
Yeah, so we are working with partners across the city and across city agencies to make sure that we identify the right places for these school-based health centers.
Okay.
And so that, you know, data is always a part of the conversation when it comes to deploying these resources.
Okay. And just really quickly, going back to your testimony, because I know that you were talking about connecting families to SNAP, WIC, EITC, enrolling New Yorkers in Medicaid, keeping them covered. Yesterday, we just had a long hearing with HRA, and so just wondering if you could speak a little bit about what the conversations are or collaboration partnership with HRA in that, and then I had a second part to that question once you answer.
Yeah, no, we love our colleagues and our co-agency partners at DSS. I meet regularly with Commissioner Aaron Dalton. We have an interagency task force on this very issue.
Okay.
That brings together some of the senior leaders in our agency and in their agency, and we are working this problem together. We're trying to identify what are the ways that we can leverage the place-based nature of our work. You know, we see hundreds of thousands of people in our clinics, in our vital records shop, in our neighborhood action centers. So the question becomes, while people are in those facilities and they're waiting, can't we do more? Can't we enroll them in some of these programs? And so we're trying to work on that at the health department to step up and to really lean in there. And we're grateful to have DSS there to have our back as we develop this new muscle.
Okay. And then in terms of related to what's happening with HR 1 and the potential loss of families with access to benefits, because one of the big issues I know that we're facing is around the resource navigators and folks that are able to help people to enroll. So just wondering if any of your DOHMH contracts incorporate any of those positions that may also need more support.
Yeah. This is a key priority for us. You know, I think it's not just about pushing people to a website or giving them a handout or a pamphlet or a poster. Like, we have to sit with people shoulder to shoulder and help them through what in many cases are like really opaque bureaucratic forms. And so we take that charge very seriously as part of our new needs. And then in this exec budget, we got dozens and dozens of new staff to do just that. Community health workers who can do this work in a place-based way, as well as new, they're called certified application counselors, basically people who have the certification to be able to directly enroll you in health insurance. So we're committed to this. I'll also highlight the Access Health program, which, as you know, is a really important program that coordinates community-based organizations to do this kind of navigation and certified application counseling. And so the future is bright when it comes to this. We have very big challenges because of HR1, but we're not sitting on our hands, right? We are stepping in and stepping up and trying to make sure that New Yorkers have what they need to succeed.
Yeah, and how many new staff were hired for that, and also what's the dollar amount?
Yep, it's 30 community health workers,
30, okay, CHW.
10 specialized insurance enrollers. The total is $4.6 million for that. There's also other funding in that to help support the tech and the IT and stuff like that. But that's those are the people that we're going to be pushing out to our health department facilities. Now, we also have the ability to leverage volunteers, right? Because for people who are needing to keep their Medicaid, they have to submit work hour requirements. And one of the ways that you can submit those work hour requirements is through volunteering. And so we think that there's an opportunity to basically recruit people, have them volunteer with us, but then also, potentially give them the first steps in a healthcare career, because this work is a lot like community health worker work. So that core base of 40 staff will help us then build out to a much larger contingency of people.
Okay, yes, I totally 1,000% agree. This is now the time where we need to really beef up those staffers for that during this time. And then my last question related to your testimony is you had mentioned that there's a $20 million investment in perinatal and early childhood mental health services, as well as the expansion of our nurse-family partnership program. So just wanted to know if you could go a little bit more into detail of what that $20 million is actually going towards.
Yeah, really good question. I'm going to give some high-level points on this, and then I want to have Deputy Commissioner Lydia Ledniak join us to get into the details a little bit. So first of all, this is an expansion of the NFP program, and it's called NFPX. Essentially, it increases the eligibility window for families who can leverage this service. We thought that, of course, we don't want to mess with the secret sauce of NFP. However, we thought it was important to try and increase the aperture of who could be included in the program, so increase eligibility. And then the second component is increasing resources for perinatal mental health issues. We know that one of the things that's killing Black and brown women in this city who are recently postpartum, it's actually not things like, hemorrhage or pulmonary embolism. It's actually mental health issues, substance use issues. So we're surging resources in that capacity. So I'm going to hand it to Lydia to share a little bit more.
Do you affirm to tell the truth, the whole truth, and nothing but the truth before the committee, and to respond honestly to council member questions?
Yes.
You may begin.
So thank you for your question. So the Nurse Family Partnership Program is a program that pairs pregnant people and new parents with a nurse until the child's second birthday. So traditionally, the eligibility criteria for that program was first-time pregnant people up to the third trimester. With this expansion, we are broadening the eligibility criteria to include any pregnant person, even with a prior birth, up until the birth of the child. And we know from research that's been done in this area that parents who have multiple children, right, have additional stressors. And so we're really excited about offering this intervention to additional families. Ultimately, through this expansion, this is an expansion of this eligibility criteria across all of our 15 teams that deliver Nurse Family Partnership Program. In addition, as part of the perinatal and early childhood mental health expansion, we are going to be increasing capacity at our perinatal mental health clinics, and also investing in professional development, as well as working with academic institutions, because we know one of the findings of our Maternal Mortality Review Committee is that there's a workforce shortage in this area. And so this is another way that we are sort of listening to the recommendations that are being made to us and expanding services in these key areas.
That's actually great to hear, because as you know, a lot of immigrant communities, Black and brown communities, either are not believed when they say certain things that they're experiencing, or they don't feel that they want to cause trouble and so therefore don't report to the doctors. I mean, that's how one of my friend's sisters passed away shortly after she gave birth. And so I'm glad to hear that it's not just the first pregnancy, because as we know, it's, each pregnancy is very different. And so it's great that you're expanding it to any pregnancy, so I'm happy to hear about that. And then just lastly, around early childhood and mental health services, is that through the Article 31s, or is that through community-based models, or anything else you could speak to?
It's through existing clinic contracts that we already have.
Okay. Wait, which contracts? I'm sorry.
Clinic contracts.
Clinic contracts,
Yes.
okay. And what's the age range?
So it's perinatal and early childhood, that period,
Okay.
up through,
Probably 13, or,
I think it's early childhood, so it's like through 8.
Oh,
We
only
can-
childhood, okay.
We can get back to you on the
Okay.
exact age range on that.
okay, perfect. And then I have more questions, which I will save till later, and on capital projects, but I'll go into more of that later. But wanted to pass it off to Chair Schulman.
Thank you. Before I begin, I want to mention we've been joined by Councilmember Gennaro and Ressler.
Oh, and sorry, Councilmember Aldebal, as well as Maloney and Deputy Speaker Williams on Zoom,
Oh, okay.
and Jay Sanchez.
Okay, the fiscal 2027 executive plan reflects a $23.8 million reduction in federal funding for DOHMH compared to the fiscal 2026 adopted budget. We know that much of this decreased funding is tied to the expiration of the federal epidemiology and laboratory capacity and COVID-19 grants by July 31st, 2026. In anticipation, the executive plan includes a baseline of $17.6 million, of which 11.3, as you mentioned in your testimony, is city funding, and 70 positions for disease outbreak resilience to help sustain core surveillance and disease control activities previously funded through these temporary federal grants. At a time when public health agencies are responding to emerging infectious disease threats and monitoring outbreaks around the world, such as hantavirus and Ebola, it is important to understand whether this investment is sufficient to maintain the city's disease surveillance, laboratory, and preparedness infrastructure in the face of declining federal support. Will the $17.6 million investment fully replace the funding previously provided through the expiring ELC and COVID-19 grants? If not, what funding gap remains?
Yeah, thank you for that question, Chair. And I think let me just step back and share a little bit about the environment that we're operating in. The funding that you're referring to was sort of this really large one-time investment from the federal government. And I think it is sort of the same story of how public health has been funded for decades, which is these boom-bust cycles. The reality is that this administration gets it. This mayor gets it. OMB gets it. They understand that that's not how you can fund public health.
Right.
You have to be able to have stable funding to provide the services that people need. And this investment is what we need. We have the services now to be able to deliver what New Yorkers require of us. You know, the $17.6 million is going to allow us to, number one, deploy staff in places, for instance, like congregate settings where we see a lot of outbreaks and clusters form,
Right.
places like shelters, places like nursing homes. So having these disease investigation specialists for that. It also gives us the ability to shore up the systems that our staff use, the platforms, the technology. And so I think that, look, there's always more work to do, but at the present moment, we have what we need.
Okay, great. What programs, services, or positions previously supported by ELC and COVID-19 grants will be sustained with this funding, or is it basically how you respond?
Exactly. We don't really expect any service disruptions or cuts to programming moving forward because of this, because of the investment that we have.
Okay, are any public health services, surveillance activities, laboratory functions, or preparedness efforts expected to be reduced as a result of expiring federal funding?
No.
Okay. Beyond ELC and COVID-19 grants, are there other federal funding streams that DOHMH is concerned may be reduced or eliminated in future years? I know, it's a loaded question.
Yeah, how much time do we have, right? Like, I think you know, this is one of the things that keeps me up at night. You know, the idea that the federal government can just sort of decide on a Tuesday that they want to, you know, remove our funding, and this is what happened. It happened about a year ago, about $100 million. We were able to fight back. We went to court, got an injunction. Thanks to the advocacy of this council, thanks to the advocacy of Letitia James, we got that money back. But, you know, there's nothing specific that we're concerned about right now other than the just general climate of concern. And that's why it's important for, you know, city government to stabilize this funding, and that's what we're seeing here in this exec budget.
No, and, you know, and I'm very glad to see it. I'm going to switch gears because I'm going to ask you about childhood asthma in the Bronx. Mayor Mamdani announced a $20 million investment from the MTA Congestion Pricing Mitigation Program to improve childhood asthma outcomes in the Bronx. The investment will support two major initiatives, including $8.9 million for the Bronx Asthma Program, including the establishment of a new Bronx Asthma Center, and $11.1 million to expand the asthma case management program in Bronx schools. The school-based expansion will provide intensive asthma support services, including in-school medication administration, self-management, education for students and families, and the addition of up to 15 schools to the program. While asthma-related emergency department visits among children ages 5 to 18 declined by 38% citywide and 25% in the Bronx between 2009 and 2024, rates in parts of the Bronx remain disproportionately high due to longstanding inequities, environmental burdens, and gaps in access to care. How will the $8.9 million allocated for the Bronx Asthma Program and Bronx Asthma Center be utilized?
Yeah, thank you, Chair, for this question. You know, look, as an ER doctor, what I've seen in my own emergency department is that too often asthma presentations are not dictated by biology or genetics. They're dictated by things like structural racism. They're dictated by, you know, access or no access to health care, dictated by things like being surrounded by mold or pests. And so, you know, we're extremely grateful for, you know, the opportunity to say that this new $20 million investment will be actualized in a targeted way in some of the very communities that are most impacted by asthma. So there are two things that we're doing here with this funding. Number one, we are increasing our footprint when it comes to our targeted asthma case management program in schools. The reason why we're doing that is because it's incredibly important to meet people where they're at and meet students where they're at. They're spending hours and hours and hours a day at school, so let's go there. The second is it allows us to surge resources to our what we call community-based asthma interventions. What this allows us to do is to go literally to the source of the problem in people's homes, do the home remediation work that needs to happen, the pest mitigation, address the mold, et cetera. And so this is not funding a new physical space because we already have a physical space in the Bronx at our Tremont Neighborhood Health Action Center. This is going a step further in sort of saying that we need to further target our resources and meet people where they are.
Okay, so this is an expansion of the Tremont Center, is that what you said? Or
So it's so we have our
so
space.
it's not a new structure, go ahead.
Yeah, we have our space in the Tremont
Okay.
Neighborhood Health Action Center, and now we have more resources to deploy for what we call community-based interventions,
Okay.
as well as in the schools.
How will the Bronx Asthma Center coordinate with hospitals, primary care providers, schools, and community-based organizations in the Bronx?
Yeah, I'm going to say a few words about this, and then I'm going to turn it over to Lydia to share a little bit more. So you asked about asthma centers. Sorry, did you ask about the schools or?
I said, how will the Bronx Asthma Center coordinate with hospitals, primary care providers, schools, and CPOs?
I see. Okay, I'm going to call up Dr. McNatt to the table. Yeah, so we are coordinating in this work through a network called NICAN, which is basically the New York City Asthma Network. This is a network of community-based organizations, provider groups, et cetera, who can help us to support individuals with asthma in the Bronx. I'm going to hand it over to Dr. McNatt to show a little bit more.
Morning.
Morning.
Do you swear to tell the truth and the whole truth before the council members today?
Yes, thank you.
You may begin.
Good morning, and thank you for the question. We're excited to be able to talk about and center the Bronx Asthma Initiative. And you're correct, there is a lot of collaboration that is and will be taking place across the South Bronx. The work that we do with federally qualified health centers, community-based organizations, faith-based organizations, as well as the Asthma Network, help us to be able to implement the kinds of programs that the commissioner described, but also create an ecosystem that makes it easier for community members and families and their children to navigate asthma care within this environment. And so in addition to some of the examples you heard from the commissioner, this funding will also be supporting our support and technical assistance to primary care practices in the South Bronx. So we'll be working with dozens of primary care practices around how they improve the quality of care for children with asthma. And so this is really an opportunity for a defined ecosystem. Work is happening in schools, it's happening in your primary care sites, it's happening in your home, and it's also happening in the action center that the commissioner described. Thanks so much for the question.
What metrics will DOH, I have a number of questions about the asthma center, so what metrics will DOHMH use to evaluate the center's effectiveness in reducing asthma-related emergency room visits and hospitalizations?
Thank you so much for the question. So the Bronx Asthma Initiative will utilize a comprehensive process and outcome evaluation approach for this work. The primary outcome metrics that we focus on are reducing asthma-related emergency department visits and reducing asthma-related hospitalizations for children. To measure population-level impact, we're also analyzing trends for children residing in the Bronx and in the neighborhoods that we're serving through this work in comparison to children residing in other parts of the Bronx. So this analysis helps us understand over time how the intervention is impacting the kids who are going through the services of the Bronx Asthma Initiative. Additionally, we're also assessing feasibility of leveraging a local health information exchange, which helps us with pre and post analysis of the same ED utilization as well as hospital admissions. Thanks so much.
Okay, you answered this a little bit. How will the $11.1 million expansion of the asthma case management program be implemented in Bronx schools? And I'm going to ask what criteria will be used to select the additional 15 schools participating in the program?
I'm going to turn it over to Deputy Commissioner Lydia Ledniak for more on that.
Thank you for the question. So the asthma case management program will be expanding to an additional 15 schools in the Bronx. So really the overall goal, just like with the current asthma case management program, is to control asthma, which is to prevent asthma exacerbations, to reduce hospitalizations, and to ultimately reduce the number of days missed at school. So a structured approach was utilized to select the schools, and I have that here, which is one that we are looking for a general education K through 8th grade school, that there is a Office of School Health doctor and nurse on site, that there is a large population in that school with poorly controlled asthma, where the population is at risk of poor asthma outcomes, as well as the school is located in the environmental justice communities identified by the MTA in the Bronx.
Okay, that's great. How many students and families are expected to be served annually through the expansion?
So currently, with the current asthma case management program, which operates in 14 schools, we serve over 2,200 children every year. With this expansion, we are aiming to reach an additional 750 children. However, because of the intensive asthma case management model and the training that is done in the entire school, in those school communities, we are expecting to reach about 6,000 people through this asthma case management program expansion.
What specific services will students and families receive through the asthma case management program?
So the asthma case management program, is a partnership through the Office of School Health between the Department of Health and New York City Public Schools. We provide intensive case management services to students, which includes medication administration, medication distribution, education around self-management, and ultimately education to the entire school community about asthma and prevention.
Okay, how will case managers coordinate with school nurses, pediatricians, hospitals, and community providers to improve medication adherence and asthma control?
Thank you for the question. So we are planning, as you know, the key to getting school-based medication administration is through the medication administration form, the MAF form. Right now, that process is entirely manual. People fill out pieces of paper.
It's manual? Okay.
Oh, yes, they have to, and then they have to, the family has to bring it to the nurse in the school. So as part of this initiative, we are transforming that.
Digital?
Yep, we are going to build in the asthma case management form into the citywide immunization registry, which will allow doctors and families to fill out that form, and it will be seamlessly delivered to our Office of School Health, thereby significantly improving the timeline and ensuring that students are getting the medications that they need.
Great. Will schools receive additional nursing, social work, or administrative support? It may not be a question you can answer as part of the expansion, or yes?
Yes, they will.
Great.
In addition to the additional asthma case managers, we're also going to be taking on social workers who are going to be working with, families to provide additional education and support.
With the new digital system, what safeguards will be implemented to protect student health information? Because that's a big issue now, and ensure compliance with privacy requirements.
Yes, excellent and really important issue that we've been thinking a lot about in how we're operationalizing this, and that is why we have selected to utilize already existing New York City infrastructure that is, over a decade old, the citywide immunization registry, to build out this portal, and because that system is fully secure and compliant with all confidentiality and HIPAA requirements.
Will DOHMH publish regular reports or dashboards on program outcomes and asthma trends in participating communities and schools?
Yes, absolutely. We will be publishing reports that, go along with what my colleague, Dr. McNatt, just talked about, which we're going to be looking at asthma, sort of like the asthma rates in schools, number of hospitalizations, reductions in days missed in school, et cetera.
How will the department measure whether congestion pricing mitigation investments are contributing to improved respiratory health outcomes in the Bronx, which is actually a good study to have, as a matter of fact, around congestion pricing?
I'm going to pass it to Dr. McNatt.
Thank you so much for the question. The department will measure respiratory outcomes with air quality monitoring, which has already started. Early findings from this work suggest that congestion pricing tolling is not changing the level of vehicle exhaust in environmental justice designated neighborhoods, but the monitoring will continue and will evaluate the impact of the programming on, as my colleague shared, asthma-related ED visits, hospitalizations, asthma control, school days missed, et cetera. Thanks so much.
The Department of Transportation announced yesterday or today that they're going to be using sensors in terms of traffic and all of that kind of stuff, because truck traffic really causes a lot of the asthma issues. Is there a way for you guys to work with them and see how that configures with this?
Yes, thank you so much for the question. We work very closely with DOT and MTA, and so looking forward to be able to utilize the data that they identify.
Can the administration confirm that this initiative funds 9 positions in FY 2026 and 26 positions beginning in fiscal year 2027 and in the out years?
I'm going to pass it to Aaron to share a little bit more about that.
Yep, confirmed.
Great. What titles and functions will these positions serve within the Bronx Asthma Center and the school-based asthma case management program? And also give me the hiring timeline.
There's a number of key positions that we're looking to hire for this, including program directors, asthma capacity building manager, an evaluation manager, community engagement coordinators, and data analyst. We're looking to bring folks in the next few weeks, and the goal is to bring as many of them as we can before the 2027 school year begins.
Okay, great. And I presume that, and with all of this, you're working with the Bronx Borough President and the Bronx electeds on this? Okay, great.
Yep.
By the way, I wanted to acknowledge that we've been joined by Majority Leader Sean Abreu. Well, I'm doing this. Thank you. All right, I'm going to thank you. And this looks really promising. I, in a previous life, worked at Woodhull Hospital, which was considered Asthma Alley. Because of all the truck traffic and everything else and the commercial traffic around there. So, and the NYCHA housing. So, so I'm going to talk about sexual health now. DOHMH's sexual health clinics provide low to no cost sexually transmitted infection testing, treatment, prevention, and HIV-related services. The fiscal 2027 executive plan includes $4 million in additional city and state funding beginning in fiscal 2027 to support rapid STI testing at Chelsea, Fort Greene, Morrisania, and Corona sexual health clinics. How will the additional $4 million for rapid STI testing be allocated across the 4 clinic sites, and what services will the funding further support?
Yeah, thank you for this question, Chair. This is an integral part of our public health fabric here in the city, the ability to offer these low to no cost services across our network of public health clinics. Our sexual health clinics in particular provide this sort of safety net of the safety net functions for this city. Folks don't have to worry about immigration status, insurance status.
Right.
There's no mind towards payment. We are able to, at this point, say that we're going to be opening up a 3rd Quickie Express clinic in Morrisania. That's not by accident. We look at the data, and the data tells us that there are rising STD rates in this area, so we're going to meet the demand and the need, and get the resources that we need in that specific area. The funding is supporting renovations at Morrisania as well as Corona. Okay. And gives us the ability to really shore up our lab equipment, our testing kits, and the specialized reagents that we need.
I'm going to bring up, I brought it up at it was brought up at the preliminary budget hearing, but the Crown Heights Clinic, is there still no plans to do anything there? We're getting a lot of incoming calls from people that live in that district and others, so it's...
Yeah, this is a top priority for us to get that clinic back online. At the moment, it's really a question of funding and staff, but this is certainly something that we hear you, Chair, we hear council, and we hear the community as well, and we're trying to meet that, bless you, that need. Right down the street, the Fort Greene Clinic is open, and so
okay.
We hope to be able to say that both those clinics will be operational soon.
Just keeping it in the loop, keeping it current. Let's see. What trends is DOHMH currently observing in STI and HIV rates citywide, including demographic or geographic disparities?
Yeah, I'm going to call up Dr. Sarah Bronstein to join me on this, but just to give you a very sort of high-level overview, what we see from our last recorded data set is that most reported STIs either decreased or remained stable, and so this is generally good. I think, again, there's much more work that we can do, but this is encouraging. So I'm going to hand it over to Dr. Bronstein.
Do you affirm to tell the truth, the whole truth, and nothing but the truth before the committee, and to respond honestly to council member questions? You may begin.
Yes. Thank you for this question, Councilmember Chair Schulman. As our commissioner mentioned, we do see concerning trends in HIV. As we've mentioned before, in 2024, we saw the 4th consecutive year in which new HIV diagnoses increased in the city or remained stable, and that really is in contrast to marked declines that we observed prior to 2020. We'd also mentioned at the preliminary hearing that in 2024 we saw an estimated 17% increase in estimated new HIV infections compared with 2023, and really persistent disparities across all the factors we measure, including race and ethnicity and gender. So for example, 86% of people newly diagnosed with HIV in 2024 were Black or Latino, and 42% of people with new HIV diagnoses lived in high or very high poverty areas of the city. Somewhat in contrast, in some ways, STIs, we see something a bit different. As the Commissioner mentioned, in 2024, we did actually see rates of most reported STIs decreased or remained relatively stable compared with 2023. And that is a promising trend that differs from previous years. But like for HIV, we do see persistent disparities by race and ethnicity and other factors for STIs. For example, the primary and secondary syphilis rate among Black women in 2024 was 9 times higher than the rate among white women. This is, of course, concerning in and of itself, and because congenital syphilis is something that we are very actively monitoring and working to prevent. And chlamydia and gonorrhea rates among people living in very high poverty neighborhoods in the city were 3 times higher than rates among people living in lower poverty neighborhoods.
Okay, don't go anywhere.
Okay.
During a recent council roundtable run by myself and Chair Lee, we heard from multiple community-based organizations that older adult sexual health is often overlooked. Has DOHMH observed increases in STI rates among older adults, and what outreach or education efforts are underway for this population?
Pass it to Dr. Bronstein.
Thank you for this question. I was actually quite glad to see this, because this is an area that we've been interested in and actively pursuing for a while. So just in terms of your question, Chair Schulman, about the HIV rates, in 2024, 282 people ages 50 and older were newly diagnosed with HIV in New York City, and that was an increase of 18% from the prior year, 2023. However, that was a bit of an aberrant trend in that from 2019 to 2024, we did observe an 8% decrease in the number of HIV diagnoses among this group. But nonetheless, we also know that that older people constitute a majority of people living with HIV in the city. So not just being newly affected by HIV, but in terms of current burden. In terms of other STIs, I'll just mention that from 2019 to 2024, case rates of chlamydia, gonorrhea, primary and secondary syphilis, and early latent syphilis among people ages 60 and older remain stable. The health department does a lot of work to both prevent HIV and STIs in this population, and to educate the population about available services, risk, et cetera. So for example, we are preparing to release a request for proposals for a new sexual health and aging resources and training for clinical providers, what we're calling SHARP program. And this is to fund an organization that will develop and offer clinical trainings and provider and patient-facing resources to enhance primary care providers' capacity to initiate sexual health conversations, take sexual health histories, and implement routine opt-out HIV and STI screening among patients 50 and older. And we anticipate funding that organization who's successfully awarded in the fall. We also have our Be Into Health program that supports HIV clinics around the city to do evidence-based interventions to promote retention in HIV care. And we expect to fund 4 clinics in this program to focus specifically on Black and Latino people ages 50 and older, and address their needs. Our Ryan White program also has an outpatient ambulatory services program, and within that there's a focus on the needs of people living with HIV who are older. Our housing services program, our housing opportunities for people with HIV, also funds 3 organizations to provide housing assistance and supportive services to income-eligible people who are ages 55 and older. So as you can see, we have a lot of programming in this area, and continue to invest so that our older New Yorkers can be sexually healthy.
What? I wanted to ask, so my understanding from the Commissioner for the Department for the Aging that they want to work with you on this, so I presume that you're going to be doing that.
Absolutely, and we've met several times with Commissioner Lisa Scott McKenzie.
Okay, good. How are you promoting this? Like, what how are you marketing this, marketing the services that you have?
Well, we work very, very closely with our wide array of community partners. This programming is really going out into the community to support those service providers, clinical, non-clinical providers who know the needs of these communities and work closely with them to provide services directly. So we do a lot of work through our planning bodies, our advisory groups, to ensure that all of our community partners are aware of current and upcoming programming so that they can take advantage.
Okay, I have a lot more questions, but I want to give my colleagues an opportunity to ask questions, so I'll come back on second round.
Okay, great. Okay, we'll start with Majority Leader Abreu, followed by Councilmember Narcisse.
Thank you, Chair. And thank you, Commissioner, for testifying today.
Thank you, Majority.
The Supplemental Nutritional Assistance Program Education, SNAP-Ed, that program provides nutrition education, healthy eating support, and food budgeting resources to low-income individuals and families across New York City. SNAP-Ed programming has historically supported neighborhoods with experiencing high rates of food insecurity and diet-related illness. With minimal remaining SNAP-Ed funding expected to expire in September 2026, it is important to understand how DOHMH plans to sustain these services and prevent disruptions for vulnerable New Yorkers who rely on nutrition education and food access. My question is, how is DOHMH preparing to prevent disruptions to nutrition education and healthy eating programs serving low-income New Yorkers?
Yeah, it's a great question. First of all, we know that food is medicine for some of our most vulnerable patients. Really, the challenge that many of them are having is that they are having to choose between paying for medications or putting more food in their fridge. And so SNAP is one of the key interventions that can help address that. Now, with regard to SNAP-Ed, we're working closely with OMB, with our colleagues at the state to identify what the funding needs would be. I'm going to hand it over to Aaron to share a little bit more about this.
Yeah, thanks for the question. Yeah, SNAP-Ed is we receive a relatively small amount of money. It's a little bit less than $2 million. I think it's $1.7 million. Funds about 17 staff who are currently on board. This is one that we all across the nation learned about with the HR1 passage last year that was going to be phased out. So yes, the natural expiration of this funding is coming up in September.
And given its relatively small size, do you think this is something that the administration will be able to cover?
I mean, this is another good example of, first of all, I think the deadline was already extended through conversations with the state, which was great. So this is funding that we received through New York State Department of Health. So we are continuing conversations with the state. We're certainly continuing conversations with the city and the admin about
sorry, you were responding? What populations, neighborhoods, and community-based organizations would be most impacted if SNAP-Ed funding is not renewed or replaced?
I'm going to call up Dr. McNatt to share a little bit more about the details on the specific neighborhoods.
Sounds great. Thank you, Commissioner.
Thank you so much for the question. We are deeply concerned about access to SNAP-Ed and to SNAP benefits generally. We know that often the hardest hit neighborhoods include, not solely, but include places like the South Bronx and East Harlem and Central Brooklyn. We are investing in other aspects of food-related programming while we wait to understand the landscape. And so in those 3 locations, we have action centers that make food-related programming available, both for folks who have SNAP and folks who don't have SNAP. And so that includes programming like Get the Good Stuff and Groceries to Go and Health Bucks and the More Veggies program and the Food Voucher program. And so we are heavily focused on food affordability and food security in the city, but understand the concern that you shared. Thank you so much.
Thank you all for your service.
Great, and we've been joined by Councilmember Mealy, and then I'll go ahead to Councilmember Narcisse, followed by Councilmember Wong.
Thank you. Good morning. Thank you for being here, Commissioner and the team. During the Council Women's Caucus meeting, we had last month, we discussed cancer-related services provided to New Yorkers. As we know, one of the Healthy New York NYC goals is to reduce deaths due to screenable cancers, including lung, breast, and colon cancer, cervical cancer, and prostate by 20% by 2030. Is any of the funding contracted out to CBOs, and what efforts are you putting in place to reduce cancer-related death, including programming and marketing campaign?
Yeah, thank you very much for that question, Council Member. We, as part of Healthy NYC, as you've stated, have a goal to reduce the deaths of folks who have screenable cancers. One of the things that we are avidly exploring is trying to identify, first of all, not just where the deaths are happening and sort of identifying the, let's call them hotspot areas, but now also trying to identify where are the resources that we're deploying to make sure that we're doing more of this targeted resource delivery. And we're really excited about this new phase of Healthy NYC, which will be, really a focus and a doubling down on each one of those drivers, but also making sure that the resource that's targeting a driver, like in this case, screenable cancers, is really targeted at the areas where we're seeing the most need and the highest number of deaths. To your question of the advertising campaigns, yes. We actually just ran a very successful advertising campaign over the course of the last month, focusing on the intersection between alcohol and its impact on increasing cancer risk, which many individuals don't know. And so trying to make sure that individuals have the information and the education they need to make the right decisions in their lives.
Thank you. And one of my problems with colon cancer, this is one of the preventable cancer. We should not be having people dying with colon cancer. Constituents come to my office very often to ask about birth and death certificate and other vital records. What are current processing times? And is the department clearing the backlog? Because we've been having backlog on that.
Yeah, we are aware of the issue and looking to make an impact on this. As you know, the birth certificate process through our vital records shop is something that we are responsible for, and we take pride in our ability to do this vital service for New Yorkers. The backlog is top of mind for us, and we're working to shorten it as much as possible.
Thank you. I see on the statement here from you, a $12 million investment in the peer workforce at substance use recovery program across New York City. We have an increase in our kids using drugs as over the top right now, and I'm sure you have seen it too. Do you have a breakdown by how you spend, which area you're targeting the most when it comes to drug use? And if we can collaborate with you to help out, because every time I see a young person under the drug influence, it just hurt my heart.
Yeah.
And they're so young too.
First of all, yes, absolutely. Let's work together on this. We have an incredible team in our mental hygiene division that is eager to sit down and do some problem solving with you. Specifically when it comes to the piece that you mentioned around the $12 million, that is, I think, one of the things I'm most proud of in this first 90 days, quite frankly, this investment. It puts money into an intervention that has tons of data for it, but is underused throughout the country, and these are peer specialists. To put it simply, these are individuals who themselves have struggled with substance use, and they're walking their own journey towards recovery, and they can go and help other individuals start their journeys. And as an ER doctor, I have to tell you, this is like a dream come true, kind of program, because many of the people who I see in my emergency department who are on the verge of maybe thinking about starting their journey to recovery, me saying something is not as powerful as someone who's been in their seat.
Sure.
So this $12 million will help to put 500 more of those people out there in this city, and you're really proud about that.
Okay. Chair, one more question on climate. Climate health and climate change preparedness. We had a study released by DOHMH on March of this year, outlined the department efforts to address the public health impacts of climate change, including extreme heat, we know that, flooding, air quality, and energy energy and security. As climate-related health risks continue to grow, understanding the department priorities and preparedness efforts remain critical. What is DOHMH budget for climate health initiatives, and how is allocated across key priorities? What are the department primary climate health initiatives, and how does it measure success?
Yeah, thank you for that question. Climate change is a public health issue, absolutely. If it's the heat-related events or the air quality challenges, we know that the climate affects people's health in a very powerful way. We have a whole team dedicated to this intersection of climate change and public health as part of our environmental health division. The work that we do on this is not easily sort of contained to just that division, though. I mean, this is really woven in throughout the whole agency. So we can get back to you with regard to the specific budgetary items. Let me hand it to Aaron to see if he has anything to add.
Yeah, thanks, Commissioner, and thanks, Mr. Narcisse. Yeah, the one thing I would add is that there is a process actually for new needs, whether it's on the expense side or the capital side, to take into consideration climate impacts. So that's actually been built in as part of the review process with OMB and with City Hall. So that is a consideration that comes up regularly and whenever we're thinking about new resources.
Thank you. Thank you, Chair.
Thank you. Councilmember Wong, followed by Wilson.
Okay, thank you, Chair. Thank you, Dr. Martin, for coming today. I have 3 questions regarding supervisory licenses on street vendors. Starting July 1st, DOHMH begins issuing 2,200 new supervisory licenses, the first wave of 11,000 new permits over 5 years. My constituents, especially those in Elmhurst and Rico Park, already live with congested sidewalks, blocked storefronts, and sanitation problems from vendors. I support legal pathways for vendors, but the number of new licenses is dramatically outpacing inspection capacity. And this budget funds 133 new inspection positions by FY30. My questions: 1, how many are coming online on FY27 specifically, and how many will be assigned to Queens? And second, before July 1st, what is the current number of DOHMH inspectors covering Queens Community Boards 4, 5, and 6?
Thank you very much, Councilmember. First of all, as a Queens kid and as a Rego Park resident, this is an issue that it hits close to home. We're trying to balance a lot of different priorities here. I'm going to hand it to Deputy Commissioner Crenshift to share more on this, but the idea is we're trying to focus on food safety compliance, on vendor education, and also building the inspection and enforcement capacity so we can do this right and really get this balance right. So I'm going to hand it over to Deputy Commissioner.
Thank you.
Good morning. Do you affirm to tell the truth, the whole truth, and nothing but the truth before this committee and to respond honestly to council member questions?
Yes, thank you. Good morning, Corinne Schiff. I'm the Deputy Commissioner for Environmental Health, and our mobile food vending program is in my division. So we are preparing to implement the council's significant, as you say, expansion of mobile food vending in the city. We will be issuing, starting in July, starting each fiscal year beginning this July, 2,200 supervisory license applications. Those applications would then be turned in, if they are turned into us, would be turned into licenses, supervisory licenses, and that gives the licensee the opportunity to apply for a supervisory license permit. So just to let you know how this will roll out, they won't immediately become permits for vendors to be operating out on the street. These are not designated for specific areas. There is a permit available to work anywhere in the city, and there is a permit available to work in the boroughs outside of Manhattan. We were very pleased, as the Commissioner said in his testimony, to receive resources that we will need to be able to monitor the food safety aspects of these newly permitted units. The issues that you have expressed concerns about and that your constituents are concerned about are handled not only by us when we really focus on the food safety aspect of mobile food vending. Sanitation very much focuses on some of these other issues that you are describing.
Okay, thank you. Thank you, Chair. I'll have questions for round two. Thank you.
Great. Okay, Councilmember Wilson, followed by Kavan.
Thank you, Chair. Good morning, Commissioner. I have a couple questions related to LGBTQ healthcare. So, PrEP and PEP have been amazing developments in preventing the spread of HIV/AIDS. How does the budget ensure affordable PrEP and PEP access, as well as public information on the effectiveness of the drugs and how to use them effectively and safely?
Yeah, thank you for that question, council member. So as I mentioned at the top, our ability to provide medications for sexual health and STDs is a core priority of ours at the Public Health Department. We have 6 sexual health clinics. All of them are, low cost to no cost, so individuals can always walk in and get the medications that they need from us. That will remain true. There also is, no thought to someone's immigration status or ability to pay. And so, we look forward to continuing to provide any and all medications that are needed for both PrEP and PEP.
And then pivoting to gender-affirming care. So it's a particular concern to this body. We passed a package of bills, the Protect Trans Future package last year on this. How is the department addressing healthcare disparities between TGNC, NBI, and gender-conforming patients, reminding them of their rights and helping to make gender-affirming care affordable and private?
Yeah, that's a really good question. So a couple things. The first is we have a trans, non-conforming, and non-binary advisory committee. I actually was just there 2 weeks ago where we had an honest conversation that, this federal government is trying to erase their existence from public record. And so they are counting, the federal government's counting on cities like New York to not say anything and to step back from its role in protecting health for this population. And we will not stop protecting trans, non-conforming, non-binary people. So from our perspective, that advisory committee is what helps us keep ourselves honest and make sure that the services that we're delivering keep them top of mind. We also select and give funding to 20 CBOs throughout the TGNCB Empowerment Fund, which gives us the ability to not just do the work internally, but also to identify the community-based organizations that are really good at this and to fund them to be able to do what they do.
Thank you. That commitment is so important now more than ever. And then finally, in my district, organizations like SAGE ensure the health and well-being of LGBTQ seniors. How does your budget ensure that LGBTQ seniors receive the services they need, including health screenings, vaccinations, and medications? And how is the department ensuring isolated LGBTQ seniors especially are aware of the services for them?
Yeah, it's a really good question. I think there's certainly a lot we can do with you on this, and we're looking forward to partnering with you to make sure we get this right. We have, as I mentioned, at all of our sexual health clinics, we are in a position to help anybody who walks in those doors, whether it's youth or seniors. But targeted interventions, I think we can do a lot more. So we're looking forward to working with you on that.
Okay. Thank you. Look forward to that too.
All right, thank you, Council Member. Stepping in for the Finance Chair, before I start my own questioning, I just wanted to welcome and thank the WIN NYC advocates who are up in the balcony today. Appreciate y'all being here. I want to pick up, I think, where the Council Member just left off in terms of support for our trans, gender nonconforming, gender expansive community, gender affirming care. Commissioner, you said it really well when you said that there is this concerted effort to erase folks from existence. And I just want to put this in the context of the past, because this has happened before, and it is also the reason why our community struggle to this day. So for folks who don't know this, before 1933, Germany was a center of LGBT plus community and culture, and they had a bunch of renowned organizations serving and supporting trans and gender nonconforming people. And it was under Hitler's Nazi government that they were targeted, and it's the same argument of like, we have to protect youth and raising healthy families, and they use that as a mechanism for genocide, right? And that included just decimating the Institute for Sexual Research, which was founded by a Jewish doctor, and that was where like the first modern gender affirmation surgeries were done, and they swarmed the Institute. They burnt over 20,000 books, and it was irreversible, right? Like it set back the progress of the work, not just medically, but socially a long ways. And so here we find ourselves today. And so I want to root it in how important it is and how it's not different. It's not that different. So you said that you guys have launched the Trans Rights or Human Rights Public Awareness Campaign in partnership with the Office of LGBTQIA Plus Affairs and DOHMH. I just want to know what the total budget allocation is for the campaign and what funding source is being used and how the city's going to measure whether the campaign leads to increased awareness of legal protections, increased reporting of discrimination, mental health. Like, what are the things that you're looking at in that?
Got it. Well, first, I'm going to hand it to Aaron in a second. First, let me share that it's incredibly important that we get the messaging right here and that we lean in on the comms and the campaign here. But it's also important to deliver for people, you know, and to provide the services they need. And we're excited to say that pretty soon we're going to be able to offer gender-affirming care directly at our clinics. We have a clinic that will be opening up in Corona, which will offer gender-affirming hormone therapy for adults. It's like one of the first times the public health department has ever taken that step, and we're proud to not just stop there. We'll continue moving forward with this.
Well, can I ask a follow-up on that
Yeah,
particularly?
sure.
Because that's a really big deal, but also it's you know, we're seeing this devastating decrease in services for youth, and especially youth under 13, 12. Like there are almost no providers who provide that care, and the one or two that do is obviously under attack from the federal government. So, are you thinking about an expansion in that youth care? Because I'm talking to parents all the time, and they don't know where to take their children.
Yeah, as you can appreciate, the balance that we have to strike is we are committed to this issue and want to make sure that we provide the services and resources for youth, as well as making sure that we don't expose ourselves to clawbacks from the federal government, which disrupt the rest of the care that we can give. And so there's much more to come on this, trying to sort of figure out that right balance. So we're eager to work with you on this, but rest assured we are working on this, and we're trying to figure out how to do this. Let me hand it to Aaron.
Yes, the numbers.
Yeah, thanks, Chair Cabana. Thanks, Commissioner. So just to put some numbers on a couple of things we've talked about. One is, as the Commissioner mentioned, this 20 community-based organizations that are receiving funding. So that's through the TGNC NB Empowerment Fund, and that's a $2 million investment. And then there's also the trans equity programming. So there are 7 FY26 City Council discretionary contracts across 5 vendors, totaling $2.75 million. That supports primary care, surgical care, mental health care, education programs, and a whole host of other resources.
Yeah, I will say that the investments for just on the trans equity front, we want to see them higher, right? Last year, the LGBTQIA plus caucus, along with community advocates, like shout out to the Trans Equity Coalition who did incredible work, were able to secure an initiative funding a historic investment, almost $13.25 million for gender affirming care. And there is a greater need today than there was even last year. And I know that the advocates are asking for a bigger investment from the administration. I know it's something that the mayor ran on when he was running for office. And so, while we see that investment there, there's a lot of room between that commitment that was made and what we see right now in the exec budget. So do you anticipate us seeing differences when it comes to the adopted, or what are we looking at there?
Yeah, we see you, we hear you, we're on the exact same page, and we can't get in front of City Hall or OMB on this, but there's much more to come on this exact issue.
Right.
We're looking forward
We
to
want to
working
be partners in this, so
Yep.
whatever we
Yep.
can do to help on that front is a big deal. And then before I pass it, before I pass it over to Chair Schulman, I just, I have one more question for you. Gender identity discrimination complaints, the 5-year high, right? While transgender New Yorkers are obviously continuing to face harassment and violence and barriers to care. What investments particularly are being made to address mental health impacts of discrimination and anti-trans violence? Like how much is being specifically earmarked to culturally competent mental health services for transgender, gender nonconforming, and non-binary New Yorkers? I realize that question, it could be in public health, it could be in the DOHMH portion, but I'm just going to ask it now.
Yeah, well, I'll start the conversation and then we can continue with some of our experts. Yeah, look, from our standpoint on our mental health side, our services are available to all New Yorkers, including LGBTQIA+ New Yorkers. Now, that being said, there are specific allotments and carve-outs that help to allow us to do our work even more focused in that community. And so I want to not, jump out ahead of our mental hygiene team, who can give you a little bit more specifics in that. But yeah, absolutely, we do see an opportunity, not just for the LGBTQIA community writ large with regard to mental health, but also the youth component is incredibly important that we get that right. So.
Right, thank you. Pass it to you, Chair. Thanks.
All right, thank you, thank you. Councilmember Ressler?
Right. Thank you very much. Congratulations on your appointment, Commissioner. It's when people are new to city government, one of the quickest ways to judge them is based on the people you hire and put around you. So I was very pleased by your chief of staff appointment, somebody who I worked with for a long time at ACS. So
shout out to Jill.
Shout out to Jill Krause. Okay, few things from me. I'll try to go fast because I'd like to cover a fair bit. So, according to the report we received earlier this year based on legislation we passed last year, there are currently 465 vacant supportive housing units that are contracted by the Department of Health and Mental Hygiene. They are offline with no referral in process. So that's nearly 500 units of housing offline, no referral in process, supportive housing, the most urgently needed kind of single type of housing in all of New York City. Do you have a breakdown of why those units are vacant, and do they need significant repairs? And if, as the City Council's Progressive Caucus has advocated for with our Rentals Within Reach campaign, we were to provide additional funding to fix those units up, would you take it to help to connect more residents who need supportive housing to it?
Yeah, let me say, first of all, you're exactly right. We see the same picture as you do. At the end of the day, sometimes a home is the most important intervention for individuals. We're proud to contract over 13,300 units in total. Our vacancy rate is somewhere in the 5 to 6% range. There's some details here that I want to hold off until our mental hygiene team.
I'll come back to them this afternoon.
But I'll just say that it's a little complicated when we're trying to move folks through the process, right? There are natural things that happen. People pass away, or there are other complications that make it challenging to quickly get people in and out. It's also important to make sure we get the right person in the right home.
Without a doubt, all of that's true, and there's a separate conversation we have to have about how we do a better job of getting somebody through the application process and into housing more quickly. But the thing that we have focused on for both NYCHA and supportive housing under DOHMH and HRA's purviews on the supportive housing side is that we have 1,000 city units that we fund that are vacant and that have no referral in process. And that, in my opinion, is offensive. It's disgraceful. We have thousands of people sleeping on the streets and in our subways who are suffering from chronic mental illness, who have no place to go. The number one solution, the evidence-based, cost-effective solution is supportive housing. And the fact that we have so many vacant units with no referral in process is, I think, mismanagement that we cannot defend or accept. And so we want to put the resources in place to get those units fixed up and work together on it. So we'll follow up with the team this afternoon further on that. I was really pleased by the article in Cranes this morning about the additional community health workers. And so I just wanted to run through this a little bit. Yeah. So our current estimates are that 233,000 people are going to lose access to health care. They'll no longer be eligible for the essential plan after the changes that were made in Albany.
Yep.
And so just to give a sense, to have this on the record and for everyone to understand, that's a single person who's earning between $31,920 and $39,900. So somebody making $30-something thousand a year, living in poverty, right, in New York City, cannot get by, between 200 and 250% of the poverty line, no longer has lost their health care as a result of the changes that have been made. So could you, I think there's two things I'd like you to speak to, because I'm out of time, and I don't want to, Chair Lee will kill me, because she's got 16 more hearings today. Firstly, how are these community health workers, what are the health insurance options that these community health workers are going to be able to connect these very low-income New Yorkers to now that they're no longer eligible for the essential plan? And then secondly, I'm profoundly concerned about the 500,000 people that are going to lose access to Medicaid as a result of the new bureaucracy that is being imposed around recertification every 6 months. I know that we don't have the terms yet from Albany, from the State Department of Health, on exactly what that process is going to look like, but how can those community health workers do more to proactively engage New Yorkers and try to make that process as easy as possible? Is that part of the purview of, I believe, the 46 individuals that you're hiring with those $3 million?
Yeah, look, I mean, we could talk for hours on this, and we
I know.
will
I
follow
tried to
up.
go fast, but
No,
big questions.
We'll follow up with you, and it's clear that you understand this issue and really are committed to helping to address it, and so we're eager to work with you on this. Let's talk one at a time. So first, with the essential plan, your data is exactly right. 230-something thousand individuals are going to end up losing coverage. So what do we do about it? So first, we pulled the Board of Health together just about 2 weeks ago to pass a resolution that calls this what it is. Number one, these are attacks on public health insurance by the federal government. Number two, it commits us to creating a plan to address these coverage loss scenarios, and we immediately put money behind it. We launched a campaign to help individuals who may lose their essential plan, help them enroll in other coverage options, including NYC Care, which is another type of coverage, as you know, safety net of the safety net type of coverage options. But third, helping these individuals also recognize that they can always come to us. We have 11 clinics across the city, and folks can come to us to get their care. With regard to Medicaid, so we have 46 new FTEs that are going to be coming in to help us do this work. That's the baseline. That's sort of a floor. On top of that, we can build in navigators and people who are looking for either volunteer work or looking to do workforce development. And we can add many, many, many more layers on top of that. And we have a huge community of community-based organizations as part of the Access Health program. So the bottom line is this is us as a health department putting our hand up and saying we are committed to this fight. We're going to work with other organizations, we're going to work with other agencies, and we're going to work to get this done on behalf of New Yorkers.
Okay, I really appreciate that. I think, we can't just underscore how devastating the federal policies have been that are going to lead to 1 in 11 New Yorkers losing their health care, right? 9% of New York City residents are going to lose their health insurance as a result of changes to Medicaid and eligibility changes to the essential plan. And when we're shifting, what is billions of dollars, extraordinary sums of onto the health and hospitals that, as a result of so many newly uninsured people going in for care there, NYC Care is a good model. I helped to launch it, but it's not insurance. And, frankly, the wait times on primary care and secondary care are not what we want them to be. So, we have limited options here. Appreciate your creativity in trying to step up and saying we want to do our best to connect people to care and preventative care as much as possible. I think we all need to be much more focused on this issue and immediately, and I appreciate your leadership in pushing this conversation.
Thank you, and we're looking forward to working with you. As I can say, as an ER doctor who is part of the health and hospital system, I think we are going to see a much larger volume of folks coming through our ERs, and the bottom line is we as a health department need to do our job to help ER docs like myself so that we can take care of people, but also not have to worry about helping them get insured. So.
Thank you. Just want to recognize we've been joined by Councilmember Morano on Zoom, and I'm going to, in the interest of time, there were a couple questions that the Deputy Speaker had wanted to ask about the racial equity plan, which we'll forward you guys, and hopefully you can get back to us on those. And I will pass it off to Chair Schulman. And apologies, I had to step out to take an important phone call, so I apologize.
Okay, so the speaker had to be called away. She asked me to ask the questions that she wanted to ask, so I'm going to ask on her behalf. The Office of Healthcare Accountability was established in June 2024 through the Healthcare Accountability and Consumer Protection Act, which the speaker spearheaded while serving as chair of the Committee on Consumer and Worker Protection. The office was created to examine healthcare costs across New York City, improve transparency in healthcare pricing and spending, and identify strategies to reduce costs for patients and the healthcare system overall. The fiscal 2025 adopted budget added $2 million and 15 positions to DOHMH's budget for the Office of Healthcare Accountability, but no additional funding was added to support the office in the preliminary and executive plans. Pursuant to Local Law 78, the office is required to publish an annual report detailing its findings, analyses, and recommendations, which is required to be released by January 1st. What progress has the Office of Healthcare Accountability made since it was established?
Yeah, first of all, just thank you to the speaker for her leadership on this issue. We don't think you can have a conversation about affordability in this city without talking about healthcare, and we don't think you can hold healthcare systems accountable without a body like this, the Office of Healthcare Accountability. You know, the thing that I would say right up front is the tool that we were able to release last December, the price comparison tool, offers New Yorkers an ability to check the price of 30-something, common procedures and services, and this gives New Yorkers the insight that they need to make decisions about where they should go for their care. Secondly, yes, we're hard at work at the annual report. We have a agreed upon deadline with the speaker to make sure that we get that out the door by August 1st. And so we will be working with her team, and with council to make sure that we get the information that we need to do with regard to that annual report. Let me pause there. Much more I could say on the office, but I know you may have other questions.
And the portal that you were talking about, do we know how many people, I know we asked this during the preliminary budget hearings, how many people have used it?
Yep.
How are we marketing it, that kind of stuff?
Yep. 15,000 people have used it.
Okay.
And yes, we are absolutely, singing, praises of this site from the rooftop. I think it's an incredibly effective tool, and folks should get online and should use it. You can just Google search price transparency tool, New York City Health Department.
You should put it out in one of your wonderful tweets that you always put out.
Honestly, that's not a bad idea.
Has the office identified opportunities to reduce healthcare costs or improve affordability for New Yorkers?
Yeah, we're hard at work trying to identify the intersection between the 4 key areas that we're trying to address with affordability and this office. So area 1 is Medicaid coverage and helping individuals who are at risk of losing their Medicaid stay covered. Number 2 is benefit enrollment, so cash assistance benefits like SNAP, WIC, EITC, helping individuals get those benefits. The 3rd is medical debt, trying to erase or prevent as much of it as possible. And then the 3rd is eviction prevention. So we're looking right now at this sort of intersection between what the office has done and what the office can do to address, these 4 areas. And I'm personally very excited about the ability to leverage this entity to accomplish some of our goals for affordability.
How many of the 15 budgeted positions are currently filled?
Currently, we have 12 of the 15 filled. We have 3 remaining slots. These are some of the slots that I mentioned earlier. Highly technical medical economist slots, and so we're looking not to just fill the roles. We want to have the right person in each of those roles. So if council has quality candidates, we'd be looking to interview them and potentially bring them on board.
All right. How is the office coordinating with other city agencies and healthcare stakeholders?
Yeah, we're working across City Hall to do the work of holding healthcare systems and payers accountable. I'll give you just one concrete example. We're working closely with OLR on an upcoming report looking at the NICE PPO plan and making sure that that shift to this new PPO is done in a way that is not limiting access to care and is also decreasing costs.
Given ongoing reimbursement rate negotiations between New York Presbyterian and Emblem Health, what role has the Office of Healthcare Accountability played in assessing the impact of provider reimbursement rates on city healthcare costs?
Yeah, another really good question. So we have our team of healthcare economists and policy analysts beginning to ingest that data and to analyze it to assess what the impacts are going to be for New Yorkers. At present moment, we don't have a final analysis to share on that, but we can circle back.
When is I know you said you're working on the report. Do you have an estimate of when the report will be ready?
Yeah, we're aiming to get that by August 1st.
Okay.
Yeah.
And, I'm sure some of these questions here, because I want to skip to something else, will be answered in the report. I want to ask you about, hold on one second. Sorry, it's, just a couple of quick questions. One is about groceries to go. So groceries to go, every year, it's financed at $10 million, and I want to know if there's any move by you guys to push OMB to baseline it, because every year it's $10 million, and then we have to keep pushing and pushing and pushing, and it should just be baselined at this point.
Yeah, huge fan of this program. This is an
A lot of
incredibly
people are.
important program for individuals throughout the city who need access to fresh fruit, produce, and food that keeps them healthy. We've been able to help about 4,200 people over the course of calendar year 2025. And so we're constantly in communication with OMB to figure out how to meet the needs of our people that we serve, and are looking to continue those as we build it out.
Okay, we're in the interest of time, I think we're going to send you a bunch of questions, so we're going to ask you to answer those. That we're not going to. But one question I do want to ask, that last year City Council provided a $500,000 discretionary award to Flatbush Cats to support TNR services. So we wanted to see if the administration would consider baselining or expanding city support for TNR and low-cost spay-neuter services in future fiscal years.
Sorry.
What?
As a proud cat dad,
That's good to know.
I'm just laughing because I have 4 cats now. I have my 2 normal cats, and
That explains it now.
My fiance surprised me with 2 new foster kittens this weekend. So we will circle back.
Circle,
to you,
yeah, it's an important, because it goes back to, we had questions too about the ACC and when when are they all going to be finished? When is the Brooklyn Animal Care Center project going to be done? Because the other thing too is that the overcapacity is based on the TNR, everything goes hand in hand.
Yeah, I can just speak to some, sorry, I regained composure here.
Yeah, no.
We can say
going
that
on.
the Bronx shelter is going to be targeted for opening in early 2027.
Okay.
We have
That's good.
renovations that are going on in the Brooklyn shelter.
Right, when is that? How is that going?
Thinking about late 2027 for that one.
All right. All right. We will ask you, like I said, we'll send you a bunch of questions, and I'm going to hand it over to Chair Lee to end our session, yes?
Okay, one more question, though, from Councilmember Narcisse.
Thank you again, Chair. Recent federal court activities surrounding access to mifepristone medication has brought back national attention on reproductive health and access to abortion services. DOHMH operate the Abortion Access Hub, which connects individuals to abortion providers and reproductive health resources. and medication abortion services are currently available at 4 sexual health clinics. The executive plan includes $5 million baseline starting in FY27 for abortion access services. How will the $5 million baseline funding be used to support abortion access and reproductive health services?
Yeah, thank you very much for this question, Council Member. We take seriously our responsibility to provide access to safe abortion services, and that means not just providing those services ourselves, as you've said, but we also make sure to provide a network of providers that patients can call. This is funded through our Abortion Access Hub. We've been able to answer nearly 10,000 calls and refer over 8,000 patients to a whole network of providers who can help them if they need. And so we're not going to stop providing these services no matter what we hear from the federal administration. I'm going to pass it over to Aaron to share more.
Yeah, thanks, Councilmember Narcisse. Right, so just to reiterate, yeah, the $5 million baseline funding actually came a couple years ago, so this helped us stand up the Abortion Hub work. And of the $5 million, it includes $1 million for the Abortion Access Hub itself, and then about $4 million of that is for our public health clinics to provide medication abortion services.
Why is abortion medication currently available at only 4 of the city's 6 sexual health clinics? And are there plans to expand access citywide?
Yeah, really good question. You're right. 4 out of the 6 currently have the capabilities to do this. We are working on a 5th. I will say that the challenges are mostly with space, and some of these services need more than just a simple room. You know, we need to be able to do the care right by the patient, and so we're working through some of the challenges with regard to space and logistics, but it's our hope that we'll be able to expand these services.
Okay. What trends has DOHMH seen in utilization of the Abortion Access Hub?
So far, what we know from our data is that we've been able to answer about almost 10,000, but 9,400 calls. We've been able to refer about 8,000 patients, and interestingly, what we see is that a pretty sizable portion are people who are not even from New York City. About 25% of the folks who are calling into the hub are from places like Georgia and Texas and others. And so this service that we're providing, of course, is primarily focused for New York City residents, but we're identifying that others across the country are using it as well.
But somewhere I heard that some of the folks from here traveling to other states to get abortion medication or care. Have that? When I heard it, I was wondering, how come we're leaving the city of New York to go other states to get abortion supports, whatever?
Yeah, I haven't heard that. We will circle back on that and have a conversation with you if it seems like that's true.
Okay. Has demand for reproductive health services changed in recent years? I know you knew, but you can make from the data.
Yeah, it's a good question. So we'll have to get back to you on exactly what the trend looks like. I will say that we expect it to, because of some of the data that I've just suggested, that 25% of the people who are calling our lines are not even from New York City. And so as we see the abortion access landscape across the country change, I think we're going to end up seeing more intake from our own city.
Okay. How does DOHMH ensure timely reimbursement for community-based providers delivering those services? And quickly, Black and Latino mothers continue to experience higher rates of maternal morbidity and mortality than other groups. What is DOHMH doing to reduce these disparities?
Great. We're going to take those one at a time. I'm going to kick it to Aaron on the reimbursement, and then I'll take the second part of the question.
Yeah, thanks for the question. So we certainly aim to ensure timely reimbursement for all of our providers, including these folks. If there are issues, we're always happy to work with them directly. And actually, our chief nonprofit officer position is there for exactly that type of work. So we're happy to have that.
And
You can see that the timing things, even though we want to continue with the hearing. Go ahead.
should I continue?
No, finish.
Yeah.
Finish answer.
So yeah, you're right. So Black and Latina women face up to 4 to 5 times the likelihood of dying from pregnancy in this city, and that's unacceptable. We have a number of concrete initiatives that we leverage in a targeted way. The first one that I'm most proud of is the citywide doula initiative. This is a program that pairs at-risk pregnant people with doulas to help them basically walk through the whole process of pregnancy with someone by their side. We've had thousands and thousands and thousands of people who have been served by the CDI, the Citywide Doula Initiative. We've had 0 maternal deaths as part of this program. This
I
is
love that improvement.
an astounding.
Okay. Due to time and the
No.
chair seem like we want to keep the time, so I'm going to pass it on back to.
Yeah, we'll definitely follow up for the rest of the questions that were not asked. And then Councilmember Wong, yes.
Final question.
Final round,
Thank you,
yes.
thank you. In this budget over here, it says that highlights of the 27-30 4-year plan, you're going to have a new animal care center in the Bronx, upgrades to the animal care center in Brooklyn, and other animal welfare investments. Now, the Queens Animal Center opened on August 23rd, 2024. Looks great, 50,000 square feet, beautiful. The problem was the Brooklyn Center was closed within the same week, and all the Brooklyn animals moved into Queens. I know because the Queens Animal Care Center is within walking distance from my district office. And what happened? The Queens animal got displaced, and they became the victims, and many of them were sent away or even euthanized. So what I would like to know is, do you have a plan? Because if you're going to build, say, the Bronx one, the Brooklyn animals is going to the Bronx animals will move to Brooklyn when that's finished, and then all this is going to happen again. All right, so my question is, do you have a plan B on what to do with the animals while these animal centers are being renovated, rather than just push it into the other boroughs? That's my question.
Yeah. It's a really good question. So first of all, we have had an increase in our budget specifically for animal control. Number 2, as you've talked about, we have the Bronx shelter that's going to be opening in 27, and the Brooklyn renovation, which is becoming in the end of 2027. So we are certainly aware of the increased surge and the capacity here. I'm going to pass it over to Deputy Commissioner Corinne Schiff to share a little bit more here.
Thank you.
Thank you. And then the Queens Animal Care Center is, as you say, a beautiful state-of-the-art facility. When we opened that facility, we were able to actually align the full renovation of the Brooklyn site at the same time as we were opening up the Queens site. And what that let us do is move more rapidly to finish the Brooklyn site. And what we had been concerned about is the alternative was to be building doing the renovation at the Brooklyn site while staging those renovations. So the animals and the staff would have to be on site. That was going to slow us down, but it was also going to leave the animals and the staff essentially in a construction zone, which would have been very stressful for the animals. So we managed to align the 2 projects, and we moved the animals that were in Brooklyn to the Queens Animal Care Center before it opened. That let us keep status quo, the number of full-service shelters that we had operating in New York City, as the commissioner just said, and as we had, the chair had mentioned. We will be opening a full-service shelter for the first time in the Bronx, and we will be opening a full-service shelter in Brooklyn. That's going to expand our capacity across the city.
Okay, my final comment is that there's room for improvement on animal adoption, because what I see is that if we can do better on that, then far fewer animals will get euthanized. And I get calls every other day, animal XYZ is going to get euthanized. So what are you doing to promote adoption? And I cannot answer them because we do not, I'm not the one that's planning them.
And let me just say that the animal care centers there were no animals euthanized with respect to the move from Brooklyn to Queens. Animals are not euthanized for space. We do have animals available for adoption. We also have a facility in Manhattan that is solely dedicated to animal adoption. There are wonderful animals available for adoption from animal care centers. We welcome your helping us to get out the word about adopting from ACC, fostering from ACC. Those are New York City's animals, and we welcome your support in getting the word out to New Yorkers.
Thank you. Thank you, Commissioner. Thank you, Chair.
Thank you. Okay, we're going to take a really quick break. I'm going to say 5 minutes, knowing it's probably going to be a little longer, but definitely for sure. Want to make sure that we are starting at 12:30 at the latest. So thank you so much.
Second? Okay. So clubhouses, 4 million. Is that baseline to council amounts?
It's a good question because
Yeah.
the council amount is,
Yeah,
council amount is
it's
pretty
not,
low.
is it?
This is actually restoring, putting baseline funding in place before the
Okay.
temporary one-time federal.
So it's not?
It's not.
Okay, thank you.
Okay, yep. I'm sorry. You look a little bit. No, I was.
Okay, I think we're ready to begin.
We got time, I'm still chewing.
All right, so good afternoon and welcome to the second FY27 executive budget hearing for the day, focusing on Department of Mental Health and Mental Hygiene on the mental health portion. I'm Councilmember Linda Lee, and I'm pleased to be joined by my colleague and chair, Councilmember Caban, chair of the Committee on Mental Health and Addiction. And we have been joined by the Deputy Speaker on Zoom, Councilmember Narcisse, Wong, Wilson, Felder and Areola on Zoom, and Councilmember Ressler. And I think that's it. And Councilmember Shulman, oh, yeah, because you were the chair of the other one. Sorry about that. Okay. So welcome again to Commissioner Dr. Alistair Martin and your team, and thank you so much for joining us today to answer our questions. On May 12th, 26th, the administration released the executive financial plan for FY27 to 30 with a proposed fiscal 27 budget of $124.7 billion. Department of Health and Mental Hygiene's mental health proposed fiscal 27 budget of $923.1 million represents 0.7% of the administration's proposed FY27 budget in the executive plan. And this is an increase of $67.8 million or 7.9% from the $855.4 million originally budgeted in the preliminary plan. This increase results from several actions, mostly involving mobile treatment teams, mental health clubhouses, the Office of Community Mental Health, and an array of savings measures. As of April 2026, DOHMH's headcount for mental health was 24 less than their fiscal 26 budgeted headcount. In the Council's preliminary budget response, we called on the Mayor to add $18 million to DOHMH's mental health portfolio to invest in intensive mobile treatment, assertive community treatment, and crisis respite centers. We also raised concerns regarding mental health programs, one-shot funding, mental health continuum, New York City 988 to ensure free suicide prevention counseling is available to all New Yorkers in crisis, peer specialists, and to ensure we are adequately funding clubhouses. Although our request was not included in the plan, I look forward to hearing from the Commissioner today about their plan to sustain critical mental health programs and what steps are being taken to ensure these vital programs remain available to New Yorkers who rely on them. And I now want to turn over to my co-chair for this hearing, Chair Caban, for her opening statement.
Thank you very much. Good afternoon, everyone. I'm Councilmember Tiffany Caban, Chair of the New York City Council's Committee on Mental Health and Substance Use. Thank you for attending today's hearing on the city's fiscal 2027 executive budget for the mental hygiene portion of the Department of Health and Mental Hygiene, or DOHMH. I would like to thank Finance Chair Lee for holding this executive budget hearing with my committee, and also Dr. Martin and your team for testifying today. In the fiscal 2027 exec budget, DOHMH Mental Hygiene's proposed operating budget is $923.1 million, of which $63.2 million is spent on personnel services for 563 budgeted positions. The budget also includes nearly $860 million for other than personnel services, most of which covers 377 mental hygiene contracts. So the net change of $67.7 million in the DOHMH Mental Hygiene fiscal 2027 exec budget compared to the fiscal 2027 prelim budget, I think is mainly due to a baseline funding cliff for mobile treatment teams and DPHMH funded clubhouses. And I think that's important to point out and be clear about. And the changes also include a one-time funding to support the Office of Community Mental Health and the newly created Office of Community Safety, as well as additional opioid settlement funding that the department received. So the executive budget, it also includes an array of new savings measures focused on contract renegotiations, vacancy reductions, and anticipated underspending. And I'm interested in hearing, Dr. Martin and your team, your testimonies on how these savings were achieved and whether they would impact operations. One thing is clear, New Yorkers with mental health and substance use issues rely on all of us to advocate for them and allow them with adequate resources to continue receiving services and care that they need. And I do want to ensure that the city doesn't cut funding that will impact critical services. And so the committee is going to focus on the following topics for questions today, and that's going to be the DOHMH mobile treatment teams, the opioid settlement funding, the city supportive housing program, as well as JISH, the Justice Involved Supportive Housing, DOHMH relay programs, and headcount changes. I know that our chair, who's well-versed in this area as well, is going to focus on some other related areas. But before we begin, I would like to thank the financial analyst, Aman Mahadevan. We got to put respect on our names, you know? And Assistant Director Florentine Cabore and Deputy Director Ms. Wright for preparing this hearing, and the committee staff, Sarah Sucher and Justin Campos for their support. The committee is just incredible. They are the best. And I would also like to thank my staff, Jonah Birch. So I'm going to turn it over to Chair Lee now.
Okay, great. I'm going to make the same announcement as I did before, which is that we are having public testimony hearings all day, Wednesday, June 10th. I feel like I'm promoting a party, but it's I hope you guys are going to join us and listen in. But yes, June 10th, starting at 9:30, is going to be an all-day public testimony hearing day. So please join us for that. And without further ado, I'll pass it off to Brian Sarfo, our committee counsel, to swear in the witnesses.
Good afternoon. Do you affirm to tell the truth, the whole truth, and nothing but the truth before this committee and to respond honestly to council member questions? Commissioner Dr. Alistair Martin,
Yes.
Deputy Commissioner Anderson,
Yes.
Deputy Commissioner Dr. Pettit,
Yes.
Assistant Commissioner Nichols,
Yes.
and Assistant Commissioner Dr. Lynn Walton. You may begin.
Oh, sorry, one thing really quickly. We've been joined by Councilmember Aldebal, and sorry, go ahead.
Fantastic. Thank you very much, Chair Lee, Chair Caban, Chair Schulman, and council members who are here with us today. My name is Dr. Alistair Martin. I'm the Commissioner of Health at the New York City Department of Health and Mental Hygiene. I'm joined today by our Chief Financial Officer, Aaron Anderson, Executive Deputy Commissioner of Mental Hygiene, Dr. George Petit, and Assistant Commissioner Jamie Nichols, and Dr. Rebecca Lynn Walton. Thank you for the opportunity to testify today on our executive budget as it relates to mental health. Our mental health work is a core component of our larger vision for the health department and the city. We offer a wide range of free services for justice-involved populations and New Yorkers struggling with mental illness or substance use. Some of those services are delivered directly by the health department employees. In addition, we work with more than 200 community providers to deliver more than 500 programs. These programs offer crisis intervention, housing, clinical support, and many other mental health programming. We build on that work every day. For example, in my first 90 days at the agency, I was proud to announce a $12 million investment in the peer workforce at substance use recovery programs across New York City, a $20 million investment in perinatal and early childhood mental health services, as well as the expansion of our nurse-family partnership program, and a new campaign that encourages New Yorkers to order and carry our free naloxone kits. Last year alone, we distributed more than 285,000 naloxone kits and more than 100,000 fentanyl test strips. Across every service, we are focused on harm reduction, accessibility, and honoring every person's humanity. That is perhaps best exemplified by our peer workforce programs. Last month, the Mamdani administration announced a $12 million investment of opioid settlement funds. That money will go towards peer workforce development programs for substance use recovery, including things like internships, scholarships, and direct hiring opportunities. Over the next 4 years, this money will ultimately help employ 500 more peers across New York City. The peer model honors the fact that people in recovery have a story no one else can tell. There is no substitute for lived experience. The recent investment in this workforce will help equip 500 more people to retrace their steps on the road to recovery and bring someone back with them. Whether New Yorkers are struggling with substance use, mental illness, or transitioning out of incarceration, they need the same things we do: to know that they are not alone and to have a safe place to come home to. We recognize that affordable, stable housing is a starting point for recovery, and so we're determined to get as many New Yorkers as possible housed and connected to resources. We remain committed to the goal of the 15 over 15 program to develop 15,000 units of supportive housing, which provide affordable, independent, and permanent homes to New Yorkers who are unhoused. and either have or at risk of having a serious mental illness or a substance use disorder. This year, we surpassed 13,000 units of both 15 over 15 units and state-city partnership program units. We are well on our way to meeting or exceeding our goal. Approximately 13% of our supportive housing units serve families with children. About 5% serve young adults. In aggregate, that's more than 2,000 units that are providing New Yorkers with stability early in their lives. All 13,000 of these apartments provide long-term solutions. Our data shows that for people moving out of supportive housing, the average length of stay is 7.6 years. These units are a lifeline for thousands of our neighbors, especially in one of the most expensive cities in the world. In this year's executive budget, I'm particularly proud to see the necessary funding to turn our community syringe redemption pilot program into a mainstay initiative. That program offers payment for the collection and safe disposal of used syringes in public spaces. Participants receive guidance on how to safely dispose of syringes and are paid 20 cents a syringe for up to $10 a day. In the first year alone, that program was responsible for the collection of more than 1.7 million syringes and enrolled over 1,800 participants. That's 1.7 million syringes safely discarded away from public reach. By every metric, it was a remarkable success. That's reflected in the testimonials of participants. One of our earliest adopters said this program gave them a reason to not reuse needles. While removing litter is one small piece of a larger ecosystem for harm reduction and recovery, it's making a tangible difference in our communities. The syringe redemption program is complemented by the ongoing work of our outreach and syringe litter programs, who also offer naloxone and service referrals to New Yorkers who frequent the high-use areas our teams prioritize. Every outreach and syringe litter team partners with a syringe service program. These SSPs provide overdose prevention education, HIV and hepatitis C testing, and referrals to a range of health and social services. There are 14 SSPs across the city, and they provide services at both brick and mortar locations and through mobile vehicles. Their work reaches approximately 22,000 people a year. I'm grateful to see the value of the syringe redemption program and the larger harm reduction work it's part of be recognized by our city budget. While mental health care is integral to programming across the health department, our mental hygiene division leads that work and employs about 600 people with an operating budget of over $900 million for fiscal year 2027. There are several components of this year's city budget that support our mental health programs. In particular, there are long-standing funding cliffs that have been structurally solved in the budget. We're grateful to see our work receive the long-term stability it deserves and break out of the pattern of year-to-year funding. That includes our mobile treatment programming, which encompasses intensive mobile treatment and assisted outpatient treatment teams. IMT teams serve New Yorkers whose needs are not being met in traditional healthcare settings. They serve some of our hardest to reach neighbors and meet them wherever they are, at home, in the shelter, a street corner. Many of these teams include both clinicians and peers who are equipped to support New Yorkers through mental health and substance use disorder treatment. Services are individualized and courses of treatment are expected to last several years. That program reached more than 1,000 people a year. In parallel, our assisted outpatient treatment teams support adults with a history of multiple hospitalizations or harm caused by non-adherence to mental health treatment plans. AOT reinforces recovery by monitoring the progress of a court-ordered treatment plan and supporting New Yorkers through care coordination across multiple service providers. That work supports more than 2,000 people a year. We are also encouraged to see funding stabilize for clubhouses, which provide New Yorkers living with serious mental illness with help accessing benefits, employment opportunities, and communities. There are 13 clubhouses across all 5 boroughs. Each of these physical sites houses a community stronghold for New Yorkers with mental illness. 40% of members have been enrolled for more than 5 years. Here, participants are not clients, they're not patients, they're members. And each clubhouse is designed by and for the members it serves. New Yorkers deserve reliable, stable access to these services, and we're reassured this council and this administration are dedicating resources to sustain them. Finally, at the federal level, we are watching this administration's actions very closely. National mental health infrastructure has consistently been devalued as far as we've seen under this administration. Harm reduction work in particular has come under unwarranted scrutiny. At the New York City Health Department, our federal funding is concentrated in our disease control and our emergency preparedness divisions. Our mental hygiene division is not heavily reliant on federal funding, but every part of our agency is impacted by the rapidly changing public health landscape we live in. We continue to monitor changes in federal funding, infrastructure, and policy. And so in many ways, this year ahead is sure to be a challenging one, but I have every confidence that we will meet the moment. That confidence is not derived from any one leader, but it's derived from the many public servants committed to showing up for our city every day. Early in my tenure as health commissioner, I spoke with one of our public servants working in substance use recovery. Her name was Bev. When I asked Bev what keeps her going every day, she told me something I'll never forget. She told me this wasn't a job, it was a calling. I'm grateful to lead an agency of people who took a job and made it a calling. I have every confidence my agency will continue to answer the call for our city. Thanks for your attention. We're happy to answer your questions.
Great, thank you. So I'm going to quickly try to go through these so that I can pass it off to my colleagues. So in terms of, similarly to the last question about state funding, the executive plan includes state funding of $464.5 million in FY26 and $414 million for FY27. And because the executive plan was released before the enactment of the state fiscal 27 budget, what was added in the executive budget that was previously proposed in the state's executive budget? And is there new mental health and substance use funding in the state's adopted budget flowing to DOHMH?
First of all, we're happy to partner with our state colleagues on this work, the Office of Mental Health and OASAS. And we're always in conversation with our partners at the state to define how we can better intervene as co-partners in this. The State Department of Mental Health is spearheading a couple of expansions that we're aware of. The first is an expansion of the ACT program statewide. And so, we're going to be closely monitoring this expansion so that we can see in what ways does this impact our city's program with regard to ACT. Ultimately, from our perspective, we continue to advocate strongly for sustained state investment. We need the state to be part of this work and be our partners here in the city. And so far, we've had really, really great working relationships with the state.
That's good. I mean, especially, thanks to, of course, also on the substance use side, the opioid settlement funds. I'm glad that that's now finally being realized and spent down as well. And good to hear about the ACT programs being expanded. Do you know how much that included for the expansion?
For the State Department of Mental Health?
Right.
Yeah, we're going to have to get back to you on that.
Okay, perfect. In terms of contract savings, DOHMH has is one of the agencies that has a really large number of contracts. And just wanted to know, how often does DOHMH assess the effectiveness of its programs run by CBOs, nonprofits?
Yep. Let me ask, Chair, is this related to EO12? Or just broadly speaking, our contract reevaluations?
I think in general, but yes. I mean, the savings portion, yes, it's related to that, but also in general, I think for best practices.
Yeah, how often we.
Yeah.
So yeah, let me start on the savings piece, the EO12 piece, and then I'll
Sure.
get to Aaron to share a little bit more here. So similar to our mandate with regard to public health, we're trying to balance these two priorities. The first is really aligning with the mayor's vision on the Chief Savings Officer initiative. At the same time, we're making sure to not cut any services with regard to our mental hygiene portfolio. And I'm proud to say that we've come through this process with EO12, and I can stand firmly here and say that no programs were cut and no services were degraded as part of that experience. Let me hand it to Aaron to share a little bit more.
Yeah, thanks, Commissioner, and thanks, Chair Lee. I mean, as a general matter, all CBOs are evaluated once a year at least in the past.
Right, for the
board meetings.
contract renewal.
Yeah.
Even if it's a 3 to 5 year contract, they still sort of have the annual, okay.
Yeah, and I mean, aside from that, and I would certainly defer to my programmatic colleagues beyond this, but I mean, I think we're always thinking about metrics and how to make programs better and how they're doing and all of that good stuff.
Okay, perfect. And are there service or program areas, based on what you've done with the assessment, that would function better if they were delivered by DOHMH directly? And this is not just specifically related to the CBO contracts, but in general.
I guess you're asking the question of whether or not it's better for us to bring the services internal versus
In-house, right.
Yeah, it's a really good question. I'm going to pass it over to Dr. Petit in a second, but yeah, I think this is the core tension, not just on the mental health side, but also on the public health side, right? What do we keep in-house, and what do we, sort of contract out and find a service delivery partner for? So getting that right is something that we're constantly trying to improve on, and so let me hand it over to Dr. Petit to share a little more.
Yeah, thank you, Commissioner. Thank you for that question. As a public sector psychiatrist doing this for 30 years, it is an interesting question to be thinking about where the role of, the division is vis-a-vis the providers. But I do have to say, the way that the entire system has been sort of built up over the last, many decades is really relying on contracted providers who are deeply embedded in their communities, who know their communities in ways that it's harder for us centrally to be as attuned to some of those needs. Even though we're aware of them, it really is important for these niche providers to be able to deliver an array of services in their communities to their constituents a little bit differently than we could. There are things that we could do citywide that are more overarching, that really speak to the system as a whole. But I am a big believer that a lot of our programs that exist in these communities are best served by community-based providers.
And as a former provider, I fully subscribe to that, especially in communities that have very specific language needs and cultural needs, so yes. Okay, so DOHMH has a 3-year contract accounting for $26 million with a CBO called Somethings for a telepsychiatry service program for teens. And the contract is set to expire at the end of FY26. So just wondering, what is the update you can provide for this specific contract, and can you elaborate more about the service?
So first of all, the service that we are providing here is one that we take very seriously. This is teen mental health, and for teens, you have to be able to meet them wherever they are, and in this case, we are trying to meet them digitally, and so that's what you're seeing with the work that we're doing on Teen Space. The contract that we're talking about here is one that we are trying to re-procure and do it in a fair way, in a transparent way, and also we're making sure that we can continue to deliver the service so that there is no service disruption for teens that are involved. I'm going to hand it to Dr. Petit to share a little bit more on the details here.
Yeah, thank you again. So this contract was actually a 3-year demonstration project. So it's about to end in October, and we are going through the process of a concept paper and ultimately a reprocurement of it. I think what's really important is that there is an evaluation tied to this, so that we can actually determine not just lessons learned over the last 3 years, but where things are at currently. Where, like we talked about a little bit earlier, where we are today is very different than where we were 3 years ago, especially with a lot of this technology. So, Teen Space is free, regardless of zip code, location or wherever an individual kid, 13 to 17, can actually access, talk, text, or chat in a free way. So it's been incredibly helpful and impactful. We've had over 45,000 registrations since inception, and I think we can do more with this, and that's why we're looking at a procurement process that will help us, shape this going forward.
Okay, and it's kind of crazy to think that in 3 years the technology has advanced so much in that short time as well. Okay, so just to confirm, because I think we had heard that DOHMH was not considering renewing the grant starting in FY27, but you're saying that you are going to look at issuing out a new RFP and then putting that out?
Yeah,
Okay.
so we will extend the contract until a procurement is out on the street.
Okay, and you're saying that should be around October 27, right? Or 27?
So the contract is up now.
Right.
Or it's terminating now. We will be extending the contract as we're going through the process of the concept paper and the RFP. So
Right.
the extension will be until the next contract is until we're able to procure the next contract.
Okay, and then when do you think that would be, the new RFP to be released?
Hopefully before the end of the year, we'll have an
Okay.
RFP out.
Okay, perfect. Just wanted to check. Okay, let's see. In terms of contract renegotiations, really quickly, the executive plan includes baseline reduction of 2.2 million starting in FY27 as part of contract renegotiations. And so just wanted to know, were these contract reductions associated with the chief savings officer findings, or was it something separate?
Yeah, let me hand it over to Aaron to share more.
Okay.
Yeah, thanks, Chair Lee. So that, yes, that line item was part of the EO12 savings reduction initiative.
Okay.
Yeah.
And then how many contracts and what type of contracts are being renegotiated?
Yeah, so we're still in the process of looking at that. I think this was based on a pretty reasonable, even maybe conservative assumption. So we're in conversations right now with several different contracted vendors.
Okay, and how will the services provide through these contracts be impacted by the renegotiations? No impact, or?
Yeah, I mean, our guiding premise for this entire exercise, as we testified earlier as well, is really minimizing or making sure that there are no service impacts to the public. And so these contract renegotiations are also happening through that lens, and so there will be no service impacts.
Okay, and I'm sorry, can you, I don't know if you answered this part, but what type of contracts?
I mean, we're looking across the board. I mean,
Yeah.
as you know, mental hygiene has an enormous portfolio.
Yes.
So there's a handful at least that we're looking at specifically.
Okay.
Obviously, we can't talk about them.
Okay,
This-
yeah, if you could let us know and follow up, that would be awesome.
Happy to, yeah.
Okay, so it also includes, the executive plan also includes reduction of 1.2 million starting in FY27 as part of a renegotiation of the naloxone contract. Are the naloxone contract renegotiations also related to reduction of services due to underutilization, or why was that scheduled reduction baseline?
Yeah, so this is an incredibly important topic, and one that I have to say, the data is moving in the right direction when it comes to overdose deaths. We're down 28%, as in terms of our last recorded year on file. A lot of that is due to programs like this one. I just want to plug one more time the program that I mentioned in my testimony, nyc.gov/naloxone. Any New Yorker can get online, put their information in, and get multiple units of naloxone shipped to them completely for free. We were able to distribute about 285,000 kits over the course of the last year. Let me hand it to Aaron to share a little bit more about the budget piece.
Yeah, thanks, Commissioner. So this, I think, is actually a great example of how you can be creative when doing these savings exercises that are often pretty painful. So the story with this one is just that naloxone has come down in cost considerably over the past few years, and it continues to. And so we've seen it's already come down in our world quite a bit. But we've seen other states, California, for example, sort of hit record lows. And so we're watching very carefully what other states are doing around the country, what other municipalities are doing, and I think we're very confident that we're going to see additional savings here. So
Okay, good to know.
it's a bit of good news, yeah.
Yeah, got it. Okay, moving quickly to the clubhouses, which is a topic that is very near and dear to me. But so when we saw that there was a $4 million baseline in the FY27, I was like, yes, it includes the smaller clubhouses. And then I realized, no, that's not what it's for. But it's to address a stimulus funding cliff for existing DOHMH funded clubhouses. And so what's the total budget for the DOHMH funded clubhouses for FY27?
So thank you for that question, Chair. I have to say I agree with you in terms of how miraculous these programs are. I visited my first clubhouse just a couple weeks ago. I was at Phoenix House.
Nice.
And the idea that individuals there are getting care and support, but also dignity by being a member of the clubhouse and being involved in the daily work of taking care of the clubhouse is just a beautiful experience. So let me hand it over to Dr. Petit to talk a little bit more about the model.
Yeah, again, thank you, Commissioner and Chair Lee. So clubhouses are truly an incredible system of care that exists within our city. They are member-led. They're really about creating community. They've been a mainstay for the last 50 plus years, really being able to offer employment, education, socialization, and just a sense of purpose and belonging. We had not looked at this portfolio for over 30 years. So in 2024, we really underwent a serious consideration, got a lot of input, from the community and from stakeholders to reprocure the whole portfolio. So now we have 13 clubhouses. Membership has been growing, which is what we wanted. We really want to expand the capacity, and it's growing month over month, and there still is capacity. So this is one of these programs that we have where there is room to continue to grow. So we certainly encourage any of you that know constituents that need these types of services to send them our way. We really want to continue to increase capacity. So again, it's an incredibly effective model. It's part of this continuum. It serves obviously a particular population. We're looking at continued expansion. The State Office of OASAS is looking at procuring for youth clubhouses. We support one of the LGBT Center's youth clubhouse that serves youth, which is really important, ages 13 to 22, and we provide a lot of technical assistance and support to them. So there's definitely an expansion that's underway.
And sorry, so what's the total budgeted amount for FY27?
Let me hand it to Aaron on that.
Sure. Yeah, it's 30.7 million starting in FY27.
Okay, so around the same. And I will say, and my next question is around the reprocurement to include some of the smaller clubhouses that was funded by the city council, because we put extra funding for that in. And at the time when the concept paper for the new RFP was out, there were a lot of us, including myself, that spoke to the former commissioner about the fact that a lot of these smaller clubhouses, and I know I'm preaching to the choir, even if they're smaller, like a lot of times people have been going there 15, 20 years, it's a family, it's their support network, their system. And so to disrupt that and say, hey, now you have to go here and this one's not going to be open, that's why I think on the council side, we felt very strongly we want to support with our funding to make them whole. But, and ideas like, hub and spoke model or subcontracting or allowing them to exist and then maybe be part of the larger clubhouse organizations and maybe include those numbers in there. So there were a lot of suggestions we had made, I think, at the time, and so just wanting to know if there is a consideration to do the reprocurement for the smaller ones.
Yeah, I can start this off. As you referenced, I wasn't here when those conversations were happening. I absolutely am committed to exploring this and figuring out if there are ways to do this in coordination with you and with city councilors across City Hall to make sure we get this right.
And will you be able to pick up the funding? That's probably a question for you.
I mean, I think we're always in conversations with our partners at City Hall and OMB.
Okay, we gotta advocate to do, well, I mean, obviously we'll do our part, and then I know Councilmember Brewer is very passionate about this as well, so we'll continue to advocate on our part. And will the Office of Community Safety have any role in the oversight of the mental health clubhouses? If so, what will that role be?
Yeah, thank you for that question, Chair. We've been at the work of community mental health for the last several decades here at the department, and from our standpoint, we're eager to work with anyone who's coming to the table with solutions and resources, and we're eager to work with the Office of Community Safety. I just spoke with the commissioner this week, and we've begun the process of beginning to lay the foundation of that work that we will share. At present, there's no plan to shift any of our current mental health services to the Office of Community Safety.
Okay. I'll go back to that in 1 second, but
Yep.
To your point, the state, going really quickly to the youth clubhouses, because the state budget proposed, as you mentioned, the 15 additional youth clubhouses. Are you going to be overseeing or managing any of those 15 youth clubhouses under DOHMH?
I don't think so. I don't think
so.
We may have to
okay.
circle back to. We typically do not. We have the clubhouses that are sort of our responsibility, but let's circle back to you with the details on that.
Okay. And then just staying on the topic of Office of Community Safety, it's a total funding of $269.6 million, and 126 budgeted positions were added. starting FY28 for the newly created Office of Community Safety. Are you anticipating any further funding transfers and program shifts? Because my understanding is that these are not new monies, so to speak, but it's already existing programs that are just sort of being restructured and reorganized. So if you could speak to the budget for that, that'd be great.
Yeah, I can speak to the component that is reflected within our work. The Office of Community Mental Health is moving completely over to the Office of Community Safety. This is an office that, on paper, the lines in the budget were associated with DOHMH, but we have not controlled those programs or those services at the Office of Community Mental Health. So that whole structure will now shift over to OCS. Let me hand it over to Aaron to see if he has anything else to add.
Yeah, and just to add, so in terms of the numbers, so that means, $3.2 million and 17 positions are moving as of FY28. But again, that's just related to the Office of Community.
Right, OCMH, right?
Yeah.
Okay, and how is this looking? Because I think a lot of us are still, I don't know, we've gotten mixed feedback, but it seems like most people are still sort of not 100% clear on how OCS is going to be sort of coexisting with a lot of the other city agencies that have pieces of the different portfolios that are now under them. And so just wondering if you sort of anticipate any funding transfers or, how it would support some of the DOHMH programs and how you would work with them.
Yeah, how it's going is we're eager to do this work with them, and ultimately we see that office and my counterpart commissioner as allies in doing this work together, and we're ready to roll up our sleeves and get to work. Specifically with regard to the mental health services, there's no plan to move those services to the Office of Community Safety that we currently run.
Okay, so we'll keep tabs on that as well, and if obviously you hear anything, if you could let us know as well, that'd be great. Okay, so I'll have one last question around school-based mental health clinics and then pass it on to our chair. For school-based mental health clinics, what was the FY27 and FY26 budgets, respectively?
Yeah, thank you very much for this question. The reality is that we are proud of our work that we do to help on technical assistance, quality assurance, helping to do the strategic placement of these schools, but ultimately these are state licensed and funded programs. And so, we'll have to defer some of the specifics around the funding to the state, unless, Aaron, you have anything.
Yeah, just to add, as the commissioner said, right, the funding for these does not flow through our budget, but the budget and contracts for some of them at least are administered through New York City Public Schools or independently.
Yeah, because I know when it first started, a lot of the feedback we had heard from the community, and especially the Article 31 clinics that are partnering with the schools, was the startup funding costs was so little. I think it was maybe $25,000 if I remember, which was not enough for them to get started and running. And so if you've heard any feedback from the providers on how it's going, that would be great if you could give us feedback on that. And I know that a lot of it is from Medicaid dollars with the reimbursement system. So how is that going to then be impacted, or have you had conversations with OMH on what that's going to look like on the school side? Because obviously the clinics are operated under the state, but then how that impacts the families if the state Medicaid money starts drying up or if it gets cut.
Yeah, or if people lose insurance and lose coverage.
Right.
Yeah, exactly. We can certainly follow up on that. I personally haven't had those conversations yet with the state, but certainly something that we're happy to partner with them on to try and mitigate the impact of that.
Okay, perfect. Okay, I'm going to pass it on to Chair Caban.
Thank you. I'm going to follow up on a couple of the things that you asked about, Chair. I have so many questions, but I'm going to try to be brief. I'm going to ask you all to be succinct where you can. Going back to the clubhouses, in terms of, I appreciate the really eager and sincere sort of response to be like, we want to work with you guys to make sure that we are keeping these smaller clubhouses running. But I want to know what that means. Like, have you guys asked OMB for this? Because that's probably one of the biggest roles that you're able to do here is saying, hey, we need this funding included in the adopted. So have you asked about that particularly?
Yeah, so let me share what we have done, and then I'll kick it to Dr. Petit to see if there's anything else to add. We have re-procured, as you know, the 13 clubhouses to make sure that we raise the standards and expand the capacity. That was done back in 2024. All 13 of those are now fully operational. The conversations, are ongoing with regard to what we can do with the remaining smaller clubhouses. But I'll pass it to Dr. Petit to see if he has anything else to add.
Yeah, thank you, Commissioner. I do want to reiterate that the whole purpose of the reprocurement was to really take in all of the feedback that we had gotten, some of our own understanding of how these clubhouses had been functioning up until that date, and really committed to this national clubhouse model, and really wanting to invest in the types of services that we really believe in, which are really grounded on quality of care and looking at metrics a little bit differently through some of these outcome measures like quality of life, loneliness, and employment. And what we are seeing is that we've made a significant impact in some of those measures, and we can definitely find ways of having further conversations.
No, and totally, I hear that. I get that the model is working. What I also want to make sure is that it is participant driven, and that probably the most important thing that we could listen to are participants saying that they want to stay where they are. And I want to move on just because I know that you put this on the record already, and colleagues want to ask questions too. But the other follow-up I had, two more follow-ups that I have on the chair's question, is on the youth clubhouses. Just can you tell us? I know it's 13 at the state. Is that the number that they just added money for?
Oh, for the youth?
Yeah. Was it 15? 15. Do you know how much money that is? And also, is the city asking for a portion of that pot of money to come directly to the city?
I'm going to pass it to Jamie Nichols to talk about the program a little bit more. In terms of the budget, we can circle back on that.
I'm going to pass it again because Bertie just whispered in my ear that this is...
These are Oasis clubhouses.
Yeah.
So it's a great model. So what they've done is across the state, there's 9 recovery clubhouses in New York City. That's where the OSF funding went for additional peers. They are expanding it so that now clubhouses or recovery centers will be able to serve youth as well. So really excited about it. I work really closely with the Oasis folks. It's not a city investment, but it'll definitely benefit so many New Yorkers.
So it's not a city. We're not going to see any of that added funding for New York City residents.
It's going to be from the state, but for all the 9 clubhouses in New York City, they're going to be eligible to go for those dollars so that they can expand services.
Yeah, I guess that's my question. Is like how much of that money may we see?
We can follow up with the RFP.
Yeah.
I mean, it's on the Oasis website, but yeah, we could share.
Great. And then on the Office of Community Safety, you mentioned that the Office of Community Mental Health is going to be under this office. What I want to know is, oftentimes we do hearings and the Office of Community Health doesn't want to come because they're like, we're just a coordinating agency and we can't really speak to a lot of these different things. So if this coordinating office, this coordinating body is coming into the Office of Community Safety, are they going to be tasked with expanding their coordination or something? Like, will they be designated the coordinating, office for everything that's put under the Office of Community Safety? Like we are all still super unclear on what the organizational structure is, and if the Office of Community Mental Health is just a coordinating agency, what role are they playing being put into? Is the coordinating agency going to be coordinating with another coordinating agent? Like, what are we doing here?
Yeah. Well, let me simplify for the parts that we own. So we are the local governmental unit, which is decreed by state law. That means that we coordinate mental health activities and mental health treatment for the city. So that part is clear, and that part is not changing. In terms of what the Office of Community Safety will do, we're going to have to get back to you with some details on that, as things are still very much in the early stages now. So at the moment, you can expect us to continue to be the coordinating agency with regard to mental health care in the city.
Another question I have is also, we didn't see this in the briefings that we got on the office, but one glaring absence, I think, in what was being considered as sort of within the scope of work of this office was harm reduction. And it didn't really make sense to me that that was something that wasn't being included in the office. So I would like to know what those conversations have been like. Are y'all pushing to have harm reduction work integrated into the Office of Community Safety?
Yeah, I can maybe just kick things off and hand it over to Dr. Petit. You know, from our perspective, you know, the work of harm reduction is a key core function of what we do at the Department of Mental Health, Department of Health and Mental Hygiene, and that's not going to change. We don't have any current plans to stop doing that harm reduction work.
Okay.
Yeah, thank you for that.
That's what I find concerning, because it's literally not in the model that that has been proposed to us. So if that's, yeah.
Right. I just wanted to put a finer point on
Yeah.
sort of our role as a local government unit. We have, you know, responsibility for overseeing planning and funding mental health, substance use, and developmental disabilities. This is through state, you know, mental hygiene law 9 and 41. So our true responsibility is to ensure
Okay.
that, you know,
Yeah.
in New York City, that all those services are coordinated and planned for accordingly based on need. So we will continue to do that as the Executive Deputy Commissioner. That is my primary
Right.
responsibility, to make sure that
Yeah, I mean, I would hope to see some updated sort of metrics and goals that include harm reduction, because those metrics and goals have been shared with us and exist across these different areas, but not on that front. So that's helpful. The last thing I'll say on the Office of Community Safety is I think we're all a little bit concerned about how it's coming together. We found out, I think earlier in the week or last week, that NYPD had their first conversation with, you know, this division, and, you know, talking to officers around the country. And the conversation with NYPD, those are the first ones. Like, it's only successful when they're at the table in the beginning. So just hoping that there can be more coordination on that front. And I know that that's not you guys, but I want to go to mobile treatment teams. The exec plan, it includes baseline funding for $47.3 million starting in fiscal year 27 to address a funding cliff for mobile treatment teams. So my understanding, my reading of the proposed exec budget is that there are not operational expansions associated with funding. It's just addressing federal cuts. So it's not like an investment above what we have been doing. And obviously, we're interested in seeing the admin expand mobile treatment teams because there's a growing need, but also there has been an existing wait list that we would like to clear. So is DOHMH planning any operational expansions for mobile treatment teams in FY27?
Yeah, thank you again, Chair, for that question. It's incredibly important we get this right on mobile treatment. Since 2016, so about 10 years now, we have doubled the mobile treatment capacity in this city. We know that that's just the, scratching the surface. There's much more work to do on this. I'm going to hand it to Aaron to talk a little bit more about the budget here.
Yeah, I just wanted to echo Chair Caban that's correct. Your reading is correct about the 47.3.
And just to interject for a second, we may have doubled the capacity, but also we're seeing, and this is why there should be coordination, we're also seeing a vast increase in what we call broken windows policing or low-level offenses, and a lot of these folks that are getting picked up on those kinds of offenses and then finding their way to Rikers Island are people living with a mental health diagnosis. So we have like some cross-competing outcomes where like you may be expanding capacity, but then we're doing harm on the other end. So yeah, if you could continue.
Yeah, no, I'll leave it to others to talk about any potential future plans, but just to say yes, it stabilizes the funding that had been covered by expired federal stimulus dollars.
And are you looking on adding on top of that?
I mean, I think we're always thinking about what the resource needs are for the agency, but from a programmatic perspective, I'll leave it to others.
So what, in terms of what is the total funding allocated for IMT and ACT in the executive budget? And then just to break that down a little bit, what's coming in from the state, and whatever's coming in from the state, will that get used towards new contracts, or that's just to keep the status quo of what we've got right now?
I'm going to hand it to Aaron to talk about the budget here.
Yeah, so thanks. So putting aside the one-time funding from FY26, this is the partnership between the admin and the council. So the CTL budget is baselined at 20.5.
Which we should probably baseline, I think.
So the current CTL budget, aside from that anyway, is 20.5 for ACT, 4 million for FACT, and 44.3 million for IMT.
Okay. And how much of that is coming in from the state?
I can get back to you probably shortly with a specific breakdown.
Okay, thank you. How many people are currently on the citywide ACT and IMT wait lists?
Let me hand it to Assistant Commissioner Jamie Nichols for that.
Thanks. So we get about 5,000 referrals a year to our adult single point of access.
Yeah.
Everybody who's referred is offered a care coordinator. I'm happy to say that we have capacity in care coordination. Those folks go out and visit with people proactively wherever they are in the community, help them find or stay connected to treatment and benefits and address housing and things like that. Some people, that's sufficient. The care coordination is what they want, and they stay there, and they go to clinics or other places to get their treatment.
And I know we got this information on the prelim budget. Again, I just want to move to what currently is the wait list. And I understand also some people qualify for both, and so that kind of complicates the numbers. But again, I just want to. I'm trying to help our team stay on time.
Yep. We've got 600 people waiting for IMT, 200 for FACT, 367 for ACT, and 87 for SPACT.
Okay.
Right, those change daily, right? Assignments are made. People are connected, probably 80, 90 people a week are connected to these programs newly as other people transition off. So it's very dynamic.
Yeah. But still, even with the dynamic nature of it, that's a significant need. Like, what are the resources needed to clear the wait list?
Yeah, so I think, as the commissioner mentioned, we've doubled mobile treatment capacity over the last 10 years, and yet wait lists have persisted in that time. So obviously, it's not simply as straightforward, just adding teams, eliminating the wait list, because there's other pressures on the system. We're focused on offering additional resources for people to step down from these services into other longer-term treatment arrangements. So we have our Connect Clinic enhancement model, which demonstration project has been going really well, handling step-downs. We have Flex Act teams, which provide have larger capacity state caseloads. Those are RFP'd by the state, but those services flow through us. And so we think those step-down resources can allow us to use the existing mobile treatment capacity more efficiently.
And I'm going to apologize to my, oh wait, he's not here. Okay, so I'm not taking his question. But to that point though, right, on the mobile treatment teams, the city approved $4.5 million to create the STEPS pilot and $11 million for the IMT providers in FY26. But those funding streams haven't been released. And so I guess my question even to that is, like as of now, providers haven't been able to apply for that funding. So is that funding approval, like when is that approval going to come through so that they can do that?
I'm going to pass to Aaron.
Yeah, so first, just to circle back on your question about the funding. So for mobile treatment, it's about $12 million from the state, and just pointing out that IMT is fully city funded.
Okay, that's right, because it's not Medicaid reimbursable, right?
Right.
Yeah.
In terms of the one-time funding for the 4.5 for ACT and the 11 million for IMT, the administration I know is continuing the conversations with council, so on that piece we have to defer to City Hall and OMB.
Yeah, I mean, the funding's only as good as it is whether it gets out the door or not. So, yeah. Yeah. Okay. I again would love to see a push to add. There's definitely a need to clear these wait lists again at a time where we're seeing more and more people be criminalized under the same environment administration who are living with mental health diagnoses and don't have like a good continuum of care in place. Will the Office of Community Safety have any role in the oversight of the mobile treatment teams? Do you know?
At present, there are no plans for us to have them oversee our teams.
And also, I just want to go back for a second. On the wait list data, would you guys consider publishing the data quarterly? You said it's dynamic, it changes, but would you guys be willing to publish that?
I think we're open to having the conversation with you, Chair, and exploring what's possible there.
And does anybody want to add?
I think it's important to think about that. We're open to it. We're also concerned that referral sources may not make referrals if they see the wait list. And the truth is, we're reviewing every application for a variety of clinical risk factors, and so we're prioritizing higher risk applicants, and we don't want to discourage people
I
from
mean,
making
I don't know.
referrals.
I guess, is that a direct conversation you've had with referring organizations? Because I don't know that that's the approach that they would take, and I think just everybody having this information is super helpful. I mean, it also would make it so that, you know, one of us doesn't have to call you guys and like then get follow-up from somebody else to get the information if we know that we can just like access it in a place and talk to our partners about it. So I might suggest maybe rethinking that, especially if organizations haven't said that that's how they would react to having to being able to see the wait list. They know the wait list is there. Believe me, they know. They just want to know how deep it is, because it helps them in their advocacy, right? Like they want to be able to make accurate asks of us, of you guys, and I think that information is helpful. Okay. I'm going to move on to one more piece here, and then I'll go to colleagues. I have more questions, but I want colleagues to be able to ask questions. So the Campaign to Close Rikers, they requested $1.7 million to establish an outpatient competency restoration pilot for 50 to 75 people who might otherwise be waiting at Rikers for transfer to a state hospital. So is DOHMH working with the State Office of Mental Health to develop an outpatient competency restoration program? And has the city committed any funding for a program like that?
Great. I'm going to pass to Dr. Petit for more on this.
Yeah, thank you for that question. Well, we have not had conversations with OMH. Certainly, competency restoration is a significant issue that needs to be addressed, head on. I've seen this across the country in terms of individuals that sometimes languish in prisons and jails, waiting on competency restoration. So, even though we have not had those conversations, I'm more than eager to, engage and have further deliberations around what or how do we deal with this issue.
I will say that I represent, I mean, this is just one example, but I saw it all the time as a public defender. I represented an individual that was charged with a Berg 2 because, the accusation of stealing a piece of luggage from an apartment building lobby is considered a violent felony because it's in a dwelling technically. So was facing upstate prison time, was found to be incompetent because it's a felony and not a misdemeanor. And they wouldn't make him an offer because of course his mental health issues meant that he had a long rap sheet. And it was like several years before he was deemed competent to go to trial just to get an acquittal at trial. And so like, just to put this into context about how, important this is, people who have been found not competent to stand trial, they're obviously most in need of mental health treatment. That's just one example of somebody languishing at Rikers awaiting a bed, for example. So what's DOHMH doing to serve this population?
Specifically with competency restoration, is that objective? Pass it back to Dr. Petit here.
Yeah, I mean, and again, 2 months in, so I'm not 100% of everything that we do within the division, but certainly within our Bureau of Justice Impacted populations, we have a number of initiatives. We have a health justice network that sort of coordinates, peer activities, in individuals that are coming out of prisons. I can certainly look into this a little bit more and get back to you on what in particular we're doing around competency restoration, but certainly an area that I am well aware of as being something that we probably should be focusing a little more attention on.
Thank you. Yeah, we can turn to the call. I have a lot more questions, but.
Okay, we're going to start with Councilmember Wong, followed by Ressler.
Thank you, Chair. My predecessor, Councilman Robert Holden, spent years asking for basic transparency on Kendra's law petitions, and I intend to continue that work. The question is simple. How many assisted outpatient treatment petitions, AOT petitions, were filed in New York City in FY25? How many were approved? How many were denied? And what are the numbers of Queens specifically, broken down by borough? There is a Queens AOT team. I want to know whether it's being used, by whom, how often, and with what results. City agencies, NYPD, DHS, H&H can file petitions. Which agencies are actually doing so and how often? Please answer that.
Thank you, Councilmember. First of all, absolutely agree. And the service that we provide with AOT promotes engagement in mental health services for individuals who have had histories of multiple hospitalizations due to harm and who and have had treatment non-adherence. And so AOT provides an extra level of care. To your question directly, in FY25, we monitored about 2,800, so 2,834 individuals. And to go a little bit deeper, I'm going to hand it over to Assistant Commissioner Jamie Nichols.
Yeah, thanks. We've got a lot of experience in assisted outpatient treatment. We've been doing it since 1999 and use it, I think, more than every state in the country in terms of the scope of our program here in New York City. The lawyers and psychiatrists that do the petitions are really experienced and very rarely is a petition ever denied. I don't have the numbers now, but I can tell you it's a very infrequent occurrence.
Thank you. This data should not be hard to produce, and I don't understand why it hasn't been consistently reported to the council. Is it something you could do in the future?
Yeah, we can point you. The State Office of Mental Health has a dynamic dashboard on their website with all of the petitions and court orders that have ever been filed since the program's inception. And we can point you to that information, and it's broken down by borough.
Okay, I'll provide my contact info later, and
Great.
then you can reach that, send that to me. Thank you. Thank you, Chair.
Thank you. Oh, yeah. And we've been joined by Council Members Felder and P. Sanchez on Zoom, and wanted to pass it on to Councilmember Ressler.
Thank you very much, Chair Lee and Chair Caban. You know, I've been giving Chair Lee shout-outs at every one of these hearings for her endurance, but I feel like Brian doesn't get enough attention and love. So I want to thank Brian for being here at every single one of these hearings, too. It's been a marathon. Okay. Commissioner already heard my first question, but I'm going to repeat it again. I'll do it briefly. 465 vacant supportive housing units without a referral in process that are under DOHMH purview, according to the most recent report that was provided to our office earlier this year. Recognizing that OMH is doing a far worse job, I'll just say that you're not the worst actor out there, but it's still too many vacant units and it's unacceptable. So can you give us a breakdown of why these units are vacant without a referral in process? Do they need significant repairs? What are the investments that we can make that we'll see more of those units activated over the course of FY27?
Thank you for the question. Let me hand it over to Assistant Commissioner Jamie Nichols.
Yeah, so we've got over 13,300 units of permanent, affordable, supportive housing in our contract portfolio. The last quarterly report from Local Law 135 showed that we had 104 of those units were vacant with no referral. So that's a bit lower than the number you cited. 523 are vacant with a referral in process. That means a person has seen the apartment and said, yes, I want to move in, and they're in the process of getting tax credit documentation and the move-in, right, which takes a little bit of time. So I think our vacancy rate is pretty good. There's some offline units, 376 as of that last quarterly report are offline. Typically, there's two main drivers of that. One is serious repairs are needed, so those are being done. The second is that the prior tenant deceased in the unit and it is sealed. That's a really challenging issue. We're really glad the mayor's housing plan identified a number of initiatives to improve housing and reduce vacancies, and they're really going to be helping us focus on the sealed unit issue.
Okay, so of the 370 odd that are offline, there's a resource need on the repairs to see those units brought back online? Do you have an estimate of what that would cost to see those units brought back into your portfolio and activated?
I don't have an estimate at this point. That's changing all the time, right? New units, this is every day the numbers are a little bit different. So a unit that's being repaired today will be available for move-in tomorrow. Those are not long-term same units vacant. The providers do have some money in their budgets for repairs, and they do that, and the landlords as well will pay for those repairs. So that's not a budget number that's visible to us.
Okay. I mean, I'm looking at the last report that I'm seeing, which is listing 465 as either offline plus no referral. So I do want to dig into this data. We'll follow up with you directly. So we're concerned about just making sure we have the correct understanding of where we are. And then I just want to take a moment to also ask about our challenges in coordinating with the Department of Health and Mental Hygiene regarding constituents with severe mental health issues. There is, when we reach out, there is, I would describe it as very limited assistance is provided. We're told to call for a mobile crisis team, which maybe tries to visit once, then there's no follow-up. The Department of Health will not engage with us or provide any updates or solutions that may have been provided to the individual who we're calling about. The individuals continue to endanger their own safety and safety of members of our community. It happens again and again and again, and I don't, at this point, I don't even think it's worth calling the Department of Health. It doesn't help. It makes no difference. So I'm just trying to figure out how can we partner more effectively. We have an individual with severe mental health challenges screaming in a park for hours every day for now 2 years. It's been a daily, almost probably 5 days a week, hours on end, often drunk, screams nasty, threatening things at neighbors. I just like, what are we, is DOHMH able to help on a situation like that? Because we haven't gotten any help yet.
Let me ask just a follow-up question, Councilmember. Is this for individuals who are slotted for supportive housing, or are these individuals?
No. These are just people who are struggling with mental illness around my community who are causing serious issues. And
makes sense.
I get no help. I mean, I try. I call everyone I can in the agency. It doesn't make a difference. I get no help. And this has been the case for years. And I just am so frustrated and disappointed that it's like, it feels like I have to take the health department off as one of the resources to go to because it doesn't yield to outcomes. It doesn't actually make a difference, and I certainly get no updates because we get nothing is shared with me. So it's just deeply, deeply frustrating. And is there any, in that example, is there anything the health department can do to help?
Yeah, first of all, I hear you, we hear you, and thank you for flagging this. Moving forward, this is the kind of work that we're trying to, in an interagency way with OCS, really be able to address, and so we're eager to try to do some problem solving around this. Let me see if, Jamie, do you have anything else you want to add?
Yeah, I'm sorry you feel that way. It's frustrating on our side too, because there's a lot that we do, but we can't share a person's protected health information back with you. So we really appreciate the referrals and the situations that you bring to our attention. We act on them. I know that. I see the information. But we can't talk about a person's treatment plan with a third party.
I totally understand their HIPAA restrictions, but we don't see any improvement on the ground. Like, we don't see change. We don't, without getting into specifics about somebody's exact treatment plan, I don't need to know that information. I do want to know we're actively engaging with this person, we've been connecting them to help, we're involved, that we're making a difference, that we're in a sustained way continuing to engage here, like anything, so that we can come back to our constituents and say, hey, we're trying, the health department's engaged, we're doing something. And I just get a brick wall and I see no difference in the outcomes. So it just feels like nothing's happening and I can't see the result. So I don't advocate for these things. I don't even call anymore because I honestly feel like, what's the point? Last up, you just spoke to the coordination with the Office of Community Safety. Have you met with the deputy mayor?
I've met with my counterpart, with the commissioner, yeah.
The commissioner, there's the deputy mayor, you mean?
There's a deputy mayor, and then there's a newly appointed commissioner, Aisha Delaney-Brumsfeld. Yeah.
Oh, okay, great.
Our deputy mayors have met, so at a level higher than mine. My deputy mayor has met with that deputy mayor, but I correspond with
I think just after the public safety hearing at the beginning of the week, we wanted to make sure that somebody's talking to the Office of Community Safety.
Absolutely.
So, thank you.
Yep.
Thank you. I just want to kind of reiterate Councilmember Ressler's concerns again. As somebody who actively worked navigating the space between like confidentiality, HIPAA, and all those things, I think there is information that could be shared about progress that doesn't violate HIPAA that would be helpful to our offices. I also, Councilmember Ressler, I wanted to give you a quick opportunity. If you had any other questions on supportive housing vacancies, you can ask them, because I was going to ask them anyway, if you want to take a second to do that.
Yeah. Go ahead. I'm just going to dig in on the data that you left.
Okay. I guess we'll go over to Councilmember Aldewall then.
Thank you, chairs, and thank you, Commissioner. I do have a question about headcount. Your reduction of 33 vacant positions, and how long have these positions been vacant? And are they tied to specific mental health programs?
Thank you for that question, Councilmember. All of the headcount targets that we identified were targets that were not highly necessary, were not necessary for executing the functions that we have across our agency. And so those headcount reductions are not affecting any of our ability to do the work that we do in the Division of Mental Hygiene. I'll hand it to Aaron to share more.
Yeah, thank you for the question. I mean, as I've said before, like these are always difficult exercises to do when you're trying to find savings, as every other city agency was asked to do. But our guiding principle was really that certainly it not impact services, but also that we look at the longest, vacancies that have been out there the longest, vacancies that do not impact direct services. And, it's hard to do, but, the types of positions we ended up looking at for this were things like more back office functions, right? Like a data analyst or an office manager. So it's spread across. There's not a single area where they're sort of clustered, but we looked across the whole agency and including within mental hygiene across the division. So.
Were any of the positions like hard to fill positions, and what has been your strategy, or what is your strategy moving forward to fill positions that have been, historically hard to fill, or where there's high turnover?
I can speak a little bit to that. We're doing many different things to try and get folks through the door, and also to retain them once they're part of the health department team. A couple of things that we're doing are really targeted interventions on social media, believe it or not, to really get this, get some of these job postings in front of individuals. I, in fact, recently was part of a social media push to help people come into the health department to fill some of the hardest to fill roles. I'll tell you another example. We're currently exploring partnerships with academic institutions, with universities, to be able to provide a sort of a foot in the door for some of these hard to fill roles, so that a student can come into the health department as an intern and then potentially be brought on as a full-time staffer. So we're trying to be creative about this. We also want to continue to shout it from the rooftops. We're hiring and we want folks to apply.
How often do you look at your vacancies and your turnover rates, and how is that impacting the services that you're providing?
I'm going to hand it to Aaron for this one.
Yeah, I mean, I think we're continually looking at them is the short answer. We have really re-upped recruitment efforts. I mean, I think all these creative ways, in addition to the usual ways, partnering with DCAS, hosting career fairs, things like that. I think one positive statistic is that I think it was 2 years ago, starting in 2024, we actually was the first time since the height of the pandemic where we actually saw more people coming into the agency than leaving. And that trend has continued for the last couple of years. So I think we're making headway for sure.
That's good to hear.
and we're additionally applying these creative ways. I mean, see the Instagram campaigns, right?
I think that there's long been sort of a reluctance for young folks to, apply for or work in city government. I think we're beginning to see a change. People are understanding that city services and city government can work for people and make an impact in their lives. And we're hoping to see that, the hiring patterns change in accordance with that.
Thank you.
Okay, great. I was going to say, I keep saying Commissioner Caban, sorry. Chair Caban.
I want to follow up on some of Councilmember Ressler's questions. The mayor recently released the block by block housing report, and it details also some things around the administration convening an internal working group with DOHMH and DSS and HPD to improve the application and placement process for supportive housing, with the goal of reducing that vacancy, the supportive housing vacancy, to 5% by the end of 2026. Can you tell me like what's DOHMH's contribution to that working group is? Like how many employees are dedicated to this group? What specifics are being discussed to improve and expedite the application and placement process for supportive housing?
Yeah, thank you for this question, Chair. So we are indeed part of this interagency working group with us, with HPD, DSS, and you're exactly right, targeting a 5% vacancy rate by the end of this year. The two things that we're trying to do together across these three agencies are, number one, faster unsealing, and then the second is to try to reduce the documentation burden. We shouldn't let paperwork stand in the way of somebody getting into a home that is available for them. Let me hand it over to Commissioner Jamie Nichols to share a little bit more about the working group.
Yeah, would love to know, what the personnel allocation is and
Yep.
yeah.
We've got 3 staff in the work group.
Okay. And do you think that the city is on track to, based on what you're seeing so far, to reduce the supportive housing vacancy rate to that 5% by the end of the year?
Yes, I do.
That's great. Will additional funding be allocated to DOHMH for supportive housing in fiscal years 27 to 28? And if so, how much? Obviously, we're talking about getting that vacancy rate down to 5% by the end of the year, but I'm assuming the goal is to get to that 0 vacancy rate. And so what are the plans for beyond 2026? So 27 to 28, are you anticipating extra funding there?
Yeah, so I don't think the vacancy work is necessarily a funding question. Otherwise, I'd turn it to Aaron here. I wouldn't answer. I think it's really about the things that the commissioner mentioned, right? Unsealing apartments, reducing paperwork burden. There's no, a cost associated with that. No new cost. We are adding supportive houses units all the time. We added, 700 since last year. Our MMR target is to get up to 14,000 by next fiscal year. So the budget is always growing because we're always adding new units thanks to the open RFP. We do, I just want to make a point about the vacancy rate. I think a healthy system has vacancies as people are moving out and moving in, right? Not everybody stays forever. So the goal is not to get it to 0. I think the goal is to get, I think we're at a
Or I guess
level.
a better way to say it is the goal is to get anybody who is eligible for and needs supportive housing into a unit.
Sure, and I think that's a development question. We also want to get make use of vacancies, but we need more apartments.
Yeah. So I want to talk a little bit about evictions in the supportive housing space. You guys oversee thousands of these units. Can you estimate the number of eviction cases brought against supportive housing tenants in DOHMH funded units every year?
So let me just say a few words at the top there, and that is that we're focused in this agency on helping to address the challenge of eviction in this city and making sure that any individual who is facing an eviction has the right to right to counsel, as we are a right to counsel city, as we passed in 2017.
We need more money for that too.
That's right.
Yeah.
We remain committed to the work of managing this process in a fair way and in a comprehensive way. So let me hand it to Jamie to share a little bit more.
I think we're committed to limiting getting as close to 0 as possible for evictions from supportive housing. The purpose is to house people, and that's our goal. We track the discharges that are related to evictions. We've always tracked that. Number is very low. There were 55 last fiscal year out of, at that time, 12,800 units at the end of last fiscal year. So we'll keep an eye on that. We issued some housing stability and eviction prevention guidance in April of this year, and a part of that was adding some new data elements to our data system to track the filing of cases, which is, I think, what you asked about, which we didn't have a data point about that. So we've been training providers on that since April, and the data collection will begin in July for the next fiscal
and noted
year.
that you're ramping up sort of the data collection. Would you, so it's, if there's the 55 units, estimating per year, do you have any numbers on how many of, like, say, that 55 have been non-payments and how many have been holdovers, for example?
Yeah, so that's we don't have that now. We will
Okay.
have that. That is
Great.
one of the pieces of information we're collecting.
Heard, understood. This is a process question. So when you find out that a supportive housing tenant is being evicted on a non-payment case, like what's the agency response? What are the steps?
Yeah, so I think this is outlined in our eviction prevention guidance, right, which is to service providers around the steps we expect them to take to help tenants to understand, is this about a benefit issue, a budgeting issue, a behavioral health issue, what are the matters? And so our service providers are contracted to help tenants meet their responsibilities and assert their rights as tenants. So it depends on the individual situation and what's driving the arrears.
Okay. So would it be correct to say just like DOHMH specific role in terms of the guidance as you help put it together and inform kind of what went into the guidance? Obviously, you have housing lawyers and things also contributing to the guidance. Does that sound more or less accurate?
So our guidance is to the service providers. We're not, there's housing court and lawyer, we're not.
Yeah, but I mean, obviously
the
the
legal
guidance
matters.
includes housing, the basic housing and tenant law in it. And I'm just wondering if like, what's DOHMH's contribution to the guidance? Is that about sort of the service provisions and what can help somebody get back on track if they're in arrears? Like what's the involvement?
So we wrote the guidance. It's our guidance. It's 100% us, and the guidance.
Great.
Yeah.
I could have asked that a lot more simply. I apologize. We've been doing a lot of these hearings, but thank you. Thank you for bearing with me. I want to move to the relay program. The executive plan included a baseline reduction of $2 million starting in FY26 for the relay program to eliminate spending on phones and monetary incentives for participation, like gift cards and things. And I'm concerned about this. I want to know what the rationale is choosing this area for savings and why this is a benefit that's being cut off. And I'm going to give an example again. I come from the public defense world, so this is the easiest example. When they provided clients with cell phones, the warrant rates dropped exponentially by just simply sending a text message to our clients about when they had to come back to court. Like this is really, I think, a really, really critical thing. Cell phones, they keep people engaged. They allow service providers to be proactively connected with clients. So I'm just wondering what the rationale was for that $2 million cut.
Yeah, thank you for that question, Chair Caban. First of all, let me just say a few words about the Relay Program. This is a program that is a wonder, really. Myself as an ER physician, having a patient who wakes up from a non-fatal overdose, having appeared there to help them, track the course to recovery is just an incredible intervention. We've been able to contract with over a dozen hospitals and emergency departments to expand this program. The savings that you're seeing is not a cut to the staff or any of the people that are involved. And so we thought it was important to make sure that, in order to execute this program, that no staff that provide the services were a part of that savings.
But there are tools that are critical. Like I understand that you're not cutting any staff, but it is eliminating spending on, like I said, phones or other things that have been shown to sort of help with participation and continuity of care. So just, again, hoping for the rationale behind the decision to cut back on that.
Yeah. Maybe I can kick it over to Dr. Rebecca Lynn-Wall.
Sure, yeah. So the cut was to an enhancement to existing. We certainly do gift cards. We have an amazing storage system that I've gone through in our building with how to find that. So we certainly absolutely support it. And so we already do gift cards. We do work with people on their phone and how to follow up with them and make sure that we do have ways to connect with them, talk to, if they're already talking to like homeless services, how do we engage their case manager there? So this was just something that was supposed to start. We hadn't yet.
Oh, okay. So do you currently spend on phones for participants in the Relay program?
We don't have phones, but we do the gift card to enhance people being able to follow.
Okay, got it.
So basically, hear you 100% on the evidence. We're not taking away the phones. We would start the phone program, but we chose to not start it. So.
I think we should. I think we should be doing it. And probably, giving phones to people is also probably cheaper than having more people to send out to go find them not quite knowing where to locate them, for example. So I just, yeah, I'm a little concerned about that. But what's the contracted budget for the relay program? I think that was mentioned, but how many contracts does it fund, and who are the service providers under those contracts?
Yeah, thank you for that question, Chair. We have a total of 13 emergency departments that we're currently contracting with. We can get you the full list in a follow-up.
Great, thank you. I'm going to move over to JISH. The total budget for JISH for FY26 and 27.
FY26 total budget is 10.4 million, and FY27 is 8.3 million. You know, this is an incredibly important program. As you know, Chair, being able to provide this service for someone who's recently incarcerated, it could literally mean the difference between life and death. So it's a program that we take very seriously.
How many JISH units are currently in operation, and like, do you have the breakdown by borough?
Yeah, we currently have 120 operational now. I'm going to hand it over to Jamie Nichols to share more.
Yeah, those 120 units are spread across the Bronx, Brooklyn, and Manhattan. They're all scattered site units, so the exact location may change a little bit.
Yeah.
So I don't have the split between each borough.
Okay, we'd love to know what the split is between each borough, and then, you know, the goal that y'all have stated is to reach 350 units eventually. So what's the timeline of reaching that, do you think? And how much money do you need to reach it?
Let me hand it to Jamie.
Yeah, so just this past February, we amended the open RFP to add additional funding, so thank you. We're excited about that. The proposals are coming in. We opened up the RFP for scattered as well as congregate, so we won't know the timeline for construction until we've reviewed the proposals, made the awards, and it, you know, moves further along in the finance.
A while from now.
Yeah.
Got it. Do the contract savings in the exec plan include any JISH contracts that you're aware of?
Well,
No?
hand it to Aaron. Not to my knowledge. Let me hand it to Aaron.
The question was, are there any cuts to contracts?
Yeah, like, you know, there's a bunch of contract savings in the executive budget, and just wondering if any of those include any JISH contracts.
Oh, no, JISH is not a part of our savings.
Okay,
Yeah.
got it. Thank you. Just give me a moment here. I just want to see if I have anything left on this. Oh, so you mentioned the JISH RFP, which excited that it was reissued. The RFP is for that 190 units. Some of that will be for the Just Home project, right? Like, I think it's 58 of the 83 are for the Just Home. That's still, yeah, the math, I guess I'm a little bit confused about the math. If we've got that, we understand that some of the JISH funding will be used for 58 of the 83 units that are part of Just Home. That would still seem to leave funding available for 322 units, which is 132 units more than the RFP included. So can you clarify why the unit count was reduced, and was any of the portion of the originally allocated JISH funding redirected for other purposes?
We'll hand it to Jamie for more.
No funds were redirected. The health department put all of the available funds into raising the rates for the existing 120 units, as well as any new units awarded through the amended RFP. So the higher rates per unit is the reason why we have fewer units overall.
Okay, so that has to do with sort of like the fair market, like, that has to do with the market?
Yep, exactly.
Okay, got it. Will the Office of Community Safety have any role in the administration of JISH? That's my last question on that piece, but.
At present, there are no plans to have the Office of Community Safety do anything with JISH.
I just want to look here to see. Yeah, I think I am done on the mental health. So, Councilmember Brewer, do you have questions? Okay, go for it.
I love Ricky Wong. That's number one.
I know. Oh my God, we always call out Ricky Wong.
I like him better than I like everybody else. Just so you know.
We won't take it personally.
No.
You got some fans.
My question is just on the child care, and I'm late. I was with DOT on a walking around for the 72nd Street bike lane. That was lovely. My question is, when you close it, you know, for legitimate reasons, a child care center because of whatever reason, does it depend how long the situation will mandate, I suppose, how long it takes to reopen. Hopefully they are responsive to the criteria that Department of Health brought to their attention. But meanwhile, of course, the parents are not able to find other childcare, so on. What's a general time frame? Could it be sped up? What are some of the hindrances to reopening up a childcare center? Depending, I know, on the issues. I understand that.
Yeah, thank you so much for that question, Councilmember. You know, it's a balance, right? We're trying to do two things at once. One is keep kids safe, and if a child care center is out of compliance, we do need to take action.
Right.
And the second is not disrupt the community of families that depend on that center. And so this is sometimes more art than science, and so we are aware of the fact that sometimes it does take longer than parents would like. So we're going to work hard on trying to, again, balance those two, needs and get that wait time to be as short as possible.
Okay. I mean, that would be helpful. I think communication with the parents is also helpful. That would perhaps be improved. I'm doing it, but I think it would be good for DOH to do it also.
Yeah.
Right. Thank
We
you.
hear you. Yep.
You got Ricky, so you got no problems.
Sorry. We've been joined by Councilmember Narcisse as well as Councilmember Brewer. And I think for round two, quickly, we're going to go, wait, Councilmember, did you have a question? No? Okay. I think for round two, quickly, we're going to go with Councilmember Wong, followed by Ressler.
Thank you, Chair. Regarding the Office of Community Safety, okay, the executive plan includes a baseline transfer of 3.2 million city funding, 17 budgeted positions starting in fiscal 28 from DOHMH to OCS. That's clear. But my question is, the Office of Community Safety launched on March 19th with 260 million and 2 staffers. And the FY27 executive plan brings that to 270 million. So my question is, what has the Office of Community Safety actually done since March 19th? Can you answer that?
Thank you very much for that question, Councilmember. We're going to defer questions on the Office of Community Safety with regard to what they've been doing in actions to that office. What I can tell you is, from our standpoint, we've already begun doing the work of talking with them and figuring out how to synergize our efforts, and so we know that they're hard at work trying to figure this out behind the scenes.
Yeah. What programs are operating under it today that were not operating before? And how is it different from Thrive NYC? Like so much money was spent, and then there's very little got accomplished. Please answer that.
Yeah. Do you mean for Office of Community Mental Health or Office of Community Safety?
Yeah, Community Safety. Yeah.
Okay, got it. The details and sort of the programming, I'm going to have to leave to that office and leadership there. However, we do know a couple of very important things. The Be Heard program will be completely, operated by that office, and we look forward to working with the leadership of that office to make sure that program is as successful as it can be.
Yeah. Okay. Well, I'm not opposed to the concept, but 270 million with no defined operational model is not a mental health program. It's just a press release. Thank you. Thank you, Chair.
Okay. Councilmember Ressler.
Great, thank you so much. I want to apologize. I was looking at the report from November, and in fact, the most recent report is from April 30th. So just to go through it, in November, there was a combined 465 units that were offline or online with no referral in process. As of April 30th, there's 486 units that are either offline, supportive housing units under DOHMH's control, that are either offline or with no referral in process. So let's try again on those. So for the 381 that are currently offline, do you have an average cost of repair to bring that unit back online? I recognize it's a fluid dynamic. I recognize that things are changing, but just so that we could try to ballpark some resources to invest to help bring those units online, because I think we all want to see every one of those units online, right?
Sure. Thank you, Jamie.
What would,
Yes.
do you have a ballpark estimate per unit for the renovation costs?
I don't have that information.
Can you provide that to us?
The repair, the majority, I don't know if I can, the majority of repair costs would be borne by the landlord. Our relationship is with the service provider. Sometimes those are the same entity, but oftentimes they're not. So we're not seeing those costs. Those are
For scatter site units, or for
Both.
congregate,
They could
the landlord and the provider are the same, right?
not always.
So you don't have a contractual model through the provider to be able to do repairs or upgrades when a unit's offline?
There's a small amount of money in our contracts with the service providers to address minor repairs.
Could
My
amendments
guess
be
is
made
that
if
these
there were
ones that are
resources?
offline have much more significant repairs, and that's why they're offline.
So
The routine
what-
painting and stuff, that's covered in our service
Sure.
contract.
Could amendments be made to those contracts to put additional resources in to fix up the units, or are we just stuck with a few
Maybe.
hundred?
I mean, I think this is, how can we get,
All right,
make
maybe ask the
repairs,
question.
and what's
How do you
an
want to
efficient
fix
way
up
to do that?
How do you want to fix up the offline units? What's your proposal to do it?
I think that's less of a health question. I think we'd really want to talk to the construction people on that.
But these are units that within your control that are empty, right, and offline, and that we desperately need people living in. So, from April 30th to November 30th, just a 6-month period, but in that period, the number of offline units didn't change, from 387 to 381. We don't want to just be getting the next report in 6 months that there's 379 offline units and that we haven't done anything either. So any ideas that you can share with us at this hearing for resources, where resources could be brought to bear to bring those units back online?
So I think, Councilmember, we're eager to do some problem solving with you on this. Clearly, there are tools on the table for us to do this, and so we'd be looking forward to bringing those tools to bear to solve this problem.
The Progressive Caucus is actively discussing with City Hall and with OMB resources that we want to invest in the budget to bring these units online. It is, in my opinion, disgraceful that we're funding 1,000 city supportive housing units between DOHMH and HRA, so they have even more than you guys, that are not filled with people when we have thousands of folks sleeping on the streets with serious mental illness who desperately need help. We know this is the evidence-based approach, the cost-effective approach to making a difference in people's lives. We want to put resources in this budget that activates every one of these units so that at the next budget hearing a year from now, when we're doing this all over again, we're talking about how we got that number dramatically down. And so there's 2 weeks left, 3 weeks and change left before we're voting on a budget. There isn't a lot of time, so if you have suggestions you want to share with us, let us know, but we're pushing for resources, and we'll push for our best ideas unless you want to share any with us. Thank you.
Thank you, Councilmember.
Okay, great. Back over to Chair Caban.
Thank you. I want to ask a little bit about harm reduction and the opioid settlement funding. So how is it determined how much opioid settlement funds flow to DOHMH?
Yeah, thank you for that question. Just to say right at the top, this is a considerable opportunity for us to redress some of the harms that were caused by the opioid manufacturers. I think they see this as a once-in-a-generation opportunity, really. We have just a small part of the funding that comes in, as you know. The other agencies are OCME, as well as H&H. And so we have control and oversight over the portions that we, have access to. And so we can defer questions to sort of the higher level, how much is given to which agency to OMB.
Can you talk a little bit about, I guess specifically for DOHMH, how much you're eligible to receive and what the timeline is for receive it, and when you anticipate not receiving it anymore? When does the funding stop?
The timeline end, yeah. Let me hand it over to Dr. Rebecca Lynn Walton on this.
Thank you. Yeah. So how it happens is that City Hall determines it's in 4-year increments, and as we approach the end, then we keep talking about more. And so I know I was part of the early discussions, and so they were looking at sort of a 10 to 20-year timeline for all the funds, but also conversations are ongoing about it. So I would say, so every dollar we've been given, just to be clear, is out the door into communities. At least 40 organizations have received funding across the full continuum in every borough, and really focusing on both populations and communities hardest hit by the opioid crisis. So all of those dollars are out the door, and we just posted yesterday our updated report with all of those organizations, and then as they ramp up, metrics get out as well. So the overarching question you asked was how are decisions made, and we regularly meet with City Hall and our other partners and community members. We're about to launch a listening tour as well. That's what we did last time, to figure out from community members how they want dollars spent. So at all moments, we're really talking about how to do it. Do we need to speed up? Do we need to slow down? Efforts to do it.
And will any of the funding, will the Office of Community Safety be eligible to receive any of the opioid settlement funding? And are you guys planning to transfer any opioid settlement funding to the Office of Community Safety?
We currently are not in any discussions about transferring any of those dollars over to the Office of Community Safety.
And are you considering, I just want to go to now the syringe redemption pilot for a second, are you considering transitioning it from pilot status into a permanent program?
The syringe redemption pilot program was, from our standpoint, a huge success. As you know, over 1.7 million syringes picked up. We're not just doing community safety in that action, we're also paying people. They get up to $10 a day, and the vast majority of those folks are using that money to pay for food and other basic necessities. And so from our standpoint, this is a huge success. Let me hand it over to Aaron to talk about the funding piece.
Yeah, this is something we're really excited about from this executive budget, which is baseline funding for the syringe redemption program. So,
Great. And then I'm assuming that there's no information around whether you're considering transferring that pilot or that program to the Office of Community Safety. So I'll just put it on the record, but as an outstanding question we have about that office. My last question has to do with the SAM-HSA updated guidance on funding for harm reduction. So in this past April, the guidance basically eliminated federal funding eligibility for fentanyl and like different test strips, overdose hotlines, other harm reduction supplies that obviously many providers rely on and use. Have you guys assessed how much federal funding New York City supported providers stand to lose as a result of those changes? And does the exec budget include any city funds to backfill those losses and maintain that part of the overdose prevention service?
Thanks for that question. I'm going to hand it to Dr. Rebecca Lynn Walton on this.
Yeah, so this was one way in which people were somewhat protected, that they weren't using SAMHSA funding for this. I know the state has decided to use opioid settlement funds to fund test strips. Our providers are using our funding that we're giving them for test strips, and so we've been working with our providers so that we can figure out how to help them shift, because we don't want anyone to need a test strip and not have access to it. We also provide them as part of our naloxone kits as well.
Okay, great. Thank you. And thank you, Chair.
Okay, we've also been joined by Council Members Brooks Powers and Gutierrez, and Councilmember Brooks Powers has questions.
Thank you, chairs, and thank you for the testimony. How does DOHMH target mental health services for formerly incarcerated individuals? In particular, what strategies has the agency found to be effective in reducing recidivism? And how is the agency prioritizing these strategies and working with the Department of Corrections, CHS, and other agencies to ensure we are able to reduce the incarcerated population in light of the closure of Rikers Island?
Yeah, thank you for that question, Council Member. And it's incredibly important that we get this right for this impacted population. From our standpoint, it's not only important to treat these individuals with dignity, but it's also important to provide these resources to break the cycle of reincarceration and recidivism. Let me hand it over to Dr. Petit to share a little bit more on this.
Yeah, thank you for that question. So certainly, this is a critically important population that we want to make sure that we're offering the full array of services across the continuum. So within the division, there is a bureau specifically focused on initiatives that are aimed at addressing some of these concerns through a health justice network and a lot of interagency collaboration. We do actually also have what I consider a really remarkable program. There's a co-response team, which is pairing, clinicians with police officers to be able to, address some of the higher acuity calls that come in and make sure that when there is an individual who's in crisis who might have justice involvement or level of violence or agitation, that we're addressing it in a clinically specific manner. So it's been incredibly successful in terms of really making sure that folks aren't going back into jail. And like those, there are multiple programs that we either support or are part of that really are addressing some of the issues around diversion and re-entry into the community.
Thank you. And two final questions. One, this executive plan includes a reduction of $10 million in fiscal 26 for supportive housing. Can the department explain the rationale for this reduction and what impact it will have on any upcoming supportive housing projects? And in February of this year, the department released an updated RFP to fund new supportive housing for people with behavioral health needs who have histories of incarceration and homelessness. Can you provide an update on the status of this RFP and when we can expect to see the expansion of justice-involved supportive housing in our city?
Yeah, thank you for that question, Councilmember. The $10 million reflects basically a one-time savings from anticipated underspending. This isn't a reduction in any services. This isn't taking away units. It's not, taking down housing. Let me hand it to Assistant Commissioner Jamie Nichols to talk about that RFP in particular.
Thank you.
Thank you. We released an amendment to the Justice Involved Supportive Housing RFP in February that raised the rates that we paid per unit and added added a congregate option as well as scattered site. So those proposals are rolling in and will be reviewed depending on what the proposals are and what's awarded. That will determine the timeline for those units to become available. So scattered site becomes available sooner. You're just releasing on the common market, but congregate units take time to construct, and we don't yet know those construction timelines yet.
Thank you. Thank you, chairs.
Thank you. Okay, great. And I think that is it for this portion for DOHMH. So we thank you so much, Commissioner, and it's great to see all of your team members here and Deputy Commissioner. So thank you so much, and we'll send follow-up questions.
Thank you.
Thank you.
Thank you.
Okay, so we are going to roll right into H&H because we're a little bit behind. So hang tight, everyone. We'll start in a few minutes. Okay, all right. So good afternoon, everyone. Welcome to the final FY27 budget hearing for today, focusing on New York City Health and Hospitals. I'm Councilmember Linda Lee, and I'm proud to be joined by my colleague, Councilmember Mercedes Narcisse, who is the chair of the Committee on Hospitals. We've been joined by okay, they're in and out, I promise. Council members Wong, Brewer, Ressler, Aldebal, Brooks Powers. I think that's it for now. So welcome, President CEO, Dr. Katz, and your team, and thank you all for joining us today to answer our questions. On May 12th, 2026, the administration released the executive plan for FY27 to 2030 with a proposed FY27 budget of $124.7 billion. Health and Hospitals' proposed FY27 budget of $1.75 billion represents a 1.5% of the administration's proposed FY27 budget in the executive plan, and this is an increase of $7.1 million or 0.4% from the $1.74 billion originally budgeted in the FY27 preliminary plan. This increase results from several actions, mostly involving a Medicaid initiative adjustment to support the system's cash flow, federal reimbursement, funding for costs incurred during COVID-19 pandemic, increased correctional health services expenses, and an array of new savings measures. As of FY26 quarter 3, Health and Hospitals headcount was 43,580, and in the council's preliminary budget response, we called on the mayor to add $3.6 million to H&H to invest in the mental health continuum. And we also raised concerns regarding BHERD restructuring, Medicaid restrictions, and the state-directed plan. Although our request was not included in the plan, I look forward to hearing from the Director CEO today about your commitment to strengthening H&H's mental health services, addressing the challenges posed by BHERD restructuring and Medicaid restrictions, and ensuring these programs remain a reliable resource for New Yorkers who rely on them. And I now want to turn it over to my co-chair for this hearing, Councilmember and Chair Narcisse, for her opening statement.
Good afternoon, and thank you for being here, Dr. Katz. We're happy to have you here. I am Council Member Mercedes Narcisse, Chair of the Committee on Hospitals. Thank you for attending today's hearing on the city's fiscal 2027 executive budget for New York City Health and Hospitals Corporation, or H&H. I would like to thank Chair Lee for holding this executive budget hearing with me, and of course, thank you to all the leadership and for coming here to testify today. H&H proposed operating budget for fiscal 2027 executive budget totals $1.75 billion and is a $7.1 million higher than the fiscal 2027 preliminary budget. The main changes include an increase of $32.6 million to support correctional health services expenses, saving of $25.8 million to reduce reliance of temporary staffing, reducing overtime, and improving revenue collections and contract rebates. And lastly, a reduction of $4.8 million for BHERD transfer of funding to FDNY. We will also review H&H Executive Capital Commitment Plan of $2.9 billion, which includes funding for the Correctional Health Outpost Unit and critical healthcare expansion on the Rockaway Peninsula. My top line topics for questions today hearing will focus on bridge to home and show, correctional health services, medical malpractice defense contracts, Maimonides Health merger, H&H maternal health services, H&H headcount changes, and the Elmhurst Hospital Emergency Renovation Capital Project, and BHERD. Before we begin, I would like to thank the financial analysts, Aman Mahadevan, Assistant Director Florentine Carberry, and Deputy Director Isha White for preparing this hearing, as well as my staff committee, Ria Ogazarara, and of course Manu Butt for their support. Finally, I will also like to thank my staff, Frank Shea, Joshina Charlotte, and Courtney Lee, and all my staff for doing the work in the district office. I will now turn it over back to my colleague, Chair Lee.
Great, thank you. And I've been announcing this at every hearing, which is that we're doing one full long day, it should be fun, of public testimony on Wednesday, June 10th, starting at 9:30. So please make sure to sign up Wednesday, June 10th, beginning at 9:30 for our public testimony session. We've also been joined by our public advocate, who is very appropriately dressed for tonight's game. No, appropriately. Okay, perfect. So while we're trying to do that, let me just make sure, hold on one second, sorry. No, you're good. Okay. So I will hand it off to our awesome committee counsel, Brian Sarfo, to administer the oath for witnesses.
Good afternoon. Do you affirm to tell the truth, the whole truth, and nothing but the truth before this committee and to respond honestly to council member questions? CEO Dr. Katz, Senior Vice President Alberg, and Senior Vice President Dr. Yang. You may begin.
Hi. Good afternoon, Chair Narcisse, Chair Lee, and members of the Committee on Hospitals and Finance. I'm Dr. Mitch Katz. I'm a primary care doctor, and I'm the proud president and CEO of New York City Health and Hospitals. I have my great CFO here, John Olberg, and Dr. Yang, who does an amazing job for correctional health. Our executive plan builds on the January plan. I'm happy to say we are doing very well. We're going to close the fiscal year with a closing cash balance of $784 million, or 22 days of cash on hand, and a positive operating margin of $134 million, all in line with our historic performance. Some financial good news, our patient care revenue, which comes strictly from insurance, $60 million higher than in the same period in fiscal '25. Our financial initiatives remain on track to achieve $472 million of gain, and we pump all that money into hiring nurses, which I know our chair is a huge supporter of. The nurses keep our patients safe and take care of them. We're now up to 10,800 full and part-time nurses, and we've reduced our use of registry really to only what it's meant to be when someone has a maternity leave, a paternity leave, a disability leave, and you're holding their job, but not using temporary as a staffing method. We're grateful that the executive budget gave us funding for correctional health and maternal morbidity and mortality. This council knows that there are headwinds ahead, that H.R. 1, it's a very mean-spirited piece of legislation. I'm sure you discussed the parts of it with the DOHMH and DSS. We're all involved in different ways that people are going to be pushed off services, whether it's for food, whether it's for health insurance, and it certainly will affect our bottom line because we will still take care of them. Whether or not we get paid, that's not going to change whether or not we are going to take care of them, which explains why we do show operating losses in fiscal 28 and 30. I'm an optimist. I hope that there will be changes after the next election, but we are going to make sure that we do everything possible to maintain the care to our patients, regardless of whether or not they have health insurance. So I look forward to your suggestions, your comments, your questions, and appreciate the amazing support that we've enjoyed from the City Council. Thank you.
Thank you. Great, thank you so much. And we've also been joined by Councilmember Ariola on Zoom. And with that, I'm going to try to zip through my questions and then pass it off to Chair Narcisse. So, in terms of the executive plan, the savings on the executive plan, it included 14.1 million starting in FY26 and baseline to reach 27 million by FY28. And we were told that these savings would be achieved by reducing reliance on temporary staffing, which you just mentioned, reducing overtime. So how has this maybe impacted, or hopefully not impact, the reliance on temporary staffing as part of the savings exercise?
I'm happy to say that it has not affected us. These were cuts that we could do without, in part because we've been so successful now in hiring, we have been able to eliminate the temporary lines, and so there's no decrease in service associated with that decrease in $14 million.
Perfect. And just as we have been saying on the council, definitely great to hear that services are not going to be impacted, because obviously that's not what we want to see. So thank you for that. And were H&H medical staff part of the discussions on reducing overtime?
Correct. Right. We always work to try to make sure there too. Physician overtime is a symptom of not being able to hire enough full-time physicians, and we've had a very successful year now of hiring physicians, and so the amount of overtime we need to use has decreased dramatically.
Okay, perfect. And then in terms of the revenue collection, because I know it's probably a combination of the insurance reimbursements along with miscellaneous revenue, philanthropy grants, and that such combination. Have the revenue collection improvements, if you could break down if it's a combination of those, or if it's, how it breaks down in terms of those categories?
The revenue improvements has really been starting since 8 years ago, when we sort of first began this journey of learning how to bill insurance, right? We're not interested in billing people. We're interested in billing insurance. We're not interested in giving for-profit insurance a free ride by providing care for free and not billing them. And so each year we have gotten better at it. It's a complicated issue. It involves things like making sure the documentation supports the bill, making sure that the prior authorization is done, making sure some of the contracts that I inherited when I came were poorly negotiated. So they might give an overall amount per visit that was less than the vaccination that you gave during the visit, because the overall fee included the vaccination. So each year we look at the contracts, we improve the contracts, we improve our documentation is much better, and all of those things contribute to year, our increases are higher than inflation, which is how I view it, right? If it's just 3% more, well, then that would just say I was just getting inflation. But the fact that each year we've done better than 3% says that we are getting better and better at billing insurance.
That's great. And I know that just obviously on a much smaller scale, when I was running our Article 31 clinic, it almost felt like we were constantly trying to justify and get funding and reimbursements from the insurance companies, including Medicaid. So I appreciate your efforts in that area for sure. And then speaking of contracts, which contracts were part of the savings exercises? And in general, how often does H&H look into the contracts for funding efficiencies?
John?
Yeah. Good afternoon. Good afternoon. Yes, this is also, as Mitch had mentioned, just part of our normal course of business to make sure that the contracts that we have with a wide variety of vendors are giving us, a fair price. So we frequently, as the contracts expire, will go back, and that could be a host of supplies and services that are delivered at health and hospitals by outside vendors.
Okay, and then how often do you look at them, and are there areas of where maybe it would make more sense to bring them in-house versus doing it externally?
Yes, we're always looking for the cost benefit of doing something in-house versus hiring it out. We also take advantage of, we're almost a $13 billion enterprise, and I think as we've learned over the years is that we have a certain amount of leverage in terms of how we purchase, right? So we take advantage of that. Contracts are different. Some, when they expire, give us the opportunity to go back and renegotiate. There could be certain situations where we may say we're not satisfied with this price. So it's an ongoing, effort, especially with our larger vendors, and we've been pretty successful at that, and we're actually trying to line up perhaps we're looking, forward to this year and the following year, because as Mitch mentioned, we have, pretty sizable deficits in those out years, but we've targeted, a $100 million savings target on top of what we've, provided here.
That's amazing. Yeah, because I brought this up in other hearings as well, where as a city, we have tremendous buying power, and so if we can leverage that in any way, we should definitely look into that. And has technology helped at all with that in terms of streamlining, cutting costs, and those types of things?
Certainly, we're always looking for that opportunity. And certainly the world of AI is a whole nother new, environment for us, but we look at that in terms of ways to maybe more effectively deliver care. And as Mitch had mentioned, with denials, we're starting to explore perhaps using AI technology with that.
I know on the clinical notes and all of those things, it's helped a lot of folks be more efficient, so that's great. Okay, perfect. And just in terms of the federal funding risks, obviously, that are set to take effect this summer and fall, what steps are you taking to prepare for some of these changes to Medicaid eligibility?
Right. So the analogy I always think of with the government changes, and that's why it's so dangerous, it's the true scientific experiment that if you have boiling water and you drop a frog into it, the frog will jump out. But if you put the frog in the water and you just slowly heat it, the frog will die.
Right.
And I feel this bill was really created with that in mind, that the changes are very incremental. So that you never have that moment when you say, "Oh my God!" But as they accumulate, right? And now we have the first people, for example, not getting food, right? But so far, everybody is still insured, right? But then there's going to be the people who are falling off, and they've arranged for there to be accommodation for the first shift, so they won't all fall off at once. I mean, the most important thing that we do is to constantly remind people, we're here whatever insurance or no insurance you have, right? That does not affect your care, and we are the only, provider who can do full range services for people who do not have insurance. The FQHCs are great, but don't have the specialty services.
Right.
Right. So, when someone needs the MRI or they need the breast biopsy, they're going to come to us. So beyond that, we just need to think about how, given that there will be less dollars, because more of the people that we care for will be uninsured.
Exactly.
So we have to figure out the model of how to do it. You had already asked John. We do think that in the coming months there are going to be opportunities for AI to help us to do certain administrative tasks more efficiently.
Yeah.
That may help a bit. We're constantly looking to see how we can be, what care models are the most efficient, deliver the greatest benefit. We will work with you and share any information. We're certainly working hard to re-enroll everybody we can. And to help people learn that there are exemptions, including for volunteer work. We welcome, I know, the Public Health Department has a great initiative for volunteering to help other people to get benefits. We're also, always trying to get people to work in our skilled nursing facilities, where the only skill you need is the willingness to sit next to somebody next to a baseball game and talk to them about it, or sit with someone and play cards. They're always looking for a fourth hand, right? And that would qualify as, volunteer experience, right? There's nothing wrong with work. There's something wrong with taking away people's fundamental health care. Right, and we want to try to figure out as much as possible how we maintain people's benefits.
Yep, no, definitely. And I think that was brought up in quite a few of the hearings we've had so far, especially with HRA as well as DOHMH before this, when it comes to making sure that the health benefits and also just in general, like SNAP, food stamps, the resource navigators remain funded. And do you have those staff that are going to be impacted by this within the hospital setting or within some of your other program areas?
So far, no.
Okay.
I mean, nobody is affected yet,
Okay.
right? Again, that's this very slow moving
Yes.
thing, right? I mean,
Yeah.
again, even to the end of this year, we're fiscally okay.
I know,
It's-
22 days of cash on hand is very great.
Yeah, it's only as you get into the outer years when you start adding up all the incremental things. But again, we have reason to hope that there is an election before there are the final cuts, and that maybe there is some opportunity to protect the benefits that people need.
And then in terms of that, and the subsidy amount that could potentially increase as the eligibility gets stricter in the long term, do you have any sort of, I know you're saying this year it should be okay, but in the out years, have you done calculations of how much extra funding you would need?
Well, in a sense, the shortfall is the loss. The question is, how much can we make up without harming services?
Right, so whatever that delta is.
Right, and if it all happens, we will need to come up with alternative models, but maybe, sometimes bad times cause you to have creative thoughts, come up with new ways, right? The city learned a whole new set of things through COVID that we never knew before, right? We never used before. I hope it's not going to come to that, but we will certainly look for other opportunities to figure out how to protect services. That will be our bottom line.
Yes, definitely. Mental health continuum, obviously, we are huge fans of, and it's an interagency partnership between H&H, DOHMH, and DOE to provide mental health care in the schools. And the program is typically funded for $5 million. We've been pushing every year to see if it could be baseline, but will the $5 million for the mental health continuum be allocated at adoption? Do you know? Have you been having these conversations with OMB?
We have been talking with them, and it is in process. Like you, I've actually visited them, and they are amazing. I particularly like that part of the model is to mentor teachers on how to care for someone in the classroom, because most of the time is going to be spent in the classroom, not with the therapist. So the model of saying, yes, we provide therapy, but we also teach the teachers how to take care of kids who are in distress, because that's where most of the time they're going to be in the classroom. So those discussions are ongoing, and I feel very hopeful.
Great. And does the funding for $5 million keep programming at current levels?
Current level.
Current levels, okay. And how many centers have been opened since this initiative began, and will there be any new clinics opening in 2026?
There are no new clinics opening. Do you know the number?
Yeah, I think it's 16 clinics.
16, okay, that's right, same, yeah, yep. Okay, and then just really quickly, because this also has come up, a topic of Office of Community Safety with a few of the hearings we've had so far. The executive plan includes a baseline transfer of NGBV funding of $3.3 million to the Office of Community Safety starting in FY28. Is the administration planning to transfer any other H&H programs or services that you know of to OCS?
Not at the current time.
Okay. And H&H's hospital-based violence interruption program, HVIP, seeks to break, cycles of violence by providing interruption prevention, community engagement services. I assume that it would make sense for the Office of Community Safety to be involved with this program if the program is effective. And is this something that that the administration's looking into that you know of?
They have not said anything. Yesterday, I was at a really great retreat for all of the programs. It's one of our initiatives the last year. These programs all have a sort of historical background. There was Dr. Gorder in Brooklyn at Kings County had started a program. There was a Jacoby program, and what we have now done is we have programs at all of the hospitals. As we said, you can have different brands, but we all want you to learn from one another. So let's figure out a strategy. And yesterday was their first all H&H retreat together, where they spent the whole day figuring out how they learn from one another. So
that's great.
We're very excited. We want to respect the traditions, but we also want to figure out what we can learn from each other.
No, that's perfect. Thank you. And I feel like that's the best way to learn sometimes is just from your own peers.
Absolutely.
And what is the total budget for the HVIP program for FY26 and FY27, as well as the total head count?
I will have to get back to you on that.
Okay, perfect. Let me pass it off to Chair Narcisse.
Thank you, thank you. One of the interesting things I love about that billing, like, did you actually increase the staffing in the billing department, or you use technology to help you bill? Because without good billing, you can
Right.
collapse.
We definitely hired up. We haven't had to hire recently. We got to a certain level that was appropriate. But when we first learned how to do it using a contractor, and then once we learned how to do it, we said, bye-bye contractor, and we hired all the people to do it, and it's been working very effectively.
Yeah, I like that because, and I have to give you credit because ever since you took over, we have not been really in depth in H&H. And if anybody tell you that, that's one of the reasons I appreciate you a lot, because I know we've been struggling with H&H in the city of New York, and you have shown us a new vision, and that's the reason I want to say thank you personally.
I appreciate that.
Thank you. You're quite welcome. Based on your testimony, roughly about 450,000 New Yorkers losing their essential plan eligibility by July 1st. How many are current H&H patients, and what is the projected uncompensated care increase?
Those numbers.
Yeah, it's, we're talking about we call them, EP5 group. It's the group of about 450,000 people statewide that are in the process of losing their coverage. For us, that number is about 50 to 60,000 people. I think in New York City wide is somewhere around 200,000. So it is pretty devastating. But we are prepared, right, to still serve those individuals, and we will use disproportionate share funding as the vehicle, right, to pay for their services.
Thank you.
We would tell them all, continue to come for care. We're here for you whether you have insurance or don't have insurance.
Thank you. 20 days cash on hand, in line with historical performance, you know that. But 2022 days appears thin for a system about to absorb a federal shock. A healthy system targets a far larger cushion. What's the floor before it, threatens our operations?
Well, I think the reason we don't operate the same as people do in the private sector is that we have the advantage of the city and the state. Mm-hmm. So how much cash we have on hand has some relationship to how much the state owes us at any one moment, and sometimes how much the feds owe us through the state, how much the city, owes us for different things, the ability to move payments. So we're always around, and that's why it's always around that number, 28 days. Now, ultimately, if there were markedly less insured people and we were providing the same level of services, that will open a hole. Mm-hmm. And then that hole can only be filled either by the city, by the state, or us figuring out more efficient models. Mm-hmm. And we will never, back off on providing services, but we could, in a bad scenario, have to look at, for example, maybe we can't provide every service at every hospital. That could happen, right? Mm-hmm. Would the service still be available? Yes. Would it be available at every hospital? Potentially, no. I mean, I'm very firm in all of the government systems that I've run. You get to spend what your leaders give you. You don't get to spend more than that.
Yeah.
That's how it works. It's like our checking accounts. You might want to buy something more, but if you don't have the money, you don't. We will always prioritize services over administration. We don't have the high salaries that exist in the private sector. But I think what we would have to do is we'd have to look at the places we provide services and probably decrease it. If you look at the other systems, they don't do the large systems, whether we're talking NYU, Northwell, Mount Sinai, for example, they don't do OBGYN at every hospital. Well, they do GYN at every, they don't do OB at every hospital. They have a hospital for birthing. And that's where you have to go. Health and Hospitals has a different tradition because our hospitals really grew up around taking care of the neighborhoods, right? So Harlem takes care of the world of Harlem, and that's more our tradition. And so all our hospitals do OB, and that's a good thing. Pretty much all our hospitals do a pretty full spectrum of services. I think in a scenario where there was less dollars and you were prioritizing services, you'd probably have to provide the services at fewer sites, and people would have to travel for those services. But at least the service would be available. It wouldn't be cut.
Yeah. You're talking about enrollment. I know we're gonna have some complex moment to get people re-enroll, because the fact that we're dealing with population, elderlies, people that don't have no support, that live alone. So as we're talking about enrollment, I know we have strategy to recruit volunteers and stuff, and I pray God, since New York City is a great place despite everything going over our head, so I'm hoping that a lot of people will be recruiting to help address that enrollment. And you said you're gonna have kind of hub-like to do that, so thank you in advance for doing that.
Thank you.
Great news that we have hired 200 nurses. You know that brings me joy, right? I'm very happy. We forecast operating losses in FY28, FY29, and FY30 from the HR1 ramp up. How optimistic are we that the staffing increase won't get squeezed to make ends meet at the end of the day?
When I look at our system, I'm not cutting nurses because we're structured so that 5 medical surgical patients equals 1 nurse. And that is the appropriate model. I don't think there's any value in running hospitals that are under staffed. So you have to maintain the basic staff levels. Again, that's why I was going to, if one had to do something, it would probably be to look at the 11 hospitals and say, what is each borough going to have? And maybe each borough is not going to have every service at every hospital. But I don't want to ever run hospitals with too few nurses or doctors. I don't see any valor in that. That will only lead to bad care. I don't want to ever provide bad care. I would rather say something is not available than do something poorly.
I appreciate that. Dr. Katz, your testimony knows that you are still evaluating the impact of the newly enacted state budget, and that you anticipate operating losses in out years from HR1. Can you walk the committee through the challenges you see ahead, both from the state budget and the federal cuts, and how H&H is planning to meet them?
Yeah, I think I did the planning to meet them, but John can do a better job than I on the cuts themselves.
Yeah, I think first on the state budget, right? We think for health and hospitals, it should be very favorable. We're still trying to understand the details. But for hospitals in general, the governor and the legislature added over $1 billion. And that was, $600 million for hospitals, $100 million for outpatient, and then there's a quality pool we're still trying to, better understand. The value of those additional resources are not yet reflected in our plan, right? Because we didn't have enough time, the budget was late. So that should improve our out-year situation. As Mitch had said, we're always forecasting years ahead. The 5-year operating deficit is $300 to $350 million. We will need to attack that deficit, and we've seen to have, good success, thus far in that approach. It was a year ago when we were here together, and HR1 had just, been released, and our plan today is about $500 million stronger than it was then, and it's because we try to find opportunity in the midst of the turmoil, and we've managed to do that. You've heard us talk about the average commercial rate. It's a state direct, it's a rate enhancement, and we take advantage of that, and that's benefited us, rather significantly. But yeah, we are today trying to figure out solutions for, the fifth year of the plan to avoid those cuts that Mitch had mentioned.
Thank you. And like I said again, I trust Dr. Katz going to do the best he can, and I'm comfortable with a time like this to have Dr. Katz, doing the CEO of the H&H. H&H fiscal 2026 budget for emergency weather services is $5 million. The full $5 million was allocated in the preliminary plan to retroactively cover H&H emergency warming centers services during extreme cold stretches with this past winter. Will $5 million be H&H full fiscal 2026 budget for emergency weather services, or do you anticipate additional funding for being added at the adoption?
No, I think we're very grateful, right? The warming center, was a significant problem, and we had to come up with a very rapid solution. And the arrangement that we have with OMB when, Health and Hospitals, tries to address the situation is that they will cover those expenses for us. And we anticipate in the future, if we're unfortunately met with, a similar situation, that, that they will help us financially.
Okay. Okay. Does H&H offer services during extreme heat emergencies as well? If so, how much do you anticipate H&H spending on these services this coming summer?
So yes, we do offer cooling at all of our facilities for people who don't have it. I think when it comes to cooling, the city has more resources, and we are just one part of the resource. I think in the cold spell, right, everybody was staying home, and we needed the big thing that Health and Hospital was able to do was go and find the people. And I think that's what changed. And the city has always had warming centers, but people weren't necessarily going to them. We then took vans and went out and found the people and brought them in. So I think on the keeping people cool through the summer, the city has an overall response that we're just part of.
You don't have separate funding?
No separate.
Yeah, no separate funding.
Okay, the Rockaway trauma, I'm going to leave it for my colleagues that's excited to go through that, because she's excited to see you. If she does not ask all the question, I'm going to come back to that. Okay, I have one of the question I want to ask. The Office of Healthcare Accountability, the Office of was established in June 2024 through the Healthcare Accountability and Consumer Protection Act, Local Law 78. This is a legislation that Speaker Menon was proud to spearhead while serving as chair of the Committee on Consumer and Workers' Protection. The office was created to examine healthcare costs across New York City, improve transparency in healthcare, pricing and spending, and identify strategies to reduce costs for patients and the healthcare system overall. Is H&H doing any work with this office? If so, what role is H&H playing in improving transparency in their costs for care?
So we provide data to the office on all our costs, and that's where you can learn that Health and Hospitals often provides the same care, but for a third of the price, because we are a public system that devotes ourselves to services and not to other things.
Giving ongoing reimbursement rate, we talk about it, you're very good at it, you master the billing. Okay, giving ongoing reimbursement rate negotiations between New York Presbyterian and Emblem Health. What role has H&H and the Office of Healthcare Accountability played in assessing the impact of provider reimbursement rate on the city healthcare costs?
If that have delays in reaching an agreement affected the city's anticipating health plan saving? If so, by how much?
We have not been involved in those negotiations.
Okay.
Those are all done by OLR.
Okay. There's many questions, but I'm trying to wrap it up, as fast as I can. Some interesting one I have to ask. Saving in the executive plan. The executive plan includes saving of $14.1 million, starting in fiscal 2026, and baseline to reach $27 million by fiscal 2028. We were told that this savings will be achieved by reducing reliance. You had, wait, 27. Sorry, my chair just took that one. I'm gonna go to the, I was repeating because I was minding my business, I guess. I was talking. All right, did you do the federal one? I don't hear the federal one. Okay, the federal restriction on Medicaid. You did, so you did my question then, yeah? Let me see, the federal one? No, I didn't hear that one. No, you did that one. So we have a conflict here. Apparently, somebody was not paying attention. It was probably me. All right. Chair. Oh, the finance. I'm the one that's not paying attention. Sorry, Dr. Katz.
All good.
All good. Okay. You did this one. You did that one. You did the mental health. You mixed my questions with yours. We have few questions that we're interested, few questions she's interested. So I don't want you to repeat things. Just give me a second. Okay. Okay. Okay, so let's move on because I have some question in there on the side too. Asylum seekers. H&H has an asylum seeker budget of $30.9 million in fiscal 2026 with no funding in fiscal 2027. How is the remaining asylum seeker funding in H&H budget being spent?
So the money that is showing in the fiscal year 26 is all the closeout of the hotels and shelters that we were running for people who were seeking asylum. And now all of those services have been transitioned to DSS within the existing shelter system because we're no longer receiving the buses. As you remember, there were days when when 200 people would arrive to the city without any place to be sheltered. And so in order to help our sister agency, we created another system, but now that other system is no longer needed. So there's no ongoing funding for the program. It's all within DSS.
So all go to DSS?
Yes. And the money that is there that's already spent. That was money that was spent at the beginning of the fiscal year before the programs closed down.
Does H&H have any employees who are fully dedicated to asylum seeker operations? If so, what will happen to them when H&H fully winds down in asylum seekers operations?
Everybody was absorbed in other jobs.
They were all absorbed. Nobody lost their job.
Nobody lost their job.
Thank you. Good news, especially in this climate. Okay. I love Bridge to Home, so I'm going to have to tax over too. Follow up on Bridge to Home. Funding was added to the Bridge to Home program in the preliminary budget, bringing the program's budget to $20.1 million in fiscal 2027. This additional funding covers a new site for a total of 3 sites. During the preliminary budget hearing, you stated that one Bridge to Home site is operational and located in Manhattan. Have the locations for the other 2 sites been chosen yet? And is there a timeline for the opening of the 2 last sites?
I just want to take a minute to invite everybody. I know you've been there, but if you have not been to Bridge to Home, I think in my 25-year public health career, I don't know that I'm prouder of anything more than this Bridge to Home, because I always felt that sending people out of the acute care psychiatric hospital who were homeless made absolutely no sense, and that all of the good work that the nurses and the doctors had done during that period of time to stabilize the person would all be lost when 2 days later their medicines would be lost and they'd be, in the subway. And so we created this program. It's volunteer, but it's a good deal for the people. So the participants have been very willing. We've had very high retention rates. Very few people have left. The existing one in Manhattan, and we've now already placed 4 people in permanent supportive housing, which was another part of the idea that, yes, we all are in favor of supportive housing, but you cannot actually go from the psychiatric ward to supportive housing. There are all these steps. You have to find an apartment, you have to sign a lease, you have to get furniture, there has to be a first month, and you have to be ready to live in that environment on your own. But we're doing injectables. As a nurse chair, you would appreciate, we're giving people monthly injections so that they keep their mental health. We've seen tremendous improvement in people's abilities to have a positive life outlook. And so with that, the city has generously agreed. The second one will be in Brooklyn and will be opened in September. And the third one, do you know if it's Queens or Bronx? Because I know we're going to do in each borough.
Yes, I'm not sure if we know exactly yet.
I think we haven't yet chosen whether, the idea is that there'll be one in each borough, but I'm not sure whether number 3 is going to be Queens or Bronx. It'll probably depend on finding the right site. We need another positive thing that I'd say for all of us who've lived through this, the neighbors, they love us. You don't get you haven't heard a single complaint. They actually have pointed out how the neighborhood is better. We took down something that people didn't like that was right in front of the building. But the key thing is it's 24-hour staffing. So you don't have people sort of hanging out on the outside, the kinds of things that are upsetting neighbors. So it's been incredibly smooth. I mean, normally when we have a program, I get email complaints, noise or zero.
Nice.
Zero complaints about the Bridge to Home. And I think it's directly related to the fact that there's 24-hour staffing at the program. And we are talking to our sister agency, DHS, about are there other shelters for the mentally ill that we could increase the clinical level of services. If we do that, it does make the shelter more expensive, right? You can't provide nursing without some added expense. But I think it might actually save the city money because people revolve through these shelters without actually getting better. And it could be that if we would provide enough structure, the people don't need a hospital, but they need something more than a case manager seeing them once a month. They need some structure, they need some activities, they need some nursing, they need someone to hold on to the medicines so they're not lost. People can look remarkably different after 3 months of good nutrition, positive socialization, and medications. People who you would have thought, oh, this person could never go to supportive housing. You give them 3 months of those things, they look completely different. But they don't look different after 2 weeks in the hospital. 2 weeks in a hospital gets you from psychosis to not psychosis.
I am so sold to that. You know that. Yes. I love it. And one of the things, we said boroughs, we have 5 boroughs, but I'm hearing 3. So when is the plan to expand?
Well, this is, we hope that the city will continue to be generous and we will continue to have them.
Are we having the conversation? Because you sold me in this, the minute I walked in, I'm 100% in. So are we
going to continue? We think that there is tremendous support for us to do this.
Thank you. I'll advocate with you, definitely. The SHOW program was funded at $13.1 million in the fiscal 2027 preliminary budget. Are the 3 new SHOW units in operation? Where are the 3 new units located, or where will be located?
So we just got the funding, so they're not yet operational. The funding is for fiscal 27, so the money opens with the July budget. So once we do that, we're working closely with DHS and community-based organizations to figure out what is the best location for them. But they have been very successful at reaching people who are not going to necessarily come first time to a hospital or clinic, but who might come after we've engaged with them.
Okay. Correctional health services. The executive plan includes a baseline of $32.2 million in additional funding starting in fiscal 2026 and increasing to nearly $40 million by fiscal 2030. The funding will support correctional health services, spending related to affiliated costs and pharmaceutical drugs. We know how expensive that can be. How many providers does H&H contract with, for the provision of correctional health services? How were these providers chosen? How?
Hi. Correctional Health Services has one major affiliate, professional affiliate, as do our sister facilities in the system. And our affiliate, unlike just like some of the other facilities, is PAGNI, the Physician Affiliate Group of New York. And they we select individuals who are frontline providers. These are doctors, physicians, physician assistants, mental health clinicians, mental health treatment aides, in 1199 and Doctors Council, primarily because when we came over to Health and Hospitals, a bulk of the staff who were vetted and interviewed and selected from what had been Corizon were already in Doctors Council in 1199. And for those individuals whom we selected to join our new team, we wanted to preserve their benefits and their seniority and their retirement benefits. So that's how we ended up with PAGNI. They are a professional affiliate. It's only frontline providers, patient care providers. All the supervisors and managers are on Health and Hospitals. It is not a typical or traditional contractual relationship. So that is our main contractor. We have two other small professional contracts. One is an 18-staff carceral dental provider. They're dentists and dental hygienists and oral surgeons. And then we have 8 emergency medicine physicians who are in a group, and we contract with them to be on island.
So those are private groups? What's the name of the group?
The dental is Correctional Dental Associates.
Okay.
And Urgent Medical is a small PC.
Okay. They are from New York City or out of state?
Correctional Dental is in New Jersey and New York City. And Urgent Medical is in New York City, and I think they might do some work in Westchester, but they're New York City.
We have a lot of doctors in New York City. So
yeah.
Anyway, let's go forward with that. We can always explore that deeper, dive into it. What are the length of a H&H correctional health services contracts? How long?
So our contracts, depending on what kind of contracts we're talking about, as part of Health and Hospitals, we use the Health and Hospitals contracts as much as possible. Those are basically for laboratory or pharmaceutical and medical supplies like Cardinal Health, and those contracts generally run 3 to 5 years, depending on the need.
How many years? You have them? How long usually have the contract, the cycle of the contract?
The system contracts run 3 to 5 years.
3 to 5 years.
And they're renewed at Correctional Health Services, annually re-evaluate the performance of each of our contracts as to whether we're
You'll
satisfied
be
or not.
evaluating them?
Annually.
It's not automatically like a year cycle like?
Annually, we do this with all our senior staff.
Okay.
To evaluate whether we're getting what we pay for.
The evaluation that you do with your contractors, are they based on the responses of the staffing, people that are dealing with the actual contractors?
We have taken up corrective steps with some contractors. We have terminated contracts. We have performance measures, including turnaround time, quality of responses and results.
All right. I have some colleagues, there's different things going on. I would love to ask a question, but my colleagues that have to run, Sylvina Brooks-Power, I know she came directly. She dive into it. Okay, Sylvina Brooks-Power.
Thank you, chairs, and thank you for the testimony today. I'm going to just go ahead in the interest of time and ask the questions, and then I can repeat any question I need to. But it's always great to see you, Dr.
Great to
Katz,
see you.
and the full H&H and CHS team. So first, Dr. Katz, have been a strong partner in the Far Rockaway Trauma Center efforts and have heard the needs of our community. Based on previous conversations, we have estimated that a level 1 or level 2 trauma center would cost approximately $200 million in capital to construct. As far as you are aware, is this still a reasonable cost estimate for this facility? Next, the executive budget includes additional funding in the next few fiscal years for CHS operations and pharmaceutical operations. Can Health and Hospitals explain the rationale for these increases and how they will improve services for CHS patients? And the last two, how does New York City Health and Hospitals track and measure trauma cases across the city? And what is the average travel distance and transport time for trauma patients to reach a level 1 or a level 2 trauma center citywide? And how does that compare with the residents of the Rockaways? And I know, Dr. Katz, you had shared in an interview a while back a very profound statistic in terms of the number of trauma centers in the different boroughs. And if you could just on the record share, based on the boroughs, where our trauma centers are located and how many they have, I'd appreciate it.
I'll do my best. Let's just deal with the CHS question, because that's very straightforward.
Yeah.
The increase really reflects the increase in volume of the number of detainees on Rikers. So Rikers has been much more crowded than before. And so some of it is just the per person cost of the medical care. And then we're very proud of providing the same level of care at Rikers that we would provide to anyone. And so that means many more injectable drugs that are expensive, but that we believe ultimately provide good care. So it's a combination of more people, more expensive pharmaceuticals. I remain with you a big supporter of the Rockaway Trauma Center. I feel that the fact that it is a 40-minute trip to the nearest level 1 or level 2 trauma center, assuming reasonable traffic, which, as we know, is not always the correct assumption. There are, as you know best, there are only 2 ways off the peninsula, and both of them can be very congested. And it is a very long and thin peninsula, which means that added time, depending upon where exactly on the peninsula it is. So I think that there is a very strong argument that it is wrong for people to have to wait the 40 minutes for definitive care, and that lives are lost at that. In terms, I can only say that other parts of the city have better coverage. I don't have the exact numbers, but I can certainly give a sense. Staten Island has 2 trauma centers, and while it's a, if you will, a fatter island, it's not nearly as long, right? So in terms of travel distance, it would be significantly shorter. Manhattan is certainly the place where there are the most trauma centers in a very small area, where people would have access to a trauma center. In most cases in Manhattan, I would say, no more than 10 minutes would be like the furthest within Manhattan. Brooklyn has Kings County, Maimonides, and NYU Lutheran. I may be missing, I feel like I'm missing one. But again, for the size, much shorter travel times. That really, when you look at the city as a whole, the Rockaways stand out in terms of the time people would have to travel. And that's why I support it with you.
Thank you. And in terms of the cost, as far as
Oh,
you're
yes, it's
aware-
correct. Yes, thank you for reminding me.
Yes.
Yes, that is still inaccurate. I recently, verified the number with a group that builds hospitals, and they agreed that $200 million is the capital cost.
Thank you so much,
Thank
Dr.
you.
Katz. Thank you, chairs.
Okay, great. Councilmember Caban, followed by Brewer.
Thank you. I'd like to start with a couple of questions about gender-affirming care. I asked this question earlier, but it's probably more appropriate for you all. Obviously, we're seeing the federal assaults on gender-affirming care continue and escalated. I mean, now we're seeing these private hospitals get subpoenas. So is there a plan for increasing access to gender-affirming care within H&H, specifically for younger children? Like I was mentioning, but there are so few places that provide care for children under the age of 13. So could you speak on that a little bit?
Sure. Well, with you, we remain committed to this population, and we are not going to, stop taking care of them. We believe that this is a health issue that is best dealt with by the person, by their family, and definitely not by the federal government. We have already accommodated families who were in other programs that ended, and we'll continue to do so. We don't maintain any volume cap, so we'll care for as many children as need to be cared for.
I think one thing that has come up is that, we've asked about this before, obviously, because this has been a long-term attack on that particular community. And we haven't necessarily seen an addition of patients coming to H&H. But what I will say is that I am hearing from more parents that they're, having a hard time figuring out where to take their children. And so I'm wondering also if there are dedicated referral pathways, care coordinators, expedited appointments at H&H available for patients whose treatment has been interrupted. And I want to emphasize the care coordinator piece, because I think that's what parents have at least indicated would be the most helpful, because different age and different development stages require different kinds of care, and not every doctor in every even H&H facility has the ability to provide that care.
Yeah, we certainly do try to have people come to a place where we have specialized physicians, because as you say, not all physicians, even all good physicians, are culturally competent to deal with the issues of transgender children. So I will go back and see more about whether or not we have a sufficient number of care coordinators, and we'll certainly prioritize that as things get harder and harder. As other providers stop doing this work, we want to still stay firm and keep providing it to the children.
My last question on this piece is, NYU Langone has received a federal subpoena. Mount Sinai has, except they're lying about it. Has the administration received?
We have not.
Okay. And thank you. Chairs, may I ask just a few questions on BHERD?
Wait, can we,
Okay. Just because it hits the mental health portion, and I had to wait for health and hospitals to ask those. Yeah, thank you. Okay. On BHERD, is there a plan, like we saw on the website that there is a drop in eligible calls for FY25. Do you have a plan to increase eligibility for those calls? Like as one example, open to removing the limitation of EDPM only. We're seeing other responders around the city have a much larger scope of call classifications that are eligible for their alternate responders.
Right. So you have to remember that we, Health and Hospitals, doesn't run BHERD.
I know.
We We are proud to hire and train social workers, and we think our social workers do a great job, but we don't do the operational part of Be Heard. It's certainly a model that I believe in. I think that if you want to de-escalate a situation, you want to send a mental health professional, and therefore I would want to send a mental health professional as often as possible to these situations. And I do think that it could be a much larger group, but that requires operational changes across the city.
So, and according to you, and there's been confusion about this, is Be Heard moving to health and hospitals? Is it going into
No.
the department? So it's not going to be.
So at one time there was the proposal to move it to health and hospitals, and
Right.
you know, that was not a negative on anyone. That was just recognizing that it was challenging for fire to hire enough EMTs and paramedics. In the absence of that, there were not very many calls. But that plan has changed, and I think now the administration is looking at a variety of options, and I think there are a variety of options.
Totally.
I think that really, which department is not really the issue. The issue is how do you efficiently get people who are not law enforcement frightening, but are mental health professionals to situations to de-escalate them as
Here's
quickly
my very
as
last
possible.
question, because it's not even just mental health professionals, but H&H uses peers in a myriad of programs,
Yes.
correct? And that's because you find that peers provide something that nobody else can.
Correct.
What would you? There has been an increase in peers in a lot of different places. H&H, DOHMH. It really gets celebrated. What do you think about peers on Be Heard teams? I mean, but people who live with mental illness and are part of those organizations are saying we want peers on these teams.
I think it'd be great.
Great. Thank you. That's all I've got. Thank you so much.
Okay, great. Councilmember Brewer?
Thank you very much. On correctional health, I have a question on New York Cares, bike crashes, because you know more about it, and then just mental health on the street. So correctional health, congratulations, finally. I understand there's 96 people. When Stanley Richards was here the other day, he said it was 96, which is phenomenal.
It's 95 today.
95 today. Congratulations. And so that's going well. But then at Rikers or other locations, I don't know, what's the cost, where it's a budget hearing, what else do you need? It's still challenging on Rikers as opposed to at Bellevue. And I'm just wondering if you could update us on the cost, update us on any other needs that you might have in terms of correctional health.
Yeah, I appreciate so much the additional funding, which is going to make correctional health services whole again, and that really covers the increase in cost for pharmaceuticals. As Dr. Katz noted, we have more patients and we have sicker patients, and that's really the issue there. And it will allow us to make up for the salaries for the people who are good providers and providing the kind of services that we expect them to provide. The Outposted project continues. They are funded. We are working very closely with the Department of Correction under Commissioner Richards. It's wonderful, and with the State Commission on Correction to finalize the designs for the Bronx and the Brooklyn sites.
Okay.
Really excited about it.
Fantastic. The issue to those at Rikers, how much staff is there? How is it every day? When I'm there, and I'm there pretty often, it never seems like there's a lot of folks in the clinic, but that's just because maybe I'm there at the wrong time. I got it. But it's not hard to recruit. I'm just trying to get a sense, because people get sick, obviously, and I was just trying to understand if that is still an issue, or you think you're totally copacetic with correctional health at Rikers.
We can always do better, and it is a challenging place to work. We have been much more successful in recent years, certainly since COVID, in recruiting and retaining staff. Our vacancy rate's about 8% at this point in time. Part of the reason why we needed to come to you for the budget leveling is because we've basically run out of vacancy money, dollars that were not spent because of vacancies, because we've reduced that, which is a good thing. We have staff on.
All right. I live with people who are asylum seekers, and they love New York Cares. I'm not sure they use it very much, but they know about it. So I'm just wondering, what's the cost? Are you increasing those who are participating, et cetera? Just get a sense of it.
Sure. Well, remember when NYC Cares was funded, basically it was a single funding which covers our having an 800 number and additional pharmaceuticals and the infrastructure to run the program. But the program really just takes advantage of health and hospitals. We don't cap the number, right? We've always taken care of everybody, regardless of their immigration status. The difference is there was never an organized system to enable people to know how to do it or to get a primary care appointment in 2 weeks and have that be the center of it. So I'm sure the actual costs exceed the amount of money that the city is giving, but that's okay.
Right.
These are people we've always wanted to take care of.
So how many people are taking?
130,000.
130,000, okay. And that's pretty steady?
It's about 10,000 higher than it was this time last year.
Congratulations. All right, now about this, I have to deal with bike pass and bike. I know I saw.
Wait 1 second.
I saw the helmet.
Oh, wow, okay.
All right.
No.
Go ahead.
Okay, so I have to deal with people like bikes and people don't like bikes. That's how it works. And so when you try to build a new, I would say, infrastructure, all hell breaks loose. My question is, in the papers, mostly the Post, there's a lot of concern upping the number of, I would say, crashes, accidents, or not. In other words, do you see more at Bellevue, or is it just other hospitals that are racking up? Give me a sense of what you think we are with this industry in terms of...
Accidents are up, but I would personally, as a manual bicycle rider,
Yes,
I blame the e-bikes and these electronic scooters because they just go way faster.
Right.
And that's what causes the accidents, right? It's the fact that people are coming at you really quickly. So we've seen a lot more accidents.
At Bellevue too, or at the
Yes,
other, all your
absolutely.
hospitals?
All hospitals and definitely at Bellevue, and a lot of scooters, a lot of wrist fractures, and I think the issue of the bike lanes, again, as someone who uses them all the time, is that you're still supposed to follow the law. Like when the light turns red, you stop. Right. A bike lane is not welcoming to go through a red light. And so everybody needs to, pay attention.
So, sorry, one quick thing. Can we take a quick pause because our public advocate has to go to the airport, and then we'll go back to Councilmember Brewer right after.
Thank
Great.
you.
Thank you so much. I am sorry, Councilman Brewer. My wife will be considerably mad if I don't get there, so I apologize. Thank you for giving me an opportunity. I do have to say, let's go Knicks. That's really important. And
Wait, 1 second. You have a very well-known fear of flying. What are we talking about here? Going to
no, I just said I'm picking up my wife.
Oh, okay.
Yes,
All right,
exactly.
all right, all right.
I made that very clear. Yes, and she'll be pretty upset. I'm gonna be late anyway, so she'll probably still be upset. I may have to call y'all for some help. But thank you, commissioners. So really quick, I know I had a question about Be Heard. I think you said you're not prepared to answer questions on Be Heard.
No, just that we don't do the operations of Be Heard. So our role is to train the social workers, hire them, but the operations of Be Heard is right now in the fire department.
Okay, so the $6 million for Be Heard, is that going to you? Is going to the fire department?
Fire department.
Okay, but and so I have, I've been concerned about some of the things I've heard. The commissioner basically said there's not been much conversation done with OCS coordination. The fire department's kind of said similar. Is it ultimately going to OCS? Do we know?
We don't. I don't think that decision has been made. I think everybody agrees that the goal is to send Be Heard to more calls. I think that's well established. But how to do that is the city does not seem to have come. There was a proposal in the fall that it would come to health and hospitals and we would do it. That proposal is no longer part of the city's idea. but I don't think anybody has articulated yet what it's going to be.
Okay, because I know there was a report that's something that discussed the bottleneck, because NYPD answers the call, FDY handles EMS, but AH&H employs the social workers. And so that coordination can be difficult. It sounds like it's something that could be difficult.
I don't think anybody objects to us hiring and training the social workers.
No.
I think everybody's good with that part.
Yes.
But I think there is an issue that right now, many of these calls, the police prioritize them and go rapidly to them, and the fire department, because of shortages of paramedics, take longer to get there. And so then in general, you're not achieving the goal of getting the mental health professional in the lead.
Yes.
So the police are there first.
You probably can't answer this. I'm going to ask anyway. What do you think should happen?
I don't think the issue is the department. I think this could run in a variety of ways. I think the issue is the staffing, and that the current model of staffing is not sustainable. The current model is that 2 paramedics or EMTs go out with a social worker in a non-transporting ambulance, and then if the person needs transport, they have to send 2 more EMTs in a different ambulance. So on a crowded New York City street, you have 2 ambulances, 4 EMTs, 1 social worker, and meanwhile, we have an EMT paramedic shortage. So then the calls with medical illness don't get handled as quickly. Also, these calls take a long time. You don't de-escalate somebody by tossing them into the back of your ambulance and driving them to the hospital.
Yeah.
So I think that the model, whether it's by us, by the fire department, by the Office of Community Safety, has to come up with a staffing model that there are enough of them. Right now, there are not enough paramedics or EMTs to respond to the number of calls people want.
Okay, I'd like to offline talk about this a lot further.
Okay.
Just really quickly for corrections, H&H. We met with the Department of Corrections about Local Law 42, and we brought up a Board of Corrections memo in December that talked about prolonged placement. It was found in a contagious disease unit at West Facility in Rikers Island. It also showed that CHS repeatedly raised serious concerns regarding the deteriorating mental health of individuals on supervision and did not support continued placement. What can be done to support your efforts to avoid these instances and be in compliance with the board rules?
Thanks. Hi. The communicable disease unit is unique in the New York City system, in the national system, and it's negative pressure rooms for respiratory isolation. When Correctional Health Services puts a patient in the CDU, it is for medical isolation or quarantine to rule out or to get past a period of infectivity of a communicable disease. Those individuals, even when they are in medical isolation, when they have a diagnosis of a communicable disease, are not restricted in that setting. They can still go outside. They can have court. What they can't do is be with people physically without precautions. That is for a short period of time, just until they've passed the period of infectivity, or until we've got the lab results back that says they do or they don't have the disease. There's other people who are placed in that area because of the physical layout of the area by the Department of Correction for non-medical reasons. Those are not people who we put there.
Okay, we'll probably follow up offline on that as well. Thank you. Thank you so much, Commissioner.
Tell your wife I said hi.
I will. I have details, so I'll maybe be protected when I'm late, but we'll see how that goes.
Okay.
We've also been joined by Purina Sanchez on Zoom. Sorry, Purina. And continuation with Councilmember Brewer.
Thank you very much. So on the bicycles, it's nothing to decide today to know that the accidents and crashes are up and that we have to do something about it. It's not your problem per se, but since you are a bike rider, as we all are, your input would be helpful.
Very good.
There is a bill apparently that Councilmember Hudson has to limit speed, but they still go through the red light, so I don't know. Mental health. So my office is swamped with people who see people and are experiencing I guess, abuse from people who are mentally ill on the street. And so it's the same story, it's nothing new, but do you think the city has some remedies for this, or is it just the same, oh, we just have to deal with it? It does seem to be increasing, obviously to the credit of Jessica Tisch, the numbers are down in terms of violent acts, but mental illness seems to be up. I've seen it, I know, I got 10 calls today even, just, what do you suggest?
Okay, well, this is Mitch's doctor.
I know, I like Mitch as doctor.
So I believe that a lot of the people that you're getting calls about are heavily addicted. I believe that some portion is mental illness, but people with mental illness are generally not violent. They are generally the victims, they are not the perpetrators. There is the rare person whose psychosis says, the devil says, I need to hurt you. But that is by far the minority. The people with schizophrenia typically become withdrawn. They are not the people who are upsetting to people. I believe that the vast majority of people who are upsetting are using drugs. They are addicted to the drugs. They may also have a mental illness.
Right, I understand.
But it's the drug use that is affecting their behavior. And I personally, Mitch, the doctor, thinks that they need treatment and that there needs to be, I don't think sending them to Rikers is going to help them. I think that's going to make things worse. But I think leaving them on the street is also not helping them. And I think that that judges in our current system lack alternatives.
True.
So that it's either do you release the person who has just done this crime, but maybe it was not a horrible crime, do you send them to Rikers? I agree, don't send them to Rikers, they'll only learn worse behavior. But on the other hand, I also someone has multiple incidents of these kinds of crimes. They're cycling. Good things are not going to happen to them.
Correct.
Bad things are going to happen to them.
And to the people in the neighborhood.
And why can't we as a society say, this is the third time you have been arrested. The first time you were stealing potato chips. The second time you pushed somebody. Clearly drug use is hurting you and something bad is going to happen. And therefore, we are saying, you, as a judge, you got to go to this substance treatment program. And ideally, you go voluntarily, but if you don't go, you got to go. But that's how I view it. The law is not consistent with that. The law says, as you know well, that you can only be held against your will if you are in imminent danger of hurting yourself or someone else. And it doesn't address how addiction kills people's lives and all the people around them.
But do you feel there are enough programs, because my friends who are judges feel there aren't necessarily the right program for that person to be able to deal with his or her addiction? Do you think that there are enough places?
I think that if we could all agree that some people are not going to go voluntarily,
right,
but that there should be not a first strike, but like the third time you were brought before a judge that you have to go, that would be a positive step forward. And we do that with mental illness, so why can't we say on the third time you're arrested for some, again, not a huge, these kind of stealing things, pushing people, getting into a fight. Why can't we say, this is not turning out well for you? We as a society feel you're not following through on the societal contract, and you are going to this program. Will it work all the time? No, but at least we're trying, right? I think the frustration that you've expressed to me is the same as what my friends say is, well, but you can't even call the police because the police say there's nothing they can do about it.
Right.
My daughter rides the subway home from her supermarket job, and she all the time talks about how frightened she feels as a short Asian girl in the subway, and she feels intimidated, right? And I hate that.
Okay, this is a good offline discussion to continue. Thank you, Dr. Katz.
Thank you.
Thank you. Okay, we have council members Wong, Aldebal, and Ressler.
Thank you, Chair. I want to start by acknowledging something positive. The extended care unit that opened at Elmhurst in December 2024 is exactly the kind of investment this community needed. 20 beds, up to 120-day stays, and 50% patients connecting to permanent housing on discharge. That is a real result. My question is about sustainability. What is the annual operating cost of the Elmhurst ECU? And is it fully funded in FY27? And is there any plan to expand capacity beyond 20 beds? Can you answer that?
Yes, I think currently for the extended care units, we do operate those beds at a loss, right? Because we understand how valuable they are. And again, it's a loss measured by the stay, right? But there is a return, I think, on the person's care in terms of avoiding future admissions, right, and future costs, and that's why we operate the program at a loss, because we think there's a longer-term savings to be had. I can get you those specific numbers, right?
Please do.
Mine are across all the ECUs, but we can certainly provide you the
Thank you. Thank you. Thank you, Chair.
Okay, great. Councilmember Aldable, followed by Ressler.
Thank you, Dr. Katz. And thank you, chairs. So I have a question about Jacoby Hospitals. They're all the dedicated pediatric x-ray and fluoroscopy rooms. I practiced that all morning today.
Good job. I could never have done that.
At Jacoby are completely out of service. The primary pediatric x-ray room has been out of order for nearly 3 years. And the fluoroscopy unit is now completely offline. And that's, obviously leaving pediatric patients at both Jacoby and North Central Bronx with 0 dedicated pediatric radiology rooms. And this is, obviously a problem. We need pediatric-specific equipment to adhere to pediatric radiation safety protocols, especially for premature babies. And, our office and our Bronx delegation, we've been advocating for these capital fixes to be prioritized in the budget. However, the urgency and effect on patient care for these needs is very high. Do you have any insight into why this situation has been allowed to get so critical? And what plans are in place to prevent harm to patients in the short term? And what can be done to make these fixes for Jacoby Hospital a priority for H&H?
So just acknowledge that much of our equipment is past what people would say is the useful life. We are a system that prioritizes services, and sometimes the equipment doesn't make it to the top of the list because we're so busy trying to take care of everybody. Our overall capital needs are huge and would swamp the city's budget, right? We have 11 acute 4 skilled nursing facilities, many of them quite old buildings with leaking roofs and boilers that need to be fixed and chillers, and we try to do our best to figure out what is the next priority. Fluoroscopy, thankfully, is not as much of a tool as it was in my generation as a doctor, which I suspect may have been why it didn't get the same level of priority. But there are certain things you can only do with fluoroscopy. You can't do it with a CT scan. I mean, that mostly the CT scans have replaced fluoroscopy, which is good for diagnosis, which is a good thing because less radiation to the kid. But there are certain procedures that can only be done by fluoroscopy. My understanding is that they were transferring the kids right now till they got a new fluoroscopy. I don't know the equipment schedule. Do you know it, John? No. So I'll go back, I'll call Chris Mastermano. I feel he told me what the plan is, but I don't remember it at this moment.
Yeah, and
Thank you for raising it.
I can sit down with him and figure that out as
Yeah.
well. And I have a question about the violence interruption
Yes.
program. It's been phenomenal, successful program. I've had the opportunity to meet with, dedicated staff at the SUV program at Jacobi Hospital. Are there plans to expand these programs? Protect the funding for these programs? And is this program going to go under Office of Community Safety?
Guns down, life up, right? And we're going to continue to expand them. We've now both expand them at the hospitals, as in the case of Jacobi, but also we're now creating one at Bellevue, and there's another new one. Woodhall we did last year. I'm blocking on maybe South Brooklyn. I have not heard any intention to take them to a different office of community safety, but we would want to coordinate with. That's what they are, right? They're ways of preventing violence using peers and violence prevention specialists. So, I'm very supportive of working with other people, and that's their tradition anyway.
Mm-hmm. Thank you so much.
Thank you.
Okay, Councilmember Ressler.
Thank you so much to the chairs, and congratulations to Chair Lee for making it to your last hearing of an exceedingly long week. And President Katz, sorry? Last one for the week, not in general. Next week will be even more fun. And President Katz, always good to see you. Thank you for your exceptional public service. I think you're now the one person who's been appointed by 3 mayors in a row. Is that right?
That is correct.
That is a hat you wear unto yourself. So congratulations on that well-deserved reappointment. I have a variety of questions for you, but I'll do Patsy first for a moment. 2029 is the date that Commissioner Richards gave for when DOC anticipates Woodhull and NCB opening their facilities. Is that consistent with your timeline as well?
It currently still is 2029, but we are all looking at ways that we could push that up.
And we now fully have teams at DOC and DDC, and our partners are pushing ahead as quickly as possible.
Everyone is on the same page and pulling the same.
The wind's at our
speed and
back,
direction.
finally.
Yes.
Good. And if there are obstacles or barriers, you will be sure to let us know.
Yes.
Thank you. Okay. Thank you. Dr. Katz, so the health department testified earlier that their modeling has about 783,000 New Yorkers losing health insurance as a result of H.R. 1. It's mind-boggling to think about 1 of 11 New Yorkers losing their health care, but that's what we're imminently facing. And we know that those folks end up on your doorstep. Do you have a financial model of kind of uncompensated care that will now need to provide to these 750,000 New Yorkers who've just lost their health insurance?
Well, the only real financial model we have is that we can access disproportionate share hospital dollars,
right,
and which would provide about 50% of the cost of the uncompensated care. So, that will be, a major source. 50% is better than 0.
And the modeling I've seen is that we're anticipating a $2 billion increase in hospital uncompensated care. So you're saying that would be we'd get $1 billion in federal funding through DISH and be able to cover half, but looking at an additional $1 billion in expense is rough estimates at this point.
Right, big picture, you got it right.
Okay, thank you. And forgive my ignorance, but so when do you think that funding will need to be in H&H's budget?
Well, again, I do wonder how the mid-year elections will affect this, since that's when you'd start to get some of the biggest cuts. And I still remain hopeful that the worst-case scenario will not happen. And a lot depends also on how successful the city is in keeping people on insurance, right? There's certain people who you can't keep on insurance, right? Like the people in the essential care.
Between 200 and 250%.
Right. They're just going to lose.
They're done.
They're done.
But
the other people, potentially, if you consider that almost everybody could, either be working or be taking care of children or be in school or volunteer or be disabled, if you could imagine getting everybody through those hoops, you could have relatively few people falling off.
But the recertification process every 6 months is intended to create a bureaucratic nightmare that people will not be able to comply with. And so, you know, and to that I would love, do you mind if I keep going with a few more questions? Fast? Are you guys rushing? Quickly. All right, fast. I have a few more questions. So just on that and then a couple more things. Do you have any suggested models for how, I know we don't yet have rules or policies from the state on exactly what the certification process is going to look like, but any suggestions of things we should be doing now to plan for and invest to help ensure that we're recertifying people and providing that hand-holding?
We're already increasing the use of navigators. I mean, I think that's the key thing, is that you can't just assume that people are going to, you know, be able to fax things or scan things or send things to portals or even get the right documentation. But if we had enough people doing that work, that we could in fact do it. I think that New York City will need to invest in a large number of people to help people to enroll. I don't see any other way around.
And we'll need that over the course of this fiscal year.
Yes, although, I mean, the how well or badly we do in the food will tell you a lot about the health insurance.
Okay. Right. A couple other questions. Does H&H have an estimate of how much you'll be losing from federal state-directed payment cuts? And do you believe that those cuts could have an impact on the financial sustainability of the H&H Maimonides merger?
Well, the state, in a sense, the directed payment is the one place we've done better, right? Because we got the average commercial rate. And even when that caps, it's still so much better than anything that we had before. So, I mean, I think that were it not for the average commercial rate, we would be in a very different picture already. Okay. But it's the average commercial rate that's protecting us.
And do you all have an estimate of how large the financial impact will be from Medicaid and the essential plan coverage loss? Is there a model that you can share on that? And will the city need to contribute? I mean, this is what I was getting at before, but I'm just asking it again. Will the city need to contribute more to maintain services, or are we just waiting on the elections before we make that determination?
No, we have factored into our model in this budget, right, that there will be the loss and the impact of EP5, right? We've also factored in maybe 10 to 13% of our current patients who are on Medicaid may be disrupted, right, because of these barriers that were put in place. So we factored that into our model. And as Dr. Katz mentioned, the average commercial rate, which was part of HR1 and it was approved by CMS, and we have our third year, right, before CMS for approval. That's really our first line of defense because it throws off a lot of money, about $2 billion for us. And as people are being disenrolled from Medicaid, our plan, right, anticipates that they can then draw from the federal DISH dollars.
Okay, so last question before I get in trouble because I'm getting a dirty look. Any update on NYC Care enrollment? Have the federal attacks on immigrants suppressed enrollment? And do we anticipate, are we modeling increased enrollment because of the 750,000 New Yorkers that we think are going to lose their health care?
10,000 more than previous. Yes, we're assuming more people will come in. And I think anecdotally, all of us, including me, note that there are some people who were in the program who just don't seem to be around anymore. And we take that to mean that they've gotten scared of the climate and have returned to their country of origin.
Or are no longer coming in for care.
Or just no longer coming in
I think
for
that
care.
With the anticipated expansion, making sure that we have the primary and secondary care capacity in place, which costs money for you all, is going to be critically important because this is the only way that an increasing number of New Yorkers are going to have any access to care. Thank you for your work, and thank you, chairs, for your latitude. I greatly appreciate it.
Thank you. Coming back to correctional health care, does H&H receive any insurance reimbursement when providing care to incarcerated individuals?
No, we're federally precluded.
Okay. Yeah, you're being bad. So, in the executive plan, H&H has a total correctional health services budget of $344.7 million in fiscal 2026 and $329.8 million in fiscal 2027. What specific services are supported with the funding, and how is the funding divided between medical services and mental health services?
We don't budget by medical or mental health services. Many of our patients have needs on all sides. We provide care on an individual basis, and we're staffed for whoever needs whatever they need. Most of our funding is for, I think it's 95%, was 90-something percent, 95% is for patient care.
95.
And 84% of that is personnel.
How many incarcerated individuals receive services in 2026? Has the number of the people served increased or decreased in recent years? What are the most common mental health issues incarcerated people deal with?
Yeah, excuse me, the number of patients that we have on any given day has definitely increased steadily and dramatically since COVID, which is where we hit the lowest number. I think it just in the last year increased about 15% in terms of the number of people in custody, from 6,000 to about over 7,000. And the most common reasons why people in the mental health service come to us are really adjustment disorders. The most common diagnosis among serious mentally ill patients is schizophrenia or schizoaffective disorders.
How long is the wait time for incarcerated individuals to access mental health care services?
Yeah, we have at least two levels of priority. One is stat immediate, which is within 24 hours, and the other is priority, which is within 72 hours of any referral. We will see that patient and rely on to the Department of Correction to bring that patient to us or to connect us in some other way. On an ongoing follow-up basis for patients who are in our therapeutic housing areas, they're seen on a weekly basis.
Mm-hmm. We have been joined online with P. Sanchez, Purina Sanchez, since we have two Sanchez. Sorry, because she's been waiting. Okay, how much of correctional health services budget is allocated to families on Rikers Island? And how does spending differ across other correctional facilities?
I'm sorry, could you repeat the first part?
The first part is families, but we wouldn't take care of families, but your social workers do meet with family members.
Our social workers and all our staff will meet with family members regarding their loved one in jail under our care. And our budget is spread out over all facilities. We're always moving staff around to wherever we need.
Okay. So you cannot be specific because it's something that you
We don't buy jail.
Okay, gotcha. Does the current funding level is adequate support continuing for the care for the individual in reentry of our community?
Certainly for the reentry work that we do day one on admission to jail, and for what we provide on Rikers Island, and really appreciate the making us whole this time. Thank you.
Yeah, like you said, the funding is the same complexity.
Correct.
Okay. As the city plans for the transition to borough-based jails, how do you anticipate correctional health services funding needs will change in the future fiscal years?
Can't really predict
you cannot
that far ahead in years, but we will go wherever our patients are, and the prediction at that point in time, and a big focus on the part of the city under this administration is to see how people can be safely not in jail.
I'm in agreement. People should not be in jail, especially those that don't need to be in jail. And I think Dr. Katz has been talking about it, and I'm totally in agreement. I was hearing you when you were talking about it with my colleagues. The Bellevue Outpost Therapeutic Unit opened this past April. We spoke about it earlier. What updated information do you have to share on operation of the new unit since its opening?
It's going really well, thank you.
Going well?
April 8th, we brought our first group of patients in. The first group were the people who had mental health and medical issues. Again, we're over 90% at this point in time in occupancy, and people still are coming in. The staff are responding really well. The patients are really responding very, very well. It's made a big difference in all fronts.
That's a sidebar. Do you save money? I think you save more money by actually putting people where they're supposed to. That's in my
There are
head.
definitely, we think, savings because, for one thing, you don't have the transport costs for
Yeah.
people who need specialty care, right? It's very, they have to come on a bus, right? You need deputies to escort them. But I think, and I hope all members of the City Council will come and visit the outposted unit, because it really shows you that you can have correctional health done in a humane setting. Right, that having an inhumane setting is not needed. That is not the point of correctional settings. Is either ideally to rehab people, or to, if you're making a decision that this person at this moment has to be punished in this way. But that doesn't mean that they have to be in cages, right? And you can really see the difference in the outposted unit, and I think that difference has affected the behavior of the detainees as well as the staff.
Thank you. How many individuals are currently being housed in the unit, at the unit right now?
As of this moment, 95 people.
95. The budget for the unit is $7.7 million in fiscal 2026 and $8 million in fiscal 2027. Do you anticipate any funding increase for the unit?
So we have some funding, the discrete funding for Bellevue where we reimburse the hospital for services, basic services, some of the custodial, laundry, food, things like that we buy from Bellevue, as well as to reimburse Bellevue for the specialty services that they provide on unit to us.
Okay.
So that the hospital is not affected just badly. Thank you.
Okay. In medical malpractice, the executive plan includes additional baseline funding of $4.3 million starting in fiscal 2026, increasing to $5 million by fiscal 2030 for expenses associated with medical malpractice defense contracts. Is it correct that H&H contracts with 15 different law firms for medical malpractice defense?
Yes, so the budget just corrects to what the existing use has been, and the 20 million represents a major decrease from what it historically was before we started working so hard to handle these cases well. We actually work with 17 firms, and it's because medical malpractice is very specialized. So you need a different firm if it's an orthopedic injury versus a pediatric injury or in an obstetric case.
So what the total budget for FY 2026 and 2027?
2026 is 21.3 and 27 is 21.4. Essentially the same.
Okay. Does this funding only cover payment to law firms, or does it cover payouts and settlement?
Only to lawyers. It's law firms. It's not
Just
the
the law
payouts.
So there's other money for the payout.
That is correct.
Are the contracts with these law firms, RFPs, what is the timeline for a contract? How did H&H choose which firms to contract with?
So contracts are 5 to 6 years. We do bids, but we also pay attention to how responsive the law firm is to us, and often you can do a better settlement if you're very responsive as opposed to leaving it for a long period of time. And we also try to make sure that we have the right firms for the right kinds of cases because they're so different.
I'm assuming they are from our city?
Yes, they're 100%.
Okay. How do you evaluate the slow firms, and how often do you reassess? Well, I think you just led to that 600 bid.
Yeah.
You got that already. In finding savings, did you assess the medical malpractice contract to find efficiencies? You already.
Yes, well, the biggest efficiency is that we have our own lawyers, and so that's made a huge difference. And then we only have to gain, help when we need specialty help in an area that is unusual or requires a lot of expert witnesses.
Okay. How many medical malpractice suits were filed against H&H in 2025? How does the number compare to the past years? Which H&H location or service areas received the most medical malpractice complaint?
So the closeout cases is 450. Most of the med mal, as you would expect, come from the large hospitals. The highest number involved the emergency department. Lowest number come from the long-term care settings. And about half of the cases we settle before trial.
They settle before trial?
Yes.
Okay.
That's the goal, actually, because otherwise you just rack up lawyer fees, and it's not going to the person.
And many years. Which H&H? Okay, got that. Have you looked into the possibility of hiring in-house counsel instead of relying on outside firms for medical malpractice?
We mostly have it in-house. We only,
you have in-house?
Yeah. We only use contracts for the very specific kinds of cases that are, require that kind of expertise.
Okay.
And they're very good, the inside counsel.
Okay. Momani's, we started talking earlier about it. Momani's Health was set to merge with H&H on April 1st, but right now it's still not going through. Am I correct?
It will go through eventually, but yes, it's taken a lot longer than any of us had hoped.
Okay. So what step are you taking to push the merger through? Is there a new date set yet?
We have not set a date because it's all dependent on the going before the state's FIPIC committee, which is the Public Health Planning Committee. And we learned just yesterday that in order to go before that committee, there needs to be another kind of assessment, an equity assessment. So we're now working on the equity assessment, and when the equity assessment is over, then we will go to the committee, and we believe that the committee will support this because everybody recognizes that this is a critical hospital and there is no other choice. And there's no one else has offered to help. It's a 660-bed hospital with a trauma center, the only children's hospital in Brooklyn. The hospital needs to survive. We have always said throughout this process, somebody else can do it, we're fine with that. We did not get involved to take on more hospitals. We got involved to preserve a critical resource, and that's what we're doing. If somebody else has another idea and they can put together a proposal, that would be fine. But this has now gone on months, and while we have some opposition, there's no other proposal. I keep saying it's fine to oppose something, but you need to tell us what you're going to suggest instead. And so far, we haven't made any progress on that conversation.
And that's what I've been asking folks, what's the solution? Come up with a plan if you have a better plan, and I have not heard any. There's no money there. Is there a possibility that the term of the merger will change after the resolution of the process that we're going on now?
It's always possible, but the state has provided generous support once it goes through. We have $2.4 billion of state money to help save that hospital, but that money cannot flow to the hospital unless this is actually happening.
Okay. And it's a tic-tac moment now, because the more we're not doing it, the more money is being, we're losing now?
We could be giving them, through the upper payment limit, $9 million more per month for doing exactly the same thing they're doing now. But as long as there's opposition, the process will be slow.
I'm going to leave that alone. I had more questions, but since we got to go somewhere because I don't understand why all this. But anyway, maternal health services. There is a $3.5 million in H&H fiscal 2027 executive budget for maternal medical home services, including an additional of 513,000 baseline added to this plan for maternal morbidity and mortality reduction. What specific maternity-related program does the additional 513 funding support, and which H&H location is going to be operated out?
Right, so we're very excited about this funding and very appreciative. It will pay for 2 additional social workers and a fetal heart monitoring program, and also car seats and portable cribs for new mothers. So really valuable services.
And portable crib, that's good. That can help some parents. Which other maternal health-related programs are successful at H&H?
Well, in general, our overall numbers are better than the overall New York City numbers. So, we do well. OB is a very different issue than what I do, internal medicine, because with OB, each time you expect a healthy baby. Right. When you're taking care of people who are sick, you understand that sometimes things may not go well. But OB is meant to be a happy event. And so anytime either the mother or the baby is hurt, for us, it's very serious and very negative. On the other hand, it's always known that a certain number of outcomes will not be what we want it to be. Our job is to make it, as good as we possibly can. A lot of the morbidity, we've been teaching people hear maternal morbidity and mortality, and they think that means the woman is hurt or loses her life while delivering, when really it's in the year after, right? It's a very complicated dynamic that undoubtedly has to do with depression and stress and the difficulties of being a new mom. And in some cases, there's also mental health issues or substance use issues. It's a complicated, difficult time, and our job is to do as good a job supporting those moms and those families as we possibly can.
Thank you. Well, we added, we said a year after delivery is the most crucial moment that you should have support. So what kind of programs that H&H have to offer to help those process diminish?
So we do everything from, follow-up visits with social workers through mental health practice. We are also doing a lot of work on trying to arrange visits together with the mom and the baby, because we know mothers prioritize the health care of their babies but don't always prioritize their own health care. And so we're creating at all the hospitals joint visits to do a better job of bringing the women in.
Very nice. And how often they receive those visits?
As often as necessary. We are always, as a system, because it's come up in several of the questions, we never cap volume. Our view is that there are things we do, there might be things we don't do, but if we do them for everybody who needs it. If we provide mental health services, we'll see you as often as you need it. All services should be guided by clinical need, not by protocol.
Okay, so there's no cap
to
the visit? Okay. Have you identified a need to increase resources for maternal health and mental health programs at H&H?
Yeah, well, again, this new funding will really help us quite a lot. And it's going to enable us, we're going to have a new obstetric program that looks at the baby, at the fetal monitors and alerts us when there's an issue with the baby. And I think that's going to make a big difference for the actual deliveries.
I appreciate that. Headcount changes. The number of licensed private nurses at H&H has continued to decrease since the first quarter of fiscal 2025, from 3.53 to now 336 in the third quarter of fiscal 2026. I'm pleased, Doctor, to see H&H is working on reducing its reliance on private nurses. However, the number of physicians continued to decrease from 199 in Q4 of the fiscal 2025 to 178 in Q3 of fiscal 2026.
Right.
Have these 21 positions been moved to an affiliated payroll, or were they simply eliminated?
You have it right. They moved to an affiliate payroll. So the physicians were not eliminated. It's just a better way for them and us, for us to employ them.
Okay, so, and the registered nurse, let me go to that one. I said, the registered nurse headcount increased by 223 in Q3 of fiscal 2026 compared to Q4 of fiscal 2025. Which H&H locations are the newly hired nurses staff at?
So it's throughout the acute care hospitals.
Throughout.
Yes.
And is there any plan to increase the number of residents going forward?
Yes, we're actually increasing the number. We've opened up an additional psychiatry residency at Kings County. We're going to open a family practice residency at Metropolitan. And we're looking right now at growing some of the other residencies as well.
Very good, thank you. In Helmers Hospital, I'm interested in the ER, which we spoke about.
Yes.
The executive capital commitment plan includes $2.6 million for renovation of Elmhurst Adult Emergency Room. What is the status update of this renovation, and what is the completion timeline?
Do you have that, John? Oh, here it is. Okay. So completion timeline is March 2029, currently in procurement.
2029, thank you. Okay, you know we spoke about that too. In this renovation, using available street space around Elmhurst Hospital for any expansion of the emergency room?
Yes.
Whoa! Sorry, because I work in that ER and I know how bad it is. The nurses must be very happy, and I'm happy for them. I am so happy for them. All right, let me calm myself down. Executive plan include a baseline transfer of BHERD funding from H&H to FDNY of $2 million in fiscal 2026, increased to $6.7 million by fiscal 2029 for the creation of 10 additional BHERD teams by fiscal 2029. Where will this 10 new BHERD teams be located? Do you know by any chance?
I don't. There's a fire department question.
Okay, all right. But you don't know, even though you're not interested in it? Okay.
We train them.
Okay.
We don't get to decide the operational of them.
Okay, I love that. Respect that. What will the structure of BHERD teams be going forward? Would you know that? No.
No, I think the answer is unknown at this moment.
Unknown.
I think the city is genuinely interested in trying to figure out a way for BHERD to respond to more calls.
Okay. How are BHERD calls currently dispatched and triage? And can the department clarify whether calls are routed through the NYPD 911 system or FDNY EMS dispatch?
Right now, they're running through the FDNY dispatch.
FDNY, okay. What are the specific criteria that determine whether a call qualifies as BHERD response versus a traditional police or EMS response?
That's a fire department question.
I knew you were gonna say that. All right, so you don't know and you're not asking. I think I'm getting to be in a good place with you. Let me see. Dr. Katz, I think I run through all the things that was important to me, except asking my colleagues some of a question. And now I think I'm pretty much in good place with you.
Well,
But
we
let's
love
come back
being
to
here.
Elmer's.
We
Elmer's
love being
Hospital.
I'm
So we
excited
got
about
the, we got Baxter Street. What we got? The part of it to the extension.
Right, we're working on the extension. It's still in process. But
All right. Whatever
we-
you need, I think we'll be, and then
Well, and actually, we've always tried to put capital money in and push the
Yes.
speaker and everyone to put capital money in. for
capital money
Elmhurst.
to get it.
Yeah, thank
very
you.
excited.
We
Yeah.
really appreciate your help.
Yeah. They're from Queens. I'm from Brooklyn, but I work at Elmer's ER. So
I know you.
I have mine. So, Dr. Katz and the whole team, I want to say thank you for your time. Thank you for your leadership. And I'm looking forward for amazing thing in New York City. Despite what's going on, we know things going to change.
Yeah.
Things got to change.
Well, thank you.
So,
We're
thank you.
delighted to be here.
Thank you.
Thank you
Thank
so
you.
much. We love you guys. Okay, and with that, we are
That's
officially
right. We're
done.
going to say thank you to everyone and go, boop, boop. He said, gotta go. Yes, I gotta go. Thank you, everyone.
You did all the work. I'm just like a talking head.